Hello, my name is Peter Sato, and I'm going to be talking to you today about Hello, my name is Peter Sato, and I'm going to be talking to you today about the evolving role for the pathologist in thyroid cancer diagnostics. Kinase fusion-related thyroid carcinomas is a prototype for this, but we'll also talking about the non-invasive follicular thyroid neoplasm with papillary-like nuclear features. I would like to thank the organizers for inviting me today to share this information with you. And I also want to share that I currently have no relevant financial disclosures, although I have worked previously as a consultant for Bayer Pharmaceuticals in relation to their NTRK inhibitors, and have also previously worked as a diagnostic consultant for Veracyte. So given that we don't have too much time to talk about things today, I'm going to focus my discussion on the role of the pathologist in surgical pathology and the state of pathology, particularly thyroid pathology, in regard to an update in diagnosis and the gross approach to thyroid neoplasias. Talk to you about some of the changes that have taken place for our field in terms of the molecular era of thyroid carcinoma and what the TCGA has really done for us in terms of expectations of pathologists and what we have to contribute to thyroid cancer diagnostics. And talk about the architecture, morphology, and genetics. How are we able to put those things together to say, can we look at the architecture? Can we look at the morphology in order to be able to give us an example of what we're expecting diagnostically? Look for molecular evaluations for the diagnosis, molecular evaluations for prognosis, and molecular evaluation to choose rational therapeutics. So the pathologist in surgical pathology, what is the dream of every surgical pathologist? Well, for anatomic pathologists, it's surgical pathology as a role for translational medicine. Our microscopic evaluations under what we see at the microscope, how does this translate into what is seen at the bedside? How does basic science translate into foundational biology informed by our clinical principles, driving the next generation of care? Or a pathologist who notices, oh, for instance, maybe I see a lot of inflammation associated with this tumor. What could this mean prognostically for the patient? And what does it mean in terms of choosing therapeutic options for this patient, having an inflammation-associated tumor? Aspiring pathologists are applicants. You know, we see applicants from residents that say, you know, they like to puzzle solve. They like to talk about the pinks and blues that they see underneath the slide coming alive before them. But really, what does it tell us about the fundamentals of human biology? For academic surgical pathologists, we look for people who share our desire to improve patient care by doing what it is that we enjoy most, which is advancing our practice. So we're going to talk to you a little bit about the basics, the what of medical science, the diagnosis and the plan. So traditionally for us, it's an H&E, an ancillary test that tell you what the diagnosis is for the biopsy. But what if we actually talked about just doing ancillary tests only? So maybe pathologists become irrelevant and we can just do a blood test and look for molecular changes that are going to determine, hey, with these molecular changes, this particular patient is going to be treated with this particular drug. And we don't care if the patient has thyroid cancer, if the patient has liver cancer or colon cancer. All we care about is the following set of molecular changes. And how is it that we actually communicate with our clinical colleagues when a biopsy is non-diagnostic? Resections. What is the point of a resection, right? The primary point of the resection is to remove a particular cancer that's able to be removed. If we weren't able to completely excise the tumor, what is the next best possible scenario? So the resection is the relationship to the cure. Do we put in the appropriate sections in order to be able to make the diagnosis, make all of the comments about prognosis and any other relevant findings that may be helpful in terms of determining a care plan for the patient? do negative surgical margins still have a role in the age of molecular medicine? So, making sure that we get it all out. For sarcomas, making sure we get X number of centimeters around that sarcoma. Those are the types of questions that have become relevant now that we have such finely teased diagnostic markers. I put up a few historical photos from people that I've worked with previously, trying to understand how this works. So for instance, histologic and immunohistochemical decision-making for endometrial carcinoma. What are we going to do in terms of what are we looking for practically in order to make decisions about treatment of endometrial cancer? Cancer drug response and outcomes can predict cell mass changes. So we can see what happens when we actually take the tumor, make the diagnosis, understand the molecular findings, potentially do a liquid biopsy, treat the patient, and see tumor responses. So as a background in thyroid cancer, due to more intensified surveillance, thyroid cancer is being overdiagnosed. And I put that in quotes because what does it mean overdiagnosed? It means we find it more often, right? But overdiagnosed also is referring to the fact that we're not inappropriately diagnosing it or incorrectly diagnosing it, but we're seeing it more frequently because we find it more frequently. And what does that actually mean for patients, especially when what we call thyroid cancer may not actually be biologically aggressive disease that, if left alone, untouched in the patient, may never cause any type of clinical significant effect. So increased incidence is likely linked entirely to increased diagnosis of papillary thyroid carcinoma, which is the most common type of thyroid cancer and certainly the most common type of endocrine carcinoma. But if we think about this in terms of its relative importance to diagnostics in general, if we think about COVID-19, and I'm going to give you examples from the United States from the years 2020 to 2021, there were 49 million cases of COVID-19 diagnosed in the United States versus the neighborhood of about 50,000 thyroid cancer cases. And deaths from COVID-19 over that same period were 787,000. So quite a few number of deaths relative to the number of deaths of thyroid cancer. So we're really talking about very different disease types. And we're, as we focus on thyroid cancer today, sort of think about it as completely irrelevant when we have a worldwide pandemic going on. So as a background, in the early 2010s, we saw increases in diagnosis of papillary thyroid carcinomas, predominantly linked to increased diagnosis of the follicular variant of papillary thyroid carcinoma and increased diagnoses of papillary thyroid microcarcinomas. And particularly, when we talk about papillary thyroid microcarcinomas, we're talking about the really small ones that are incidental findings on patients that are having thyroid surgery for other reasons, either a larger nodule, Hashimoto thyroiditis, or even Graves' disease, and finding these incidental lesions versus lesions that were, somewhere in the neighborhood of 5 millimeters to a centimeter in size, which could legitimately be cancers that were noticed by ultrasound and possibly biopsied, even though recommendations from the American Thyroid Association are for biopsy nodules 1.0 centimeters or larger if it's a solitary nodule. Oftentimes, if patients come to their endocrinologist and receive an ultrasound and there's a nodule there, they end up getting biopsied even if they're smaller than 1 centimeter in size. The follicular variant of papillary thyroid carcinoma, we have typically referred to those in two different forms. One, the encapsulated follicular variant of papillary thyroid carcinoma, which is a well-circumscribed tumor, and the unencapsulated follicular variant of papillary thyroid carcinoma, which tends to be more infiltrative in its growth pattern. So this is the classic papillary thyroid carcinoma. Oftentimes they can be cystic, where we start seeing the nuclear features that everybody puts together with papillary thyroid carcinoma. So you have architectural pattern, which is the papillary fronds that grow that are leaf-like, and along with classical nuclear features of papillary thyroid carcinoma, which is the nuclear clearing, grooves, intranuclear pseudo-inclusions. Also talk about the presence of pseudomonas concentric ringed calcifications present that we see. And then when we think about follicular variant of papillary thyroid carcinoma that's well circumscribed, we can also talk about it being encapsulated. And when it's encapsulated, we can talk about whether or not it's actually invasive or not invasive. And these tumors, when we look at them at higher power, they have some features of classic papillary thyroid carcinoma that you can see: nuclear membrane irregularities, some clearing, grooves, and very rare but occasional intranuclear pseudoonclusions, pretty much absent psammoma bodies. We don't see fibrovascular cores because we don't actually see architectural papillae. So it's a little bit of a different animal. When we're dealing with the non-invasive follicular variant or encapsulated follicular variant, then the question is, in order to determine malignancy, is there capsular invasion? And people would get very caught up in thresholds, right? Thresholds for capsular invasion. So is this actually invading into the capsule? Is it invading through the capsule? What is my colleague going to call it? And people would be concerned. And I have to say, this is particularly pronounced in the United States, where people are concerned about a lawsuit. Am I going to get sued for this? And that ends up being the basis for deciding whether or not you're going to call something malignant, is what is someone else going to say if they see the same lesion. Now, this particular example, of course, there's no discussion about whether or not there's capsular invasion. We see true mushrooming invasion through the wall into the adjacent thyroid tissue, and this is not going to be up for debate or subjective diagnosis among colleagues. So traditionally for the non-invasive follicular variant of papillary thyroid carcinoma, the diagnosis had been based solely upon nuclear features to make the diagnosis, which is essentially also what cytology had been used for, was to make the diagnosis based upon nuclear features. There was no need for proving that there was capsular invasion. There was no need for proof of vascular invasion, and there was no need for evidence of architectural papillae that were needed to make the diagnosis of papillary thyroid carcinoma, despite the fact that papillae is part of the diagnosis, the term. So what are the cytological features? Nuclear clearing, nuclear membrane abnormalities, architectural papillae with fibrovascular cores, psammoma bodies, nuclear crowding, and sometimes a minor component of squamous metaplasia. So the cytological diagnosis of follicular variant of papillary thyroid carcinoma, typically without some of those architectural features, a lot of times the diagnosis would be atypia of undetermined significance or follicular neoplasm of undetermined significance, suspicious for follicular neoplasm, or suspicious for malignancy. Very rare in the case of a follicular variant papillary thyroid carcinoma would these lesions be called positive for malignancy, because they were missing key features. Again, the key features that would be missing would be psammoma bodies, intranuclear pseudoonclusions, and fibrovascular cores, which can still be seen cytologically. And of course, this would lead to an overdiagnosis of carcinoma. And again, this is not the equivalent of misdiagnosis, as I mentioned a little earlier, that these tumors subjectively or objectively could be called papillary thyroid carcinoma, but there's some doubt as to what the biological significance is of this diagnosis of papillary thyroid carcinoma. So more tumors being discovered due to increased screening, subjectivity in the diagnosis of follicular variant papillary thyroid carcinoma, which for pathologists, the concern is always, is somebody else going to call this cancer if I do not call it cancer? And so pathologists would be much more inclined to call this malignancy rather than calling it benign, taking the chance that if it would be sent, the patient would be sent to a different referral center, that someone would call it cancer, and that they would be told that they misdiagnosed something as benign when somebody else called it cancer. At least that's the feeling for many pathologists that were concerned to not make the diagnosis of papillary thyroid carcinoma. And this would historically lead to more surgeries for patients that maybe didn't require surgery because they're told they have cancer, or patients that had a hemithyroidectomy or a lobectomy, subsequently going for a completion thyroidectomy because they've been told they had or were subsequently diagnosed with cancer. And yet many of these cases never occurred post-operatively. So if tumors don't recur post-operatively, were they really cancers? I say cancers because the diagnosis is correct to begin with. And cancer referring to not the pathology term of carcinoma, but cancer meaning a lesion that is going to behave aggressively, a lesion that is actually biologically at risk for causing death in the patient. So the non-invasive papillary thyroid carcinoma follicular variant, the treatment historically had been the same as for a classic papillary thyroid carcinoma, which was completion thyroidectomy plus radioactive iodine treatment. And the American Thyroid Association came out with new guidelines. Okay, this was in 2016, that had new recommendations for surveillance of these tumors. And these new guidelines, which came out about 6 years ago, for patients that had tumors that were greater than 1 centimeter and less than 4 centimeters in size, and these are patients that have thyroid carcinomas diagnosed as malignant, without evidence of extrathyroidal extension and without clinical evidence for lymph node metastases, again, because you'd actually need to take out the lymph nodes to prove pathologic metastases. The initial surgical procedure can either be a bilateral procedure, meaning a near total or total thyroidectomy, or a unilateral procedure. So if the patient was comfortable and the clinician was comfortable, the patient could have a thyroid lobectomy, even with papillary thyroid carcinoma or even with follicular carcinoma, which would be sufficient initial treatment for a low-risk papillary or low-risk follicular thyroid carcinoma. And this, again, would mean the tumor is of reasonable size and no clinical evidence of lymph node disease. And what the definition is of extrathyroidal extension has actually changed even in the last couple of years, because we talk about extrathyroidal extension previously included microscopic extrathyroidal extension, which used to cause these patients to be diagnosed pathologically as a T stage of 3, even from microscopic extrathyroidal extension in a 2 millimeter microcarcinoma. But now, microscopic extrathyroidal extension is no longer considered in the staging of pathologic staging of thyroid carcinomas since 2017, and it's gross extrathyroidal extension, which is noted surgically by the surgeon to have tumor extending outside of the thyroid, or clinical evidence of adherence outside, or evidence of invasion into extrathyroidal strap muscles. For us to be able to call it extrathyroidal extension, which would be T3B. But during the time of these ATA guidelines, this is before the change in the qualification for extrathyroidal extension. So given the fact that these tumors often had very good outcomes clinically, a group of the Endocrine Pathology Society got together a working group in 2014 made up from 7 countries, 4 continents, 24 thyroid pathologists, 2 endocrinologists, 1 surgeon, 1 psychiatrist. Again, perhaps that was not actually even enough psychiatrists to participate. 1 thyroid cancer patient, 1 biostatistician, and 1 molecular pathologist. This group ended up examining 109 cases of patients with non-invasive disease, meeting all criteria of the group, with 10 to 26 years of follow-up following excision, and all patients were alive with no evidence of disease. And the conclusion from this study was that there needs to be a revision in the nomenclature of what we call encapsulated follicular variant of papillary thyroid carcinoma, given the fact that with at least 10 years of follow-up, these patients never recurred with disease. The main morphological features of the disease is that it was follicular growth and pattern, and the nuclear features of papillary thyroid carcinoma. Again, that goes in quotes, the nuclear features, because that's a very subjective thing. No evidence of invasion, distinguishing it from invasive encapsulated follicular variant of papillary thyroid carcinoma, which I'll also mention what that may indicate. And these tumors have clonal origin with a driver mutation, indicating that the lesion, of course, is indeed neoplastic. Very, very low risk of adverse outcome. And of course, the idea of having very low risk versus no risk of adverse outcome is what needs to be actually put in place when you're making a prospective diagnosis, because you can't really talk about an entity having no risk until the patient's actually dead and has never had any adverse outcome. So very low risk, meaning that until you set up criteria for a diagnosis, and then follow it over time, you can't actually prove there's no risk until you have appropriate follow-up from the advent of a diagnosis. So participants in these studies from the Endocrine Pathology Society had agreed set upon criteria for nuclear features, and this score ranged from 0 to 9, degree of nuclear features of papillary thyroid carcinoma. And if you allow yourself to sort of gaze upon the features, meaning score of 0 means 0 features of papillary thyroid carcinoma, where the nuclei are well-rounded, they are normochromatic, dark blue, without any indication of irregularities, no grooves, no pseudo-inclusions, no clearing, all of that stuff, through the most well-formed nuclei, which is score of 9. And if you actually, just on this page from 5 to 9, and allow your eyes to toggle back and forth between 5 and 6, 7 and 8, 9 and 5, you'll see that it's really almost impossible to make this judgment. So if you every time you're looking at a case of papillary thyroid carcinoma, you're not looking at it in relationship to this made-up scale of degrees of well-developed nuclear features to be able to say, is mine a 5, a 6, a 3, or a 1? It's really quite impossible to put them in these particular categories, even though these were set up, based on some people getting together and saying, okay, these are the numbers. And so what that does set up for is this new wastebasket diagnosis, and the nuclear scoring system was set up for consistency. But the point being is that, for nuclear features, you either have them or you don't have them. So essentially, if you are, in this particular case, if you look at score 0 and score 1, it's really almost impossible to tell the difference. But the situation is, are there some nuclear features present or not? Yes or no, 0 or 1. And that would allow you to sort of put it in this area. So nuclear scoring system was set up for consistency, and the results concluded that a range of nuclear scores would deem a lesion benign or NIFT-P versus minimally invasive encapsulated follicular variant of papillary thyroid carcinoma. And you can think about it that NIFT-P is a follicular adenoma with nuclear irregularities. So it's not validated broadly, so that currently still designated as low biological potential versus no biological potential, but very, very few outcome studies have been published. So NIFT-P requires no additional surgery. The original idea was that this would drive more lobectomies, but this is actually unclear now that the American Thyroid Association has changed its guidelines to include more of an active surveillance picture with low-risk cancers that are well-differentiated thyroid carcinomas. And the new Bethesda system was released in October of 2017, now 5 years ago. They're working on the most recent, the next edition that's coming out that had no changes. So what does it actually mean with no changes for the Bethesda criteria, including NIFT-P? It means that the risk of malignancy now, the percentage of malignancy, would now be left shifted, whereas less tumors would be considered to be malignant when you start making fewer diagnoses of encapsulated follicular variant, although the classifications of atypia would remain the same. But fewer of them would actually be in the positive for malignancy once they actually come out. So because of the fact that NIFT-P exists, the risk of people saying something is suspicious or positive for malignancy would move more towards the left, and you'd start seeing more tumors being put in the atypical categories or suspicious for follicular neoplasm category. But the submission guidelines or the criteria would stay the same. Then we talk about the original tissue submission guidelines, which are similar for solitary nodules. An invasion would remove from the NIFT-P category, and it becomes invasive encapsulated follicular variant of papillary thyroid carcinoma. And the classification, of course, of these tumors is molecular driven. So encapsulated follicular variant of papillary thyroid carcinoma have RAS-like mutations, which means that when these tumors are behaving poorly, they don't metastasize to lymph nodes, but metastasize broadly to lung, bone, brain. And the infiltrative follicular variant of papillary thyroid carcinoma, those that you don't see well circumscribed lesion, but you actually see broad infiltration without a capsule into the surrounding thyroid, those actually tend to be more likely to have BRAF V600E mutations. And we're going to talk about this again when we start talking about some of the fusions. And this was all derived from the Cancer Genome Atlas, which showed tumors to have, which was published in Cell in 2014, and showed tumors, papillary thyroid carcinomas, to really have two patterns of behavior, those that were RAS-like and those that were BRAF-like. So NIFT-P and the encapsulated follicular variant of papillary thyroid carcinoma is the malignant evolution of NIFT-P, which really is akin to the minimally or widely invasive follicular thyroid carcinoma, but this includes papillary-like nuclear features. So we start thinking about follicular adenomas, and when they become malignant, become follicular thyroid carcinomas, which can either be minimally invasive or widely invasive. And NIFT-P is basically a follicular adenoma with nuclear membrane irregularities that can then become the invasive follicular variant of papillary thyroid carcinoma by invading through the capsule or invading into blood vessels. And it is very reductionist, but these are also thought to have RAS-like mutations, same as follicular carcinomas, but again, have variable nuclear membrane abnormalities. NIFT-P does not require a capsule, so it just is a lesion that's well circumscribed. It has papillary-like nuclear features. And how does one assess the capsule if there is no capsule? And so we sort of replace capsule with tumor to normal parenchymal interface. And how do you actually adequately sample this? Well, the same way you would sample the capsule if you're assessing a solitary lesion for capsular invasion in the adenoma versus follicular thyroid carcinoma. And of course, it's advised that the entire capsule be submitted. And we start talking about architecture and papillae being present that actually can exclude NIFT-P. And how do you look at the papillae if you're not looking at the entirety of the lesion? And that's somewhat of an issue. But when we're talking about tumor capsule, although the current trend is for the entire capsule to be submitted without respect to tumor size, this is really subject to your practices wherever you work. Like, for instance, European colleagues actually are much more cost effective than the US colleagues, where we submit the entire thing regardless in the US, and Europeans like that, we're not doing that. It's ridiculous, especially if it's a 10-centimeter mass. We're going to do representative sections. And we actually at Mass General Hospital published a study where we looked at this retrospective study from 25 years, looking at the submission practices, which evolved from doing representative capsular submission to doing the entirety of the capsule submission, where this change took place in 2010, where we went to full capsule submission. Prior to that was representative capsule submission. And really what we saw was there was literally no difference. The tumors that actually potentially had metastatic potential, and this is follicular thyroid carcinomas, were those tumors that were widely invasive. And the majority of widely invasive carcinomas did not go on to metastasize either. But if tumors went on to metastasize, those that did go on to metastasize were the ones that were widely invasive. And that the risk of metastasis from a minimally invasive follicular carcinoma was essentially the same as the risk of metastasis from an adenoma that was submitted with the entire capsule alone. So there was no difference between minimally invasive follicular adenomas, minimally invasive follicular carcinomas from adenoma. So that even though pathologists, we get very, very caught up on minimal invasion, and is this invasive versus not invasive, it doesn't really seem to matter unless the tumor is widely invasive. And oftentimes these widely invasive tumors, we know that when we actually see the growths. We don't need to look at it under the microscope to know it's widely invasive. So one other comment that I was alluding to just a couple of minutes ago is that one of the exclusion criteria for NIFT-P is also no architectural papillae, that if they're present, this would be considered to be classical papillary thyroid carcinoma with predominantly follicular architecture. So this simple tumor to parenchymal capsuling would not be adequate because you wouldn't be looking at the entire tumor parenchyma to exclude the presence of papillae. And this is essentially ridiculous, especially why would we be looking at these tumors any more in depth, especially if it's a large tumor, than we would be looking at an adenoma capsule. It's just not really possible or feasible. So within NIFT-P, if the entire tumor is not submitted, how do we ensure ourselves that we're not missing classic papillary thyroid carcinomas with predominantly follicular architecture. And we've been using BRAF-VE as a surrogate for looking at this thing. So now BRAF-VE is a monoclonal antibody, which is concordant with the BRAF V600E mutation. BRAF V600E mutation in thyroid is synonymous with papillary thyroid carcinoma. There is no such thing as BRAF V600E mutation in the thyroid that's not papillary thyroid carcinoma. And so sub-centimeter microcarcinomas, they may have BRAF V600E again, but even if they don't do anything, but if well assessed, BRAF negative, HbME1 positive tumors would be considered to be enough to be NIFP. So for instance, looking at HbME1, which essentially HbME1 is positive in tumors that have nuclear membrane anomalies, again, whether it's benign or malignant, but used to be a marker for papillary thyroid carcinoma, now it's a marker for nuclear membrane irregularities, and BRAF V600E stain, BRAF VE stain, is a very, very helpful adjuvant to say whether or not this tumor with a predominantly follicular pattern is actually papillary thyroid carcinoma. So it's a very, very good surrogate marker for papillary thyroid carcinoma. So NIFP debuted just about, about this point in time, 6 years ago, with several manuscripts in print since its debut, 340, as of earlier this year. Instructor reviews for pathologists have been published. The incidence of papillary thyroid carcinoma should decrease with the advent of NIFP, but we talk about whether or not there's implications for surgery or the diagnosis of papillary thyroid carcinoma, but with the guidelines from the American Thyroid Association essentially saying that you can undergo active surveillance for low-risk papillary thyroid carcinomas, it's unclear whether or not the diagnosis of NIFP actually will reduce surgeries just as well as doing active surveillance in well-differentiated thyroid carcinoma. So some implications: the reduced diagnosis of follicular variant of papillary thyroid carcinoma, possibly reduced overtreatment of indolent thyroid tumors, and also, importantly for our field, reduced need for consultation due to increased reproducibility of morphological features. So you don't have to have your personal threshold for nuclear membrane irregularities, that if you're nervous about a lesion but it's well circumscribed, non-invasive, then you'd be able to use the diagnosis of NIFP without worrying about whether or not the lesion is papillary thyroid carcinoma. And again, the Bethesda criteria haven't been changed. So atypia of undetermined significance, or follicular lesion of undetermined significance would drive molecular testing. This is preoperatively and would be able to give you this RAS-like or BRAF-like mutation to be able to decide what you're going to do in terms of treatment of these patients. So how do we incorporate molecular features into the diagnosis? Are there molecular histopathologic correlates? And when do we do postoperative molecular testing, and does it matter? And this is the meat of the discussion that I wanted to bring to you as we finish up, is that we've started talking about papillary thyroid carcinomas with high-grade features, poorly differentiated thyroid carcinoma, anaplastic thyroid cancers. Where do we draw these lines? What is the mutational profile on these tumors? And the reason why we care is because for two reasons. One, we want to talk about prognosis for patients, right? That's typically what we've been able to do as pathologists. But now we're actually able to incorporate more than just prognosis. Oh, this tumor is really bad. We actually can recommend effective therapeutic options for patients based on their mutational profiles. So we're in the era of a dawn of actionable mutations. Our group, we published a study looking at clinical, pathologic, and molecular characterization of NTRK rearranged thyroid carcinoma, where we're actually able to look at the morphology of these tumors. And if you can see this nodular growth pattern of these thyroid tumors that are sort of somewhat indiscrete. And if you look at the top right of the screen, you'll see that this has this glomeruloid pattern of growth. The top left shows this micropapillary pattern of growth, and then you can see this more solid nodular pattern of growth, and again, a little bit more of that glomeruloid pattern of growth in the bottom right. And when you see that pattern of growth, you can say to yourself, maybe this tumor actually has a translocation associated with it. In this particular case, NTRK1. And here's another NTRK3 where you can also see this kind of nodular pattern of growth, looks more solid in its growth pattern, but kind of odd. The nuclei, if you look at them more closely, they don't really have standard papillary thyroid carcinoma-like nuclei. They are somewhat irregular. Maybe they're a little bit raisinoid or somewhat, oddly angled in their pattern, but they don't have classic intranuclear pseudoinclusions. The pattern's a little bit funny. They have it. So this is what these tumors look like, and then you can actually make it more broad to expand beyond NTRK and start looking at other fusions. Now, CCDC6 RET fusion previously was known as RET PTC. This is seen in diffuse sclerosing variant of papillary thyroid carcinoma. You remember that has those prominent micro somomatous calcifications that are peppered along the entire thyroid, often associated with Hashimoto thyroiditis, often associated with squamous metaplasia within the thyroid, may be associated with prior exposure to radiation therapy, often seen in young women. So we see these lesions there, and we can predict that they have these mutations, and these mutations respond beautifully to drugs. And so we actually are able to predict, based on the morphology, that these patients are going to respond to therapeutics. And they actually have a very minimal side effect profile, which may be some diarrhea. So we've been able to develop algorithms for testing in these lesions that can say, okay, if we see this growth pattern, the next thing we're going to do is we're going to do an immunohistochemical marker for BRAF mutation. And if it's negative for BRAF mutation, because we don't find these fusions associated with BRAF mutation, so if it's negative for BRAF mutation, then we can go ahead with whatever modalities that we have available to us to test them for fusions, particularly in NTRK or RET, but also in ALK, which is also druggable. Patients that, especially in patients, what setting, we have to talk about what setting these might be in. And these are patients that have advanced thyroid cancer, so they're not surgically resectable. They may be presenting with bilateral disease, or they have lung mets at the time of diagnosis. They have liver metastases at the time of diagnosis, and these patients respond beautifully to drugs, despite the fact that they may have advanced disease. So we're able to come up with our own way of being able to do it. And there's a number of papers showing how these targeted therapeutics are extremely helpful. And these same mutations, which can be seen in other disease sites in the head and neck, for instance, where we see them in salivary tumors, in other types of molecular targets, for instance, inflammatory changes that may be seen in head and neck tumors that are responsible to therapeutics, inflammatory therapeutics. We're seeing this really, really helpful findings of these translocations that are able to be treated, or doing immunotherapy for patients that have these diseases. So we have really changed how we're viewing these tumors in terms of how we're able to treat them. How are we going to look at these things going forward? COVID's changed a lot about our practice. For our department, what we've been able to do is, given the fact that at the beginning of COVID, we weren't even able to meet in person, we ended up having virtual tumor boards where we would meet with our own consensus group with MGH, and then actually expanded it to all of our alumni who are spread all over the US, showing difficult cases. And we're able to look at these cases and talk about our practice and how we're able to do it. And it's led to very broad collaborations about how we're able to look at these cases, which has unlocked new methods for diagnosis. What are you doing at your institution? How are you practicing? What modalities are able to be available to you? And by working together in consensus, we're able to say, what are best practices? How are your clinicians taking this information from you and applying it to their practice? And I think this has been really, really helpful for us, and things that we need to think about as practicing pathologists. So what is the role for the pathologist in surgical pathology, which is far greater than just making a diagnosis? What is the role of the pathologist in directing the science of tumor biology? And how are we going to evaluate follicular pattern thyroid cancers, which is evolving with molecular genetics and known clinical behaviors in these tumors? So NIFP is new and continues to evolve. The role of genetics in accounting for the gross exam, how are we going to do it based on what we know about molecular diagnostics? The role in thyroid cancer, salivary tumors, and immunomodulatory therapies. And as we've moved forward in a molecular era closer toward integrated diagnostics, we must have more rational diagnostics. We have to integrate prognostic information, clinical next steps for therapeutics, and move our our pathology consultative practice to the next level. So I thank you so much for your attention, and I hope you're enjoying these lectures. Thank you for allowing me to participate. And we'll stop and allow you to move to the next lecturer.
Yes, Meeta. I am unmuted. Hello?
Yes, ma'am.
Yeah, I can hear you.
Display उनकी slide.
Yes. Should I start with his CV?
Yes, ma'am. Please introduce the speaker, Dr. Amitabh.
Yeah. Okay, so good morning, everyone. We have had a very nice talk by Dr. Peter Sado, and now we move on to our next talk. That is by Dr. Amitabh Srivastava. He's a consultant pathologist. We all know him very well. He is coming to frequently to India and conducting various courses. He is expert in GI pathology, endocrine pathology. He has several achievements and awards to his credit, like international publications, about 608. He is honored Mentors Award, CAP Foundation in 2019, Jack Yardley Investigator Award, Roger C. Haggett Award of Pathology Society in 2016. Can you move the slide further? Or so these are his achievements, and I would like to say that he is well known to all the pathologists here, frequently conducting, and he had been a old student of SGPGI. He belongs to SGPGI. He was passed out from here. So I welcome Dr. Amitabh, and I request him to start his presentation. Welcome, Dr. Amitabh.
Good morning, everyone. In the next 20-30 minutes or so, I'm going to give you a quick tour of the neuroendocrine tumors of the GI tract and talk a little bit about the so-called MNINs, or mixed neuroendocrine, non-neuroendocrine tumors. If you exclude the stomach, the commonest sites of neuroendocrine tumors are the small intestine and the rectum. What has also become clear in the past couple of decades that the incidence of neuroendocrine tumors has been rising consistently, pretty dramatically, whereas all other cancers are either flat or declining. And the good news is that most of it seems to be occurring in either the lung or the small intestine and rectum, but it is mostly localized disease, the brown line here, and grade 1 tumors. So with more and more imaging and colonoscopies, it's not surprising that we are seeing localized indolent neuroendocrine tumors more and more. This is just a review to emphasize to you that in the early days of recognition of the entity, it took a decade or two before something changed our understanding, or a biomarker, diagnostic or prognostic. And you can see in the last decade or so, the pace of our understanding of these tumors has increased. It's reflected in the classifications that we use and the biomarkers that we use in daily practice, at least here in the West. So let's review the problems with the old classification of neuroendocrine tumors. We call tumors carcinoid, malignant carcinoid, and small cell carcinoma, and you could argue that basically G1, G2, G3 is a rehash of the same thing. But essentially, there's a few key points to remember. When we call something a carcinoid, the oncologists often mistake it for a serotonin-secreting neuroendocrine tumor, and they may order 5-HIAA or breakdown products and think of the carcinoid syndrome, and which, as you know, only the ileal carcinoids in the GI tract secrete serotonin to any significant degree. All the other sites basically are non-serotonin secreting neuroendocrine tumors. And then not all disseminated neuroendocrine tumors present with carcinoid syndrome. Dr. Singhi spoke about the pancreatic neuroendocrine tumors yesterday. If they go to the liver, you don't really have a carcinoid syndrome. So the thought was that we should move away from something that creates confusion with serotonin secreting tumors and have a non-committal, well-differentiated neuroendocrine tumor as the nomenclature. Malignant carcinoid, well, it's kind of an oxymoron in the sense that it is carcinoid is a carcinoma. It just has a low-grade or indolent outcome, and they infiltrate and into the muscularis propria and do all the things that malignant tumors do. And if you look at overall 10-year survival, it's only about 60%. So there are tumors that are worrisome and associated with significant patient morbidity and mortality. And malignancy was always difficult to define in these tumors. And then finally, small cell carcinomas. We now know not all are small cell type. We can have large cells as part of the spectrum, and we now know that these must be distinguished from grade 3 well-differentiated neuroendocrine tumors. So this is how things stand. I'm not going to spend too much time on this because it was covered yesterday by Dr. Singhi talking about the pancreatic neuroendocrine tumors. Basically, you have 3 grades of well-differentiated and then 2 types of poorly differentiated. The poorly differentiated one are, by definition, high proliferative index, and then you have this rare subset of mixed tumors, which we'll come to towards the end. So let's talk a little bit about differentiation and grade because it creates a lot of confusion in how we sign out things sometimes in clinical practice. These are related concepts but independent in the sense that nearly all well-differentiated tumors will be either grade 1 or 2, and all poorly differentiated ones are going to be grade 3. But differentiation is not related to the proliferation or Ki67 proliferative index or the mitotic count. It's related to tumor architecture, and I'll show that in a minute. And whereas grade is related to, as I said, the proliferative activity of the tumor. So the reports that we issue in daily practice should include both differentiation and grade because of the difference in outcomes between well-differentiated neuroendocrine tumors that are grade 3 and poorly differentiated neuroendocrine carcinoma. So we should avoid this high-grade neuroendocrine carcinoma diagnosis unless it's a very small biopsy and you really cannot distinguish the tumor architecture in that biopsy. So what do we mean when we say well-differentiated neuroendocrine tumor? We mean that the tumor has an organoid architecture, so tumor that's present in nests, in acini or pseudoglandular pattern that can be mistaken for an adenocarcinoma, trabeculae or festoons. So if you see any of these organoid patterns, then it's a well-differentiated neuroendocrine tumor. In contrast, the poorly differentiated neuroendocrine tumors lack an organoid architecture. The tumor is present in sheets, often associated with high mitotic and apoptotic counts, and also associated with tumor cell necrosis. And the cytologic features could be small or large cell type, and often you may see both in high-grade tumors. So this is what we mean by small versus large cell. Small cell carcinoma in the GI tract resembles its counterpart in the lung. The chromatin is fine, almost smudgy. You see nuclear molding. There's not much cytoplasm. Whereas the large cell neuroendocrine carcinoma nuclei are often ovoid and large with an opened up chromatin with prominent nucleoli. So it's not uncommon if you have a resection to see a mixture of both small and large cell types in the same tumor. The only thing I would emphasize again in the diagnosis of poorly differentiated neuroendocrine carcinoma is that you should stick to the well-established neuroendocrine markers, chromogranin, synaptophysin, and INSM1. And do not use CD56 alone as a tool for diagnosing neuroendocrine carcinoma because it's just very non-specific, and there's a lot of tumors that can be positive for CD56. And the two tumors are also different at a molecular level. Again, this was very nicely covered. Much of this work has been actually done by Dr. Singhi. So the well-diff neuroendocrine tumors have mutations in MEN1, DAX, and ATRX, whereas the poorly differentiated neuroendocrine carcinomas have mutations in MYC, retinoblastoma gene, and TP53. So if you have a small biopsy and you're struggling, doing RB and TP53 immunostains can sometimes help. I just want to emphasize there are some neuroendocrine tumors that are more prone to being diagnosed as adenocarcinoma because they have this glandular or pseudoglandular type of architecture, and basically they are tumor acini that mimic an adenocarcinoma. And in the rectum, there is this unique peculiar entity, which is very rare, which is known in literature as signet-ring cell carcinoid. So let's run through the GI tract quickly. In the stomach, the three main settings in which you get neuroendocrine tumors are autoimmune gastritis, syndromic tumors in MEN, and you can rarely see them in a sporadic setting, and these are the tumors that are most aggressive. You can rarely also see neuroendocrine carcinomas, and there is an entity that occurs in patients who have been on PPI for a very, very long time, and these are often multifocal and have a poor outcome. Sometimes on low power, you may just think of it as a gastritis because it's quite dispersed in the setting of autoimmune gastritis, the neuroendocrine proliferation. So you may think that these are plasma cells, but this is epithelial proliferation of neuroendocrine cells that you can highlight by chromogranin and synaptophysin. The only other thing in a biopsy specimen, if you have a core biopsy of a gastric submucosal mass, sometimes the carcinoid tumors can undergo a little dyscohesion like shown here and have a myxoid stroma, so you may start thinking of a GIST or a mesenchymal tumor. Another thing to remember in the stomach is that glomus tumors can be focally positive for synaptophysin, so you don't want to misdiagnose glomus tumors as a neuroendocrine tumor. In the duodenum, you can get non-functional nets, gastrinomas, somatostatinomas, which, since they are ampullary, they may cause pancreatic duct dilatation, and they are associated with pseudomatous calcifications, actually something described by Dr. Yogesh Dayal at Tufts, who many of you probably know. We are not going to talk about gangliocytic paragangliomas, and then neuroendocrine carcinomas are similar to other sites, and then you can get tumors in the duodenum or ampullary region in a syndromic setting, including the very rare polycythemia paraganglioma somatostatinoma syndrome. So this is what I was pointing out, that you should be careful in the ampullary region. If you see something like this infiltrating to the muscle, and don't mistake it for an adenocarcinoma. Often in half of these tumors, you'll see calcifications or pseudomoma bodies, which are helpful. They're not really specific for somatostatinomas. You can see them in any neuroendocrine tumors. I've seen them in ileal carcinoids. But essentially, the point is that this SNR architecture or pseudoglandular architecture can be mistaken for an adenocarcinoma, and you need to do the neuroendocrine markers to make the right diagnosis. Rectal carcinoids are increasing in incidence. Most are small, grade 1 lesions, as I said at the start of the talk. They can be sometimes large, and about 10 to 20% will metastasize. Peculiarly enough, these are negative for chromogranin A and positive for synaptophysin. They secrete chromogranin B, so if you have antibodies for chromogranin B, you can highlight them, but it's usually not necessary. And then, as I said, the signet-ring cell variant is likely due to, we don't know too much because it's so rare, but it's likely a degenerative type change in large rectal carcinoids, and I'll show you an example. So this is the typical rectal carcinoid morphology with the trabeculae and festoons, which is a well-differentiated neuroendocrine tumor. This is pretty typical for rectal tumors. And this is what I meant by this sort of signet ring or pseudo-signet ring cell. If you imagine getting a biopsy for a tumor like this, you may misdiagnose them as signet-ring cell carcinomas because they look like adenocarcinomas rather than neuroendocrine tumors. But if you're lucky and you think about the entity, you can stain them with synaptophysin and show they are diffusely positive. If you have a resection specimen, if you sample it enough, you can see the more organoid, well-differentiated architecture, and then cells kind of falling apart on the left that imparts a pseudo-signet-ring cell appearance to these tumors. So let's talk a little bit about Minen's. Arthur said yesterday that he doesn't like the nomenclature, and I don't either. It makes it sound as if there are two different tumors happening in the same organ. Essentially, instead of saying carcinoma with divergent differentiation and mentioning the components, we are stuck with this Minin nomenclature. Sometimes in a biopsy, we will still sign things out as the old manic nomenclature, mixed adenocarcinoma, neuroendocrine carcinoma, depending on the components. By definition, you need 30% of each type, which in a biopsy is virtually impossible. So you want to, if you see two components, you want to report them in your biopsy so that the oncologist can decide based on the clinical presentation at diagnosis whether they want to treat. So if, for example, if it's in the esophagus, most patients may still get neoadjuvant chemotherapy, and they may modify the chemotherapy protocol to include the polydifferentiated neuroendocrine carcinoma component. A few caveats: you should not confuse entrapped normal structures with Minins. I'll show you an example. Many of you may remember at some point there was an entity described of ductiloid cellular tumor of the pancreas, which essentially turned out to be neuroendocrine tumors with entrapped ductules, not a specific entity. And then the other important point is that don't stain your conventional adenocarcinomas, because you may end up with focal or multifocal positivity for chromogranin and synaptophysin, and then you'll be stuck trying to interpret them. And these should be diagnosed as adenocarcinoma, not Minins. Also excluded from this group are amphicrine carcinomas. We don't talk about them anymore, but all of us who work in the field know that they exist. And these can be either gland-forming or signature cell tumors in the stomach. And if you do your neuroendocrine markers, they're diffusely positive, but we don't really know what to do with them, and are essentially signed out as adenocarcinomas with neuroendocrine differentiation. And then we'll talk a little bit about the change in nomenclature of the appendiceal goblet cell carcinomas, because we had something to do with the change. So the first point is, don't mistake entrapped structures for mixed tumors. So here you have an adenocarcinoma that's wrapping around an islet, which is benign, not part of the tumor, so don't mistake it for a mixed adenoneuroendocrine tumor. There is a converse morphology here with a well-differentiated neuroendocrine tumors that's entrapping reactive ductules, which you should not mistake for a mixed tumor. As I said, don't stain if something looks like a conventional adenocarcinoma with mucin and goblet cells. Don't stain them with neuroendocrine markers, because you may end up seeing something like this, where you may have to interpret them as either an adenocarcinoma with focal differentiation or diffuse neuroendocrine differentiation or a mixed tumor, and you can avoid that by just not doing the stain if it's a conventional adenocarcinoma. As I said, the amphicrine carcinomas in the stomach can be gland-forming or poorly differentiated. So here's an example of diffuse type gastric cancer with really striking neuroendocrine marker positivity for synaptophysin here. And those of you who are interested, there's a very recent paper a couple of months ago in Modern Pathology where very unique genetic findings have been described in these gastric amphicrine carcinomas, which you should read. Here is an example of an amphicrine carcinoma with gland formation. So you can see we are still in the stomach. We have this nest and gland formations that are positive for mucin, also positive for neuroendocrine markers. So these are basically divergent differentiation occurring within the same cells. And just like in the pancreas, where you can have a mixed acinar endocrine tumor, where you find evidence of both lines of differentiation in the same tumor cell. And you can see that it's a high-grade tumor with a very high Ki-67. So these are not considered in the Minin category currently in the WHO classification. Let's talk quickly about appendix. As I said, appendix can be a site of tubular carcinoids, which can be mistaken for adenocarcinoma. So just remember, if something looks bland, infiltrative in the appendix without a precursor adenoma, think about a neuroendocrine tumor and stain them with chromosynapto. Typically, you have this nested midgut pattern in the appendix, which is not hard to recognize. Sometimes you can see lipidized or clear cell change, which again can be mistaken for an adenocarcinoma, because you could mistake this for mucin. And there's some suggestion that these tumors may have an association with the clear cell types, may have an association with VHL. I'll talk a little bit about this entity of goblet cell carcinoids, which the Europeans used to call goblet cell carcinoma. In the old version, there were two types: a goblet cell carcinoid, where the tumor was composed of normal appearing colonic crypts, and then the entity of adenocarcinoma ex goblet cell carcinoid, when the tumor started making signet ring cells or appeared poorly differentiated. And actually, one of my colleagues here at Memorial, Laura Tang, described the type ABC tumors, which basically was goblet cell carcinoid signature in poorly diff carcinoma. So it seemed, again, like the Minin category, it seemed a little odd to us, as if, there's a different tumor occurring in a precursor goblet cell carcinoid as opposed to progression of the same disease. And Melanie Jansela, who was our fellow some years ago, did a very nice study showing that the mutational landscape of goblet cell carcinoids and adenocarcinoma X goblet cell carcinoid were essentially similar. You couldn't tell them apart. They don't have the usual colon cancer mutations. They have mutations in chromatin modified genes like ARID1A. They don't really have APC, KRAS, and BRAF mutations. And then that led to this study, an outcome study by us. So the pendulum kind of shifted. I'm not very happy with this name that we ended up proposing, because now we pretend that it has nothing to do with neuroendocrine differentiation. And we now call it goblet cell adenocarcinoma in the new WHO and separate it into low grade and high grade. And essentially, it's the same process that if you have well-formed crypts, those tumors tend to do well. If you have signet ring cells, those usually are in the intermediate category. And if you have poorly differentiated tumors, that's where the APC KRAS start appearing, and those tumors behave in a very aggressive fashion. They don't really respond to chemotherapy for colon cancer. So mixed tumors, as you can imagine, and they'll have two components by definition, and the endocrine component can be poorly differentiated or grade 1 or grade 2, and the non-neuroendocrine component can be either an adeno or squamous cell carcinoma, and outside the dual gut, it can be, if you're dealing with pancreas, it can be ductal or acinar carcinoma. And there was a thought that if you have an adenoma as the non-neuroendocrine component, the neuroendocrine tumors usually are G1 and G2, which we know that is not true because tumors don't really follow the book. And so here's a nice example of a small cell carcinoma arising in an adenoma with, you can see multifocal lymphovascular invasion, and the patient presented with widespread metastasis and died within 6 months. So any combination of tumors can basically, the exocrine and endocrine combination can happen. So I'll just show you a few examples just to emphasize what you should be looking for. So you want to see two components, unlike the amphicrine carcinoma where there are two types of differentiation within the same cell. Here you have to have two components. So this is Barrett's adenocarcinoma, gland-forming tumor, and in the middle are these clusters and nests that have a very high proliferative index, and they are diffusely positive for chromogranin. The glandular component is negative for neuroendocrine markers, so this fulfills definitions for a mixed tumor. Of course, you have to give the proportions of each component. If you have a resection specimen or in a biopsy, you have to mention what you're seeing. Here's an example of a lower intermediate grade adenocarcinoma associated with a well-differentiated neuroendocrine tumor. Doing MIB in these cases is very helpful because it gives you a sense of what component is more likely to metastasize. So here you can see the gland-forming tumor is much more higher grade, whereas the well-diff tumor has hardly any labeling. So it's a grade 1 well-differentiated neuroendocrine tumor associated with an intermediate grade adenocarcinoma, and the neuroendocrine component is diffusely positive for chromogranin. In the colon, which is probably the most common site for these MINENs, you can have a well-differentiated adenocomponent with a poorly differentiated carcinoma. You can see sheets of tumor cells here with lots of mitosis and apoptosis. It's positive for neuroendocrine markers and has a very high proliferative index. So this is a well-diff adenocarcinoma with poorly diff neuroendocrine carcinoma grade 3. So you still want to do the same thing, give some sense of differentiation, and also give a grade in these tumors. And here's a core biopsy of a retroperitoneal mass, again, coming from the colon, where you can see, it's almost like, the best analogy I can give you is like a mixed cholangiohepatocellular carcinoma, where you want to see two distinct components. So you can see the gland-forming adenocarcinoma component here that's positive for mucin, whereas this poorly differentiated solid proliferation is positive for chromogranin and has this very high proliferative index on a Ki67. So molecular features of MINENs, Arthur mentioned yesterday that these are closer to adenocarcinomas rather than well-differentiated and neuroendocrine tumors. So they have mutations usually in APC, KRAS, and P53 and SMAD4. Microsatellite instability is usually uncommon. So this suggests that these are tumors that show divergent differentiation in an adenocarcinoma, and they don't really arise de novo. And as I said earlier too, that showing that you have loss of retinoblastoma protein on immunohistochemistry and a mutant pattern can be helpful if you have small amount of material and you're trying to differentiate whether it's a polydifferentiated neuroendocrine carcinoma grade 3 versus a grade 3 well-differentiated neuroendocrine tumor. It's not absolute, but most of the time it helps quite a bit. So how to treat? Not surprisingly, if you have just one component in your biopsy sample that's metastasized, then obviously we'll end up treating the metastatic component. If you have two components in your biopsy, we end up treating the more aggressive component. And if it's not clearly defined, you don't have a biopsy of the metastatic tumor, then you look at the primary tumor and treat the most aggressive component in the primary tumor of the MINEN. So I'll wrap up now. I know we are running a little late, so I just wanted to have this quick summary of GI tract neuroendocrine tumors and give you a few pointers that might be helpful in daily practice. So you can see that the neuroendocrine and mixed neuroendocrine and non-neuroendocrine tumors can show a diverse spectrum. Accurate classification is really key to management. So give your histologic type, grade it, and stage it properly. Don't stain conventional adenocarcinomas with neuroendocrine markers because you'll end up in trouble. Do not diagnose neuroendocrine carcinoma based on CD56 alone because you can see it in melanomas, sarcomas, lots of other tumors, so it's not really specific. So you want your chromogranin, synaptophysin, or the more recent INSM1 staining to make this diagnosis, and give what components you're seeing and what proportions of each component you see in the mixed tumor. And when you have such tumors, they're very difficult to treat and they have a poor outcome unless you're lucky, the patient is lucky and you're dealing with a low-grade adenocarcinoma and a well-diff neuroendocrine tumor grade 1 or 2. So if you have an aggressive component, if you have a biopsy of the metastasis, you will end up treating the metastatic component. And if you only have the primary tumor and you don't have metastatic biopsy, then you end up treating the most aggressive component. So I'll stop here. I'm sorry for my voice. I am under the weather a little bit since yesterday. And I'll stop here, and it'll be close to midnight here. So if I am still up, I'll join you guys for a little bit of a Q&A. Otherwise, you have my email address. Feel free to reach out, and I'll be happy to answer any questions. Thank you very much for your attention, and many thanks to Dr. Jain and Vinitha for inviting me to help out with the talk and the conference. Thanks very much.
Thank you, Amitabh, for nicely covering this topic. We all know about the classification in detail, but what you covered was the problems where we can be caught while we are making the diagnosis. And despite being so late, you have covered it very well. I don't think any question is there in the chat. Anyone, any delegate there if you want to ask? There is no question in the chat. So I think we can sum up. Any other person from there? Any delegate wants to ask any question, or we should sum up? Vinitha, Manoj? I think I can sum up here because all the points were very clearly explained by Amitabh, as we know always, and we enjoy his talk. And today also we enjoyed his talk very well, where he has briefly covered all the points where we can get got. So thank you, Amitabh. Thank you for giving this address at this time. So over to the organizing committee. Manoj, Dr. Vinitha. Hello. Can you hear me? Vinitha, now so we are summing up.
Yes, ma'am. We are closing this session, ma'am. Now we are moving to the other session. Thank you so much.
Thank you once again. Thank you, Amitabh, for very nicely and lucidly covering this topic. Thank you.
In 10 minutes. Moving on to the next session, which will be starting in 10 minutes. The session will be taken in ground floor. Thank you.
प्रॉब्लम आ रही है वहाँ पे नीचे प्रॉब्लम आई थोड़ी सी प्रोजेक्ट का कुछ ठीक है वन प्रॉब्लम आ रही है मैम नीचे थोड़ा जरा
तो बताए
अभी यहीं पे होगा मैम थोड़ा सा
There is an announcement, the session we will start it here.
वो अभी प्रोजेक्टर से दिक्कत आ रही है कुछ पानी से
Due to
निकल
some technical difficulties, we will be having the next session in this room only.
तो चाय ऊपर कर दे तो चाय ऊपर
हाँ ऊपर आ जाएगी
तो we will
Okay. Some technical problem downstairs, so we'll be just.
as soon as it is rectified
Honorable Chairperson and distinguished speakers. We welcome you all on the second day of 24th International Academy of Pathologists Indian Division Annual CME 2022 being organized by the Department of Pathology, HGPGIMS, Lucknow. We begin the next session now by inviting the chairpersons, Dr. Manjula Murari ma'am, Dr. Vijayalakshmi Bhatia ma'am, and Dr. Bandhana Mehrotra ma'am to chair the session for this talk titled Interpretation of Thyroid Hormone Profile. Dr. Manjula Murari ma'am is a former professor and head of Department Pathology, HGPGIMS, with a specialization in blood and bone marrow pathology. Dr. Vijayalakshmi Bhatia ma'am is a professor of pediatric endocrinology in the Department of Endocrinology, HGPGIMS. She was also the past president of Indian Society for Pediatric and Adolescent Endocrinology. Dr. Bandhana Mehrotra ma'am is a CEO director and consultant pathologist, RMS Pathology Laboratory. She has over 38 years of experience in surgical pathology, gynae pathology, and cytology. I will request Dr. Manjula Murari ma'am to please introduce the speaker.
Hello, good morning. It's great to be back. And I compliment the organizing team for doing such a wonderful work. And I hope everyone enjoyed yesterday's session. We could not attend yesterday, but today is going to be an academic feast as well. Maybe request Dr. Bandhana to introduce the speaker.
Yes, I'll pass this to Dr. Vijayalakshmi, who knows her very well.
Good morning, everyone. It's a pleasure to introduce Dr. Preeti Davarga. She is my colleague in the Department of Endocrinology, Professor of Endocrinology, very well versed in adult as well as pediatric endocrinology. And today she'll be speaking on interpretation of thyroid hormone reports. Over to you, Dr. Preeti. And while Preeti is putting up the slides, I'd like to just add that she's a very well accomplished endocrinologist, but she has an international reputation in polycystic ovary disease. I would just like to share that we're really proud of that achievement of her. Over to you, Preeti.
Thank you, ma'am, for those kind words, and I thank the organizers for this opportunity to speak at this CME. My talk would include a brief introduction of thyroid physiology, then we go on to dysfunctions and how do we interpret those tests. And no other biochemical testing in endocrinology has so much of interference, of assay interferences as thyroid hormone. Then we talk a little bit about special situations, because we know that age and various other factors affect the thyroid functions as they would affect any other physiology. Okay. So just a few words about the thyroid physiology. We know that thyroid gland is highly conserved in all vertebrates because thyroid hormone is required for all kinds of cell activities, be it multiplication, growth, maturation, development, as well as all kinds of energy requirements are met. And to begin with, in the development of animal kingdom, earlier we were waterborne animals where iodine could be reabsorbed and it was freely, abundantly available. But over the years, when we became terrestrial animals, we required systems to concentrate iodine, and humans, I think, are the ones who have iodine deficiency disorders the most. And UP is a hotbed seat for iodine deficiency. So we really need to have adequate iodine in our diet to prevent a lot of problems associated with iodine deficiency and thyroid hormone dysfunction. The thyroid hormone is very tightly regulated. It is controlled by the TRH, which is the thyrotropin releasing hormone, which is secreted from the hypothalamus. It acts on the thyrotrope cells in the anterior pituitary, which secretes the TSH. And then this TSH acts on the thyroid follicular cells. And every function of the thyroid gland is controlled or stimulated by the TSH. It causes the cell proliferation, cell hyperplasia. It increases the sodium iodide symporter expression so that more of iodine is trapped into the follicular cells, and it increases the iodination and coupling so that it stimulates the secretion of thyroid hormone. The hormones which are secreted from the thyroid gland are predominantly the T4 and less amount of T3 is secreted, although we know that T3 is the bioactive hormone. So peripherally, the T4 is converted into T3 by the deiodinase enzymes. And since T3 is the bioactive hormone, peripherally the T4 is converted into T3. And again, this conversion also is stimulated by the TSH. All these things are important to know because when we see the dysfunction, we will understand what is the role of this tight regulation of thyroid hormone. The thyroid hormone, which is secreted, acts negatively to decrease the secretion of TSH as well as TRH. Every person has a set point of TSH secretion. Some need a higher level of T4 to control the TSH secretion. Some require a lower. So that is why we have wide ranges of TSH. The normal range is from 0.4 MIU per liter to 5 or 4.3, depending on the assay which you use. So when the T4 or T3 is low, there is less of negative regulation, TSH is high and TRH is high. If the pituitary is dysfunctional, that means if you have secondary hypothyroidism, the TSH is low as well as the T3, T4 are low. So T4 and T3 circulate in the circulation bound to proteins, the thyroxine binding globulin, which has a high capacity, low affinity, then albumin and prealbumin. As I said, free T3 is the most metabolically active, and the conversion to T3 is important for its action. The various tests for thyroid function, the biochemical tests include the measurement of thyroid hormones, TSH, thyroglobulin, as well as measurement of antibodies. And the functional tests include the radionuclide scans, which include the radioactive iodine, as well as technetium labeled scans. The structural assessment is done by thyroid ultrasound or the CT and MRI. Now a thyroid clinic is not complete if the thyroid physician doesn't do an ultrasound. That is, gradually people are learning to do their ultrasounds in their own clinic so that a complete assessment of thyroid dysfunction can be done and the disease can be interpreted and treatment can be given. So I will concentrate only on the biochemical tests of thyroid hormones. So for thyroid dysfunction, when we have high T3 and T4, as I said, with the negative regulation, the TSH is low. So that is thyrotoxicosis. Primary hypothyroidism, when the thyroid gland is dysfunctional, you have low T4 with low negative regulation of TSH secretion. You have a high TSH. And when the pituitary is dysfunctional or the hypothalamus is dysfunctional, the TSH is low and the T4, T3 also are low. But in nature, nothing is so simple and clear-cut. Everything is as confusing as possible. So let's see what kinds of confusion thyroid hormone profiles can present. Generally, thyroid hypothyroidism or decreased thyroid hormone levels generally cause vague complaints of body ache, some amount of weight gain, and joint pains, cold intolerance. If a patient walks into your clinic with generalized edema, sore voice, dry skin, it's no biggie that you diagnose the patient as hypothyroidism, but not all patients come like that. You do a TSH and you diagnose it. But mostly patients present like this, some amount of facial puffiness, some joint swelling, some joint stiffness, and always TSH is the first test which you diagnose. In our own laboratory, we do about 3,000 TSH evaluations or assessments every month. So you can understand that the number of TSH done routinely all over in population is so high. So interpretation is very important. So when a patient presents like this, TSH is the first test to be ordered. And if the TSH comes more than 60 or sky high TSH, the diagnosis is very clear. You diagnose the patient as primary hypothyroidism. To find the etiology, if there is goiter, you do a thyroid peroxidase antibody measurement to know whether the patient has autoimmune thyroiditis. If the gland is not palpable, you say atrophic thyroiditis, go ahead and just treat the patient with levothyroxine therapy. But suppose the TSH just comes bang normal, then does it rule out hypothyroidism? Yes, it rules out primary hypothyroidism, but doesn't rule out other conditions associated with hypothyroidism. So what next? We do a T4, total T4. That also comes low normal. So what do we make out of this low normal T4 and a normal TSH? Two conditions. euthyroid hypothyroxanemia. As I said, that TBG is the predominant protein which binds T4. If you have any condition which leads to decreased TBG, the total T4 will be low. But then you can differentiate by estimating a free T4, which will be normal in a patient who has TBG deficiency, but low free T4 and a normal TSH was point towards secondary hypothyroidism, because the TSH is low, that is why the free T4 is low. And this normal TSH is an inappropriate TSH for a low free T4. As we saw in the regulation, that if the T4 is low, the TSH should go up. But if the TSH is inappropriately normal or not higher than, say, 10 to 15 milli-IU per liter, you should always think of secondary hypothyroidism. And secondary hypothyroidism, isolated secondary hypothyroidism is very uncommon. It is usually associated with other pituitary hormone deficiencies. So the next step to do to diagnose whether it is really secondary hypothyroidism or what is the cause is to do an MRI or a CT, which would reveal a pituitary mass, which would make you confident that this is secondary hypothyroidism. You evaluate for other hormone deficiencies and treat accordingly. Same thing I wanted to highlight in children who come with short stature. Other than other causes for short stature, important endocrine causes would be primary hypothyroidism and growth hormone deficiency because of isolated or a part of other pituitary hormone deficiencies. Again, here doing a TSH will fool you. So T4 is the treatment of test of choice, because it will tell you that the child is euthyroid or hypothyroid, and then you go ahead and evaluate further. Suppose the same lady came with a T4, which is 70 nanomoles, which is in the normal range, TSH, which is 10 milli-IU per liter, same lady which we saw earlier. The TSH is more than the normal range, because the normal range is up to 4.5 milli-IU per liter. We did a free T4, which is normal. That is, the lower limit is 10. So what is this now? Low normal T4, normal free T4, and a TSH of 10. It is subclinical hypothyroidism. That means the patient doesn't have obvious clinical features of hypothyroidism. The T4 is normal, but the TSH is high. And T3 is also normal. As I said, that the body tries to conserve the active metabolite. So as the TSH rises, the T4 to T3 conversion increases. And even in the evolving stages of hypothyroidism, you may have low T4, but a normal T3 and a raised TSH. So this also goes in the direction of an evolving hypothyroidism. Just a word about that, all patients of subclinical hypothyroidism do not require treatment. There are few conditions where treatment should be offered to the patient. And always remember that subclinical hypothyroidism doesn't mean a lifelong therapy. Give the treatment trial for 6 to 12 months. Always counsel the patient that we will stop the treatment, reassess. If the TSH rises again, then that means you need lifelong treatment. Other causes of raised TSH with a normal or a low free T4 would be, important one would be the patient is on treatment with LT4. Commonly happens if you have to take a medicine lifelong, you're bound to forget the treatment. So patients, and when they know that they have an appointment and they have to come and see the doctor, they would start taking the treatment religiously. So the T4 may be normal, but the TSH has not had time to recover from a high to a normal level. So the similar picture you may get on a patient who's on LT4 treatment or levothyroxine treatment, but a non-compliant patient. So you can get a normal T4 and a marginally or a raised TSH. You have to go back and ask for compliance. That is one of the commonest things, because we have so many patients who are on treatment. So it should make you suspect non-compliance. Then malabsorption of T4. Again, it will be the same condition like not taking treatment. Obesity, because the set point for TSH secretion is higher in obese people. So the TSH may be high. And the other condition which people need to think is non-thyroidal illness in the evolving stage. Earlier, in the early stages of non-thyroidal illness, you get a low free T4, low free T3, and a low TSH. But when the patient is recovering, the first thing to rise is TSH, because that is the one which is going to stimulate the thyroid gland to produce more hormone. So if you have a low normal free T4 and a TSH of 8 to 10, you have to go back and take history of critical illness. The thing which I want you to pay emphasis is macro TSH, which is important for pathologists when they are assessing, having an assay for TSH. So this is something similar to macroprolactin, where you have the monomeric TSH bound to an antibody. So you form a large circulating form of TSH, which has a long half-life and is biologically inactive. And none of the platforms which are available, automated platforms, can easily distinguish between normal TSH and a macro TSH. So you have a normal or a high normal T4 with a raised TSH. So you have to think of macro TSH. The various ways by which you can at least get an idea of this interference is to use a dilution method. That means you dilute the patient's serum with the diluent provided by the manufacturer. And when you run it, normally if the patient has normal or doesn't have macro TSH, it should be a linear curve. But that doesn't happen when you have a macro TSH. The other thing which commonly used for macroprolactin is a PEG precipitation. When you add PEG, polyethylene glycol, the large molecules bind to that and get precipitated. So when you measure the TSH in the eluent, it will come low. So if the recovery is less than 25%, it makes you think that this serum had macro TSH. But still, there are situations where it may not be so clear cut, and 25% is a ballpark figure. Different labs have to set up their own standards of cutoff to say that below this recovery, we will suspect macro TSH. The other sort of confirmatory test is to do a gel filtration chromatography, where the samples will separate on the basis of the mass and the weight. The other method to do is to incubate the patient's serum with a known hypothyroid patient who already has high TSH. So when you incubate the serum for 4 hours, this immunoglobulin which is there, which is causing the macro TSH, will bind to the TSH in the patient's serum. And then when you assess or estimate the TSH, it will come low. And the heterophil antibody interference will not show this kind of a fall, because in gel filtration, the human anti-mouse antibody actually co-elutes with the macro TSH. So again, if you have so many of the patients can have heterophilic antibody against mice, so then again, it will be difficult to interpret. So then this incubation technique comes in handy. So after having seen how hypothyroid hormone profiles can be confusing and what are the ways to understand it, we come to the thyrotoxic profiles. This is a lady who presented with history of palpitation, tremors, clear-cut history suggestive of thyrotoxicosis, and which is a strong possibility. The important thing to diagnose in this patient is what is the etiology of this thyrotoxicosis, because the treatment differs with the kind of etiology the patient has. So this is a hormone profile, which is clear-cut thyrotoxicosis. We are happy. We go ahead and start antithyroid drugs, carbimazole. No. If the patient doesn't give a clue to the etiology, we have to do certain radionuclide tests just to know what kind of etiology, because the treatment will differ. This is a clear picture of Graves' disease or a diffuse thyrotoxic goiter, which picks up the whole radionuclide scan, and the salivary glands up here are hardly visible. This is if the patient has a solitary functioning thyroid nodule. Here, the treatment of choice would be a radioactive ablation. And this is where there's no uptake at all in the thyroid bed. This patient has subacute thyroiditis. The thyrotoxic profile is because of the destruction of the thyroid follicles. The whole of the thyroid hormones are there. This patient doesn't warrant antithyroid drugs, because this is a self-resolving condition. The majority of the patients over a period of 3 to 6 months would become normal. Some may have a hypothyroid phase where they may require treatment, or you may just follow them up and they will become hypothyroid. Only 10 to 15% of these patients become permanently hypothyroid. So these patients just need to be followed up and given symptomatic treatment with beta blockers and pain relief. This is another patient who comes with history of eye symptoms with proptosis in the right eye. and has a goiter and has mild tachycardia, but no other features. So we think of a possibility that this patient could have Graves' ophthalmopathy, and we go ahead and investigate him, where the T3 and T4 are absolutely normal, and even the TSH is normal. So what does this patient have? Does he still have Graves' disease and ophthalmopathy or not? This kind of a picture is common or is seen in patients who have euthyroid Graves' ophthalmopathy. Graves' ophthalmopathy, 3/4 of the patients present with simultaneous thyrotoxicosis, but 10 to 15% of the patients may present with ophthalmopathy, be euthyroid, and then develop thyrotoxicosis later on. And less than 2% of the patients may not ever develop thyrotoxicosis. They may just have ophthalmopathy and get treated over the period of time. And nearly 10 to 15% patients may develop ophthalmopathy later on. And the second possibility, which is more likely, is that this patient is a patient of Graves' of thyrotoxicosis and is on treatment. So the TSH has become normal, and these T3 and T4 are normal because of giving antithyroid drugs. So these are the two differentials when you have a patient who looks like to have Graves' disease, and this is the kind of a biochemical profile you get. So this becomes the interpretation of this biochemistry. Here comes the role. If the patient is euthyroid, or if the patient doesn't have ophthalmopathy or dermopathy, you want to know whether this patient has Graves' disease or is thyrotoxic because of any other cause. Here comes the role of measuring thyroid receptor antibodies, the TRAB antibodies as we call, because that tells you that this patient has autoimmune thyroiditis or Graves' disease. What are the other indications of doing TRAB antibody measurement is, when as I said, we do a nuclear scan, which showed a diffuse uptake, that tells you that the patient has Graves' disease. But if the scan doesn't show a good uptake or doesn't clearly show an uptake, then TRAB positivity helps you reach a diagnosis. Absence of ophthalmopathy. To predict a relapse, suppose a patient who is TRAB positive continues to be TRAB positive at the end of the treatment, you can, with reasonable amount of certainty, say that this patient is going to relapse whenever you stop the treatment. So some kind of a definitive treatment this patient requires. In pregnant women, it helps to predict neonatal occurrence of thyrotoxicosis. And in neonates, it helps to differentiate between endogenous thyrotoxicosis and thyrotoxicosis due to maternal transfer of antibodies, because treatment and the monitoring will depend on the etiology of neonatal thyrotoxicosis. So this was about just clear-cut thyrotoxicosis, but then there are situations where you have suppressed TSH and the T4 may be normal or marginal high normal. Then what are those conditions and how do you interpret these results? When you give exogenous levothyroxine therapy to a patient who is primary hypothyroid or secondary hypothyroidism, you can't give the thyroxine in a way the body titrates the levels of thyroxine and TSH. So exogenously administered thyroxine will always lead to a high normal or a high T3, T4 and a suppressed TSH. So many patients who are on thyroxine therapy, when they get this report done to monitor whether the dose is adequate or not, are unfortunately put on antithyroid drugs, suspecting that the patient is now thyrotoxic. No, it is just that you're giving exogenously thyroxine hormone, you're bound to get a high T3, T4 and a suppressed TSH. So when you see a report, a history of thyroxine replacement therapy is very important. So when actually the form should contain, are you on thyroxine replacement therapy? One of the information. The other entity, as we saw, is subclinical hypothyroidism. Sorry, it should be hyperthyroidism. Is subclinical hyperthyroidism, where there are pockets in the thyroid gland which are producing more hormone, but the level of the hormone is not so high. And as I said, that the TSH or the pituitary gland is very sensitive to hormone. So as soon as it starts reaching a high normal value, the TSH starts, the levels of TSH start going down. So you may get a suppressed TSH with high normal T4 and the patient could be subclinical hyperthyroidism or thyrotoxic. And in the initial stages of non-thyroidal illness, as I said, that initially in this stage, the free T3, T4 are low and TSH is suppressed. In the evolving or in the recovery phase, the TSH is the first to rise. And very important for all people dealing with assays is assay interference because of biotin, streptavidin, or heterophil antibody. So how do these assay interferences occur? This is a sandwich immunoassay for TSH, where you have a capture antibody. This is the antigen or the TSH, which binds to the capture antibody. Then you add the label antibody is added, which binds to this complex, and it binds to the TSH at another site than the capture antibody. And then you have a reaction, whichever, electrofluorescence, chemiluminescence, or ELISA, whichever, the reaction is red. So the concentration of TSH is directly proportional to the reaction which is produced. So in a TSH assay, you can have interference at all these levels. You can have interference when you have anti-streptavidin antibody, because then it will bind here. And in the TSH, what you have are these magnetic beads which are labeled with streptavidin. Biotinylated capture antibody binds to the streptavidin. Then you add TSH, it binds to this capture antibody. You have the labeled antibody with ruthenium, and then you get the reaction and you read it. So at all these steps, you can have interference. What I'm more interested here is to talk about biotin, which is being very commonly used these days for various reasons. Biotin is sort of a wonder drug for skin, nails and hair, skin, nails and hair. So it's become a very common dietary supplement. And you never get to know how much biotin has been added to these dietary supplements. And patients actually don't consider dietary supplements as therapy. So they will not even come out with history that they are taking biotin. And you really have to dig into it. And the best way to do is what I follow in, and we generally follow in the clinic, is to ask patients to stop taking all what they have been taking as supplements, multivites or whatever for 3 to 4 days before they come for their sampling, because that is generally the washout period for biotin. And actually biotin is used because it binds to the streptavidin and it's a very strong reaction. So the capture of TSH is very good. So if there is any interference with biotin, the high concentration of biotin actually will bind with the streptavidin, and you will not have the capture antibody bind to it. So you will have less of TSH bound, less of the reaction. So less the reaction, less is the value of TSH. This is in reverse to what happens in a competitive immunoassay, which is used for measurement of free T4, T4 and T3. Here, the sample and the labeled antigen both are added. This is a one-step method where they are added together. The antigen, labeled antigen and the analyte bind to the capture antibody, and then it is washed. And the label or the bound is stuck to this antibody and the reaction is red. So lower the reaction, higher is the concentration. It's the reverse of what we get in TSH. So if you have biotin here, it will bind to this antibody and the labeled antigen will not be able to bind. So the reaction or the amount of reaction will be less. So less the reaction, higher the concentration. So what you would get is higher free T3, T4 and a suppressed TSH. So you would get a picture like thyrotoxicosis. You would get a picture which is similar to thyrotoxicosis. And as I said earlier, that you do a trap to detect whether the patient has thyrotoxic or not. Unfortunately, TRAB also will give a high value because it is similar to how you do a T3, T4. So you would have a high free T3, T4, a high TRAB and a suppressed TSH, very clearly like a thyrotoxicosis, and the patient would be put on antithyroid drugs. So the bottom line is, if you're not convinced that the patient has thyrotoxicosis because of the history, the other things, the two things which you could do is do a radionuclide scan, which will tell you whether there's increased uptake and tell you whether it is Graves' disease or not, or suspect seriously biotin interference and use various methods to avoid or to interpret the results. One is to take a significant and an in-depth history and give a washout period so that there's no interference. Use a different platform. you need to choose a platform which does not use biotin streptavidin method for capture antibody. Or the third step is to add enough of streptavidin to the serum sample, which will bind the biotin and then do the assay. So you will not have interference of that biotin circulating with your assay platform. So just a few words about how to avoid these assay interferences. One is to repeat a test, take a detailed history and try to interpret it with the clinical condition. If after all this you strongly suspect interference, use a different platform and then compare the results. If they are same, then you have to use other methods. And if the results are discrepant, your suspicion is correct that there is interference because of certain analytes which are present. The other method, as I told you earlier, was serial dilution. The next one is adding blocking agents. You either add hypothyroid serum for macro TSH, or you have commercially available heterophil blocking antibody test tubes where you add the serum and then analyze or assay the eluent. The other methods to deplete the antibodies are precipitation, gel filtration chromatography, or affinity extraction by adding, say, streptavidin as we added to when biotin is a suspect. After all this, this is just a diagram to show you what kind of interference, what kind of thyroid hormone profile you get, and what are the various assay interferences or interpretations which you make, and what are the ways to avoid or come over these interferences. I have dealt with this earlier, so I won't go in detail again. So a word about special situations. Thyroglobulin is this is just talking about when you follow patients with differentiated thyroid cancer and you do thyroglobulin as a marker for remnant disease or a recurrence of the disease. In a patient, we were following up in endocrine surgery. This is a patient from our sister department where they found that the thyroglobulin was undetectable. So does this mean that there is no remnant or the disease has not recurred? No, because the presence of antibodies to thyroglobulin interfere with the measurement of thyroglobulin, and you have falsely low levels of thyroglobulin. It works in the same way as I showed you in the antibody assay interferences. So always when you're following patients of differentiated thyroid cancer, you need to do thyroglobulin and you need to do thyroglobulin antibody simultaneously. So if the thyroglobulin is undetectable, measurement of thyroglobulin antibody helps. A rising titer of thyroglobulin or a measurable amount of thyroglobulin antibody should make you suspect that this patient has recurrence of the disease. And then you further follow up by doing iodine scans. If they are negative, you do a PET CT to localize the disease and manage this patient further. A 26-year-old female with first trimester of pregnancy of 10 weeks of pregnancy presents with a biochemistry report of high T4 and a suppressed TSH. How do you interpret it? Is it thyrotoxicosis or is it a normal thyroid physiology? Most likely it's a normal thyroid physiology in pregnancy, because thyroid binding globulin starts increasing in pregnancy, which begins by 8 to 10 weeks of gestation. Because of raised estrogen, the TBG rises. So you have a high T4 and the HCG has intrinsic thyrotropic activity. It is very similar to TSH. It binds to the TSH receptor and stimulates the thyroid gland and in turn inhibits the TSH. So a high T4 and a suppressed TSH doesn't mean that the pregnant woman is thyrotoxic. It just means that it's most likely that it is just similar to a normal thyroid physiology happening in pregnancy. But yes, if she has clinical features, you need to do TRAB and all the exercise all over again. So significant homology between hormone-specific beta subunit of HCG and TSH. So you have high concentrations and the picture is very similar to thyrotoxicosis. So, and a word just about thyroid function in neonates, I can't stop talking about, or at least our department, ped endo people cannot stop talking about neonatal screening for congenital hypothyroidism, which should be followed practically by everyone. So how to interpret those tests? The TSH levels actually depend on the gestational age and the time when the sample was taken. Because as soon as the fetus is out or the baby is born, there is a surge of TSH which takes some time to settle down. So first of all, when should you, I won't go into the depths, maybe just introduce you to this topic of neonatal screening, that you really need to interpret the TSH values based on the gestational age as well as the time when it was collected. And there are cutoffs given for different gestational ages as well as when you collect the sample and when should you retest. It's a whole different talk. And the second thing, that total T4 is high in newborns and it remains high for the first year of life. So levels are high in infancy and they are much higher than in adults. So to conclude, I would say that thyroid function tests are freely available, but their interpretation requires knowledge of thyroid physiology. Results really need to be clinically correlated, and with the use of antibody therapy, so many humanized monoclonal and antibody therapy being used for different diseases. Interference from these antibodies is significant, so we should be aware of these assay interferences. And euthyroid hypo and hyperthyroxanemia are common, which are physiological, and we need to understand it and to manage the patient accordingly. And etiological diagnosis requires ancillary tests.
Thank you, Dr. Preeti, for that excellent lecture. Are there any brief questions from the audiences?
Thank you for your rampant use of thyroid tests in general public when self-refer themselves without any indication also, or it's many times done as part of panel. At least in my own family, I can just give examples. People have been put on, Endocrine treatment for life on the basis of just biochemical investigation, and maybe the TSH is just reaching that cutoff of 10 or something like that. And they don't have any symptoms. So how do we go about it? My question to you specifically also was, are there any age-related changes in the levels of TSH that should be taken while doing the test? And you have nomograms for different age groups of the levels of these thyroid hormones and TSH. Particularly, what's your comment about the elderly, 70 plus?
TSH does increase with age, but whatever studies are there, people have shown in normal population that the increase is say 0.4 to 0.5. People have looked at TSH is less than 50 and the geriatric population. The TSH doesn't rise more than 0.4 to 0.5. So probably when we are talking of geriatric population, 6 MIU per liter should be the cutoff. But as I showed you in my slide for that subclinical hypothyroidism, we never should say that the patient requires treatment for lifelong. There are certain indications where even the treatment is offered. Many a times we don't even offer the treatment, at least if the TSH is under 10. In those situations, we don't even offer treatment. What we do is ask the patient to come back after say 3 months, or if the patient becomes symptomatic, then the patient can report earlier, but otherwise repeat it at 3 to 6 months. If the patient is already on treatment, there are 2 ways. Either you stop it completely or you decrease the dose to half and see the TSH. If the TSH is rising, that means then the patient probably is a hypothyroid and requires treatment. But if the TSH remains normal, you can, after that, again stop it and reevaluate. And all our subclinical hypothyroids, we give a trial of treatment for 6 to 12 months. It's really difficult in patients who are obese and attribute all their weight gain to hypothyroidism. Mind you, weight gain in hypothyroidism is say 4 to 5 kilos, even in grossly hypothyroid patients. So all obese patients attribute it to a thyroid bimari hai na, uski wajah se hai. And once you're euthyroid, probably you should lose weight. Although it's very difficult to lose weight, I accept it. But Ritu is looking at me and giving me a glare. But I think that's the way we do it.
I have a question. Should the thyroid function test be included in a normal health checkup package like all the companies are offering? It's a patient is asymptomatic, no problem. He only wants to have a biochemical test like sugar and cholesterol. So many times they come for thyroid. They have no problems and the TSH comes out to be 6, 7. Then they start revolving about the TSH. It came out 6 here, it came out 3 there. What to do? Then they will go to a third lab. Should it be included in the package?
At least whatever I understand, I don't think so it is required.
That's what I think.
Unless they have a goiter or some other autoimmune disease. Then if we say that you don't require TSH, but there are certain conditions like a type 1 diabetes or patient who has other autoimmune diseases, hypothyroidism, autoimmune hypothyroidism is a commonest association with other autoimmune diseases. So in those situations, yes, but not otherwise.
Thank you. And same thing I would say is happened. People are getting free. I mean, you mentioned the specific reasons and situations where it is helpful. Even that is, I think, there's been a misuse on a very large scale, physicians advising, go and get your fee.
At least
there is an interpretation of the problem of tests also. Patients start interpreting themselves, they Google, and then their physicians also.
Okay, Dr. Vinita, very quickly, please. You had a question?
No, I think Dr. Preeti answered it later on, so I don't.
Just one question. All right.
In post-radiation cases, if hypothyroidism develops, then do they have to go in for lifelong?
yes, post-radiation, yes.
And just one last question. So most of us have a tendency to start feeling fatigue, doubt, and weight. So should we get it because you said some cases may be asymptomatic? So,
Again, you really have to put it in perspective that are you overworking? Why are you? And so all that has to be really clinically correlated. And maybe your TSH comes 6, then what?
Clinically.
Okay, we find that then. Thank you, Preeti.
Thank you, Preeti, for the lovely present.
Thank you.
Thank you, ma'am. Thank you, Chairperson. Now we would like to invite the Chairperson for our next talk. Dr. Rakesh Pandey sir and Dr. Avdesh Jaiswal for the next talk. The next talk is titled Update on Pituitary Tumors. Dr. Rakesh Pandey sir is a senior professor, formerly in the Department of Pathology, SDPGIMS. He has vast experience in pathology and cytopathology. Dr. Avdesh Jaiswal is professor in the Department of Neurosurgery, SDPGIMS. His areas of expertise are endovascular surgery, functional neurosurgery, and cerebrovascular surgery. First, Dr. Rakesh Pandey sir, to kindly introduce the speaker.
I'm filling in for Dr. Lily. Pleasure to be here and pleasure to introduce Dr. Bishan Radotra. Although I don't think for most pathologists he would need an introduction. Most of you know him. Most of you know him as an excellent pathologist and possibly the best neuropathologist in the country. He also has interest in several other branches of pathology, including endocrine pathology and dermatopathology. And I think his list of achievements and publications is too long to be enumerated here. It is a pleasure to listen to him, both in public as well as in private. And I would not stand between you and him. Dr. Bisham, please.
Thank you so much and for your kind words. When Dr. Manoj asked me to be part of this conference, I readily agreed and I told him that I'll come in person. The reason was that I wanted to meet friends and I have very high regards for Dr. Pandey, who used to visit us as examiner in PGI. So, and it's pleasure meeting him and most of you in person. And I was asked to give a talk on update in pituitary adenomas. So here I am.
Which have disappeared.
So, well, most of us have diagnosed pituitary adenomas throughout our life, and I think it is one of the easy diagnosis. You don't go wrong because 99.9%, 99.5% pituitaries are adenomas, tumors, so they don't go wrong. So that's why I think we take it lightly also. And of course, when we take it lightly, naturally we are likely to go wrong somewhere. I have a slide here to show to younger people that if they are not seen normal pituitary, the pituitary is composed of two parts, the anterior pituitary here and the posterior pituitary. This is an autopsy specimen, so it's not containing the entire posterior pituitary, and it is cut in the mid-sagittal section, not the lateral, so that posterior pituitary comes here. The anterior pituitary is composed of, as we know, I mean, most of us know that acidophil, basophil, and chromophore cells. But these are very old things now. I think please forget about those things. That these are tinctorial affinity and all those things would be. These are very old things, century-old things. One thing which I want you to know is that anterior pituitary, it's very important. Reticulin stain is very important, so that you see that nests of cells are surrounded by fibrovascular septa. It is an important stain to do in pituitary. The posterior pituitary is, I would just say for this audience, is a neural component here, and you get spindle cells. So I don't want to go into more details here. So see what has happened to pituitary tumors. For about 70 years, we knew that there is adenoma and there is a carcinoma. Carcinoma is based on the purely, I think solely on the fact that the pituitary tumor has metastasized, which we don't get actually. Most of us have not experienced carcinomas. But after 2000, there has been exponential changes in the pituitary pathology. In 2004, people advised, including WHO, that we should do P53 and K67 in pituitaries, and they, at that time, they thought that people who cannot categorize the tumor as adenoma or a carcinoma, of course, is difficult based on mitosis. Some people tend to find more mitosis and all. So they said, okay, there would be a term called atypical pituitary adenoma because these tumors are aggressive. But I think in 2016, again, some authors, they said that pituitary adenomas are benign tumors, but they are very aggressive. They are resistant to therapy. So it is not good to call it adenoma. So it is inappropriate term. So delete it. Okay. In 2017, the term atypical adenoma was dropped. But from 17, there was a lot of changes. In 17, then International Pituitary Pathology Club, which was along with the European Pituitary Pathology Group, which is actually a very big group, this European group. They thought that since adenomas are benign tumors, so why should we call it adenoma? These patients, they have recurrences, they invade sinuses, they invade brain. So, okay, we should bring the term pituitary neuroendocrine tumor. Okay, I'll stop here. Then in 2018, the IARC, that is International Agency Research Against Cancer, they thought that pituitary should be combined, clubbed with all other neuroendocrine tumors. So there should be a unified classification. Okay. Then comes, this is a slide to show you the overall neuroendocrine cells, their tumors, etc. So I limit myself to pituitary. So yesterday we discussed parathyroid, thyroid. I think we discussed pancreas as well as adrenal. So of course, pulmonary we have not discussed, and skin. but today is pituitary. And pituitary now, based on the cyto differentiation, that under what influence these cells, primitive cells, they differentiate into different cell phenotypes. It is due to some transcription factors, and I'll show you in the next slide. So basically, you remember that there are three major families of lineages of pituitary cells, and further divided into they secrete 6 type of hormones, which we all know. So this is to the new classification which has come up. This I will spend a minute or half a minute on this slide, because please remember this is very important. That pituitary stem cell, it differentiates into somatotroph stem cells under the influence of PIT1. So remember the term PIT1 is a pituitary specific. Then they differentiate into corticotroph cells, which produce ACTH under the influence of TPIT. Then steroidogenic factor 1 differentiates into gonadotroph. So these are the 3 transcription factors which produces the 3 family of cells. But then the somatotroph stem cells further differentiate into either somatotroph, the growth hormone producing, or under the influence of estrogen receptor, it forms somatotroph. When it is acted upon by growth hormone repressor, it goes into lactotroph. And under the influence of GATA2 or GATA3, with growth hormone repressor, it goes to thyrotroph. So this is actually the main slide for this session. And so please remember this, that we have 3 transcription factors and then further differentiation. And okay, thank you. So then leave it here. So this is the WHO 2002 classification, which has come up recently. And the classification is about the typing or classification is about classifying the tumors, dividing the tumors based on these lineages. PIT1 lineage tumors, which is a huge group, and then TPIT lineage tumors, corticotroph tumors, and SM1 lineage tumors, which are mostly gonadotroph. You know, the names of these tumors, it's given in this blue book, what is recommended, what is not recommended, what is acceptable, what is not acceptable is what is written on this left-hand side column. So I will show you the examples of these. And I would have to say here that mostly all the photographs in my presentation is our own cases. So that is the kind of disclosure that I have to make. So traditionally now we say that adenoma is now called as pitnet. So what is the reason why pitnet is? The pitnet is because 40% of these tumors, they invade widely. They go into the cavernous sinus, they go into the bones, they in fact invade the brain. So an adenoma, which is a benign tumor, cannot invade. Okay. Now some of these invasive tumors are really clinically aggressive and they recur time and again. Only 0.2% or 2.5% of them are able to metastasize, and therefore these adenomas, they metastasize, so they cannot be called as adenomas. These are pitnets because they resemble other neuroendocrine cells, and they express insulin associated 1 and antigen, chromogranin, synaptophysin, and peptide hormone. So basically they should be clubbed with neuroendocrine tumors. And of course, for their treatment, they require surgery, medical therapy, radiotherapy. So no benign tumor actually requires all the subspecialties. Benign tumor, once removed, is removed. But then still there are some group of people, they say, if we call it as a tumor, it is bad for the patient to know that he has tumor, and vast majority of them, they don't kill. And so this is going on, but we have to stick to that now because WHO says it. I'll show you some of the examples which we. So when we have a patient of acromegaly, history-wise, what we should, as a pathologist, what we should have in mind? I think most common it would be a somatotroph adenoma. I shouldn't use word adenoma, I should somatotroph pitnet. So growth hormone secreting. So they are of 2 types, densely granulated and sparsely granulated. Densely granulated is commonest, but there are other tumors. Suppose you have a biopsy, you do a growth hormone staining, you don't find any growth hormone. So it's not necessarily that this is not a cause of acromegaly. There are other tumors which are now described, and I'll show you the examples why they are so, like mammostematotroph, which is a combination. This mammostematotroph is the new entity in the WHO 2022. It was not there in the 2017. Then immature PD-1 lineage tumors, acidophil stem cell tumor, all these things are there could be an ectopic production of hormone somewhere else with other tumors. So from adrenal, pancreas, etc. So now I show you this example. This is one of the cases which is a densely granulated somatotroph tumor, 36-year male who had these big hands and a strug. Please note that there is asymmetrical kind of low legs, but this patient suffered from polio. So this is a post-polio effect. So that's why his legs are, feet are not really acromegalic. But you see, and I would say here, I'm not going to spend time on histology of the pituitary because all glands, endocrine tumors, all are monomorphic, then trabeculae, sheets, papillary, pseudopapillary. So there's no point in describing those things. So there is a tumor here, which is seen, a very large tumor. And in India, most of the tumors, with our own experience also, 70% are macroadenomas, is more than 1 centimeter. And giant adenomas, which is more than 4 centimeters. So macroadenoma here, and then HNDY is this. But you see, if you do growth hormone, it's diffuse cytoplasmic positivity, 3+. And then if you do PIT1, this is also almost 100% cells are showing this. And after 22 months, this tumor was again there. Although although biochemically and clinically the patient had much relief, biochemically he was not showing much. We had, luckily or fortunately, my colleagues in the PGI endocrine department, they published quite a lot. And anyway, I'm a pathologist, so my name also gets included. So they publish really quite a lot. And they're very aggressive type of people. And we had a lot of series of all types of tumor. So this was a series on acromegaly patients. And what we found was that they were very aggressive disease with higher growth hormone levels, macroadenoma, as I mentioned. And I think they also compared whether if all neurosurgeons have to operate, what is the prognosis? And if one dedicated surgeon has to operate, it was found that if there is one particular surgeon and one pathologist, so it gets better. So that was actually in this paper also. This is an example of sparsely granulated tumor. You see, these are discohesive cells, one thing. Second thing is these are characterized by, I will just give you one feature of this, that they are characterized by fibrous bodies, which are basically this eosinophilic structures indenting the nuclei. And they stain very well with the cytokeratin, low molecular weight cytokeratin, so which is usually paranuclear. And if you have this sparsely granulated somatotroph tumor, they show almost 70% of the cells, they show positivity. And then of course the growth hormone, which may not be as much as you see in densely granulated. Now, if we have a patient which we used to call as a prolactinoma, but prolactinoma now it's a meaningless now. WHO says it is meaningless, and even prolactin secreting pitnet, they have said no, not recommended. So when we have a patient with the high prolactin levels, young patients, there could be variety of causes, not necessarily a prolactin secreting adenoma. Any tumor or any mass which is pressing the stalk of the pituitary, the so-called stalk section effect, can produce hyperprolactinemia. And last month only we had a case, a young person who had prolactin levels more. It was removed and it was diagnosed as a GBM in the hypothalamus, very rare again. And the endocrinologist came, oh no, prolactin level is very high, so you do prolactin. So we did prolactin. I knew that it's a GBM, but I did PIT1 and prolactin and showed him no, it is not. So then I told him it's a stalk section effect. So all those things need to be correlated. So again, there could be sparsely granulated or densely granulated. So I'd show you one of these examples, a tumor which is giant adenoma again. And this is a recurrent tumor. That's why I think the prolactin levels, we don't do prolactin generally because prolactin, I mean, we don't get prolactin tumors now because they are treated medically, and therefore in our material, most of the people, they don't get prolactin tumor removed. So you have to do PIT1 to confirm it. TSH excess, madam has taken a very beautiful lecture on thyroid just before me, and I think I'll just say that TSH again, secreting tumors are rare, but if you do these, when we analyzed our material, we found that out of 356 odd cases, 12 came out to be TSH positive, which actually did not secrete TSH, but because of the PIT1 and the clinical and other data to staining, we found that. So the TSH chomas are the so-called, actually this is our publication, which is last year only, and we have used our TSH choma, which is no more required. It has to be thyrotroph pigment. So this is an example, and one of the things with thyrotroph tumors, a clue is that they show more sclerosis, they show more fibrosis. That's why they are difficult to remove. So they cannot be resected completely, and therefore recurrences are common. So again, you have to do TSH and you have to do PITNET. So again, the other things which clinically they come to us is Cushing disease. In 2022 classification, there has not much been change in the say densely granulated corticotroph tumors and sparsely granulated. Only thing I would like you to remember is that the Krupp cell tumor, which is a variety of this, is very aggressive and should be recognized because this is a high risk tumor. So I'm going to show you two examples. One is Cushing disease, and this was a densely granulated, and the other one is a non-functional tumor, which was ACTH producing tumor. And there's a term called whispering adenoma. Actually, this is offshoot of silent adenomas. Silent adenoma is purely nothing. You don't have any hormones. Whispering is, in Hindi, it will be very difficult. But since we follow English people, that is, I wanted to say it. The phosphoadenoma. What it shows is just a little bit of clinical feature, subtle, or a little bit of increase of the secretions, but otherwise histology we don't do. So they told us that, okay, so we had about 2 when we analyzed our cases. So this is the upper panel is the basically densely granulated. It shows 100% cells showing TPIT positive. Well, a lot of cytoplasmic positivity in the ACTH and granular cells. Here the TPIT positivity is also less, as well as the ACTH positivity is also very focal. So it is important to recognize these. I'll come next few slides. I will show you why it is important to subtype them. No, Krupp cell is very important, I told you, and it shows pale eosinophilic cytoplasm. The cells may be little, you may find something nuclei which are not really round and very monomorphic, but this is what happens. The importance is to do a cytokeratin stain to see perinuclear ring-like positive staining. So cytokeratin is again very important stain for pituitary adenomas. In this photograph, what I'm trying to show you is that Krupp cell change is also induced in the surrounding normal pituitary. So that helps to differentiate between a hyperplasia as well as adenoma. Hyperplasia does not induce this Krupp cell change in the normal. So therefore, you should always, in all these tumors, you should exclude hyperplasia by doing reticulin stain. It is very important. Of course, EM can also help in this. Now, as far as gonadotropin is concerned, just remember that gonadotropin producing tumor, their incidence or their number is higher in surgical material, and they constitute about 40% of the PITNETs. Although epidemiologically, if you see prolactin producing tumors, they are the commonest, but since they do not come to surgical material, now gonadotropin PITNET is the more common tumor. And if you take non-functional tumors, about 70 to 75% of the tumors are gonadotropins. And you have to do the SF1, steroidogenic factor 1, GATA3, ER, FSH, LH, and they are variably positive for keratin, rather not positive. I'll show you this example. So these are two cases where again, one of the features, histological features is that commonly pseudo-vascular rosettes are more common in this compared to any other. So that is one should remember. This upper tumor is positive for focally for LH and very strongly positive the SF1. The lower, the other second case is not positive for LH, FSH, and also SF positivity is also lower. So basically, the fact is that we have to do these transcription factors. Now, what is null cell adenoma? Null cell adenoma is a tumor which does not show any evidence of adenohypophyseal lineage differentiation. And the incidence used to very high. Now it has come down to as low as, because this is a tumor of exclusion. So you have to exclude all others. It doesn't secrete any transcription factor. It does not express any hormones. That is what is null cell adenoma. They may be actually confused with paragangliomas, and you have to do cytokeratin and GATA2 or GATA3. GATA3 is very uncommonly seen in CNS paraganglioma. So if it is positive, it tilts the diagnosis towards paraganglioma, the cellular region. But I think difficulties again remain. There are non-functioning tumors. So this is one of the examples of non-functioning tumor. It shows little bit of nuclear polymorphism, and it is negative for all the hormones. The whatever positivity is seen here for GH, it is in the normal surrounding pituitary. Here SF1 is also seen in the normal surrounding pituitary. So null cell adenoma is negative for hormones, negative for transcription factors. So rare. Then the question of plurihormonal. Previously, we used to say if there are two hormones, PRL, TSH, or PRL and growth hormone, it is plurihormonal. Now it is not like this. In 2022, tumors which produce PITNET, they are basically PIT1 positive tumors. So when PIT1 positive tumors, they may secrete either any of these three. So these TSH, PIT, growth hormone, or prolactin and growth hormone, but these are PIT1 positive tumors, and these are called mature plurihormonal PIT1 lineage tumors. So this is mature. So these are the examples which in this case we had the GH, we had TSH, and we had PIT1, and focally PRL. So all the hormones and PIT1. When we have only PIT1 but no hormones, it is called, this is again the same example. When we have PIT1 but no other hormones, it is called immature PIT1 lineage tumor. Previously, the so-called previously called as poorly differentiated PIT1 lineage tumors. Mind you, the tumors in pituitary, they are hardly poorly differentiated. Even if they metastasize, they do not show. So we know that they do not, unlike other neuroendocrine carcinoma of the lung or pancreas, so they have very atypical cells. Here we don't have atypical cells. So therefore, the criteria here is that tumor is like adenoma, but it does not have either hormone expression as well as transcription. So that's what you call it as a immature plurihormonal PIT1 lineage tumors. Now I will show one or two examples, and I'll stop actually wherever you tell me. This is one example which we have a case recently. So there are difficult tumors also, although these are adenomas, but there are difficult tumors. Like this case in 2017 was biopsy was sent, and this was a non-functional tumor. We did everything and we found that time we didn't know. We reported. Now retrospectively we have done everything. It is a null cell adenoma, no hormones, no transcription factor. It recurred in 2018 and had ophthalmoplegia, and again there was only the SF1 appeared, so it became a gonadotropin. And then in 2021 again the tumor size has been increasing. It was very refractory to treatment. All types of treatment was given, and now I show you what has happened. This is the original biopsy, a little hemorrhagic, and only 1 to 2% of K67, P53 was positive, negative for everything. So-called null cell adenoma. Now there is this tumor has started showing SF1 and some FSH, and the K67 has gone to 5 to 6%. So it has converted. So this would be called as gonadotropin. But in 2021, it has also clinically showing hyperthyroidism. So it is converting. So what is this tumor? Nobody knows. So this is actually now there's a concept of transdifferentiation. So tumors can transdifferentiate also. So this is one of the examples which is quite difficult, and now it is becoming more aggressive. So I think metastatic PET-NET, we had one example which was quite resistant. It had gone into the lymph nodes, into the temporal lobe, and invaded the bone, etc., etc. So until you see this metastasis to lung, metastasis to liver, bone nodes, you can't label it as a metastasis. Ki-67, I think I will just say that Ki-67 has no role currently. We used to fight, okay, 3%, no role, basically no role now. The tumors are not graded according to the classification of tumor type and subtype has major clinical importance. Unlike other nets, PIT nets are not stratified into grades based on their Ki-67 proliferative index. My neurosurgeons, they push me to do Ki-67. I have fights with them, because they have not read the new things, so I can't help it. So it's not required. But only thing is that these 5-6 types of tumors, which is sparsely granulated somatotroph tumor and the Krupp cell tumor, immature PIT1 lineage tumor, lactotroph tumors in men. So these are the ones. The importance of this all this current concept is that you should basically subtype. And these are the ones which you must pick up so that the clinician is more aware of. So I think all staining should be done, but what I would advise you, I think I'll show this as a last slide, that we had a big series which is already accepted now paper. I think soon it will be published. So what we have suggested is, and this is in I think some papers from Sylvia and some other people, they have also nearly same recommendation, that what we should do is first panel of antibody should be SF1, PIT1, ACTH or TPIT. So either transcription factors, if you don't have TPIT because it is not easily available, so you should do ACTH, because ACTH and PIT1 sensitivity is 100%. If ACTH positive, TPIT comes positive. If TPIT positive, so therefore no problems. So you should do 3 transcription factors, and whatever is positive, you do the relevant hormones accordingly. So if PIT1 is there, then you rule out GH, PRL, and TSH. So that is the message that I would like to see give you. Thank you so much. I think I'll stop here. I'd like to thank my DM student. We had a DM student, Dr. Reddy, who has done thesis on this, and who has helped me in this talk. Thank you.
You would agree that he is the best person to tell us about the recent concepts about pituitary tumors, and he has given you several references which you can look up. It's a big topic because it's kind of a concept changing thing, and it is necessary because of the binary approach of human mind, which tends to classify things into 2. Although at the back of the mind, everybody knows that things are really a spectrum and they are not binary. So we have to forget that there is an adenoma and there is a carcinoma, and you have to accept that things are in a spectrum. Are there any questions?
Yes, I'll be happy to answer.
Several. Okay, we'll start there.
Yeah.
We'll start there.
Yes.
You can do CAM 5.2.
Yeah, CAM 5.2 also. Sure. I have done CK. We have CK 818, so I did, but CAM 5.2 plus A1, A3 is equally good. Yeah. So this would be probably, I think, mixed plurihormonal. So that is another entity. So mixed plurihormonal. When you have 2 transcription factors, yes.
When we have PIT1 positive, but we have 2 of the 3 marks. So then we call it plurihormone, or we have to
No. If you have PIT1 and 2 or 3, what do you mean? PIT1 lineage? No, you call it mature PIT1 lineage plurihormonal tumor. So it becomes mature PIT1 plurihormonal. So now actually there is one term is mixed, which where transcription factors are mixed. That is different. But once it is PIT1 only and mixed, it is just called as immature PIT1.
Dr. Vinita had a question.
I just wanted a very basic question, sir. So do we have any morphological you mentioned briefly at one
Yes.
or two slides, but
Yes,
do we
yes.
have any morphological correlates for these tumors?
Yes, I think this is
Everyone is not doing the whole panel.
Yes, yes, I know. I mean, this is a very important question from a pathologist perspective. Morphology is a little bit of subjective also sometimes. But I think if you, yes, if you have more experience, one of my colleagues who does pituitary pathology in England, he even HND wise he can say that this is but he's the one who writes all these things. If you have that kind of capability, yes, but for general pathology I would say please don't attempt a morphology. I know that if there is a gonadotropin tumor I would pick up because you can see the secretions towards the lumina, towards the capillary. So I did this. If there is more spindling, there is more likely to be TSHoma. So if there is then fibrous bodies and Crook cell changes, of course, clear. If there is a pseudovascular rosettes, more prominent is gonadotropinoma. But otherwise, I think over the experience, over the years, we have found that it changes. Now, like we have done this big study, it changes quite a lot from this. The other thing, if I have a 1 minute, can I? Yes. I'll tell you that because this is a common problem everywhere. You can't have all the antibodies and all. But I would say that if you a hospital must have this facility, must invest in it, these transcription factors, because all the hormones, some of the hormones are very small. They get during processing they get lost, so they do not come to be positive. So hormonal positivity is not a good thing, because these are nuclear positivity transcription, they are good. So that's why we come up with this algorithm. So I tell you one simple example. I was in London in 2008 or 9, and a neurosurgeon from my place, PGI, went to show the data and participate in endocrine meeting. So he showed that, 700, 800 pituitary tumors. People were 700 tumors, such a big series. And he presented there 50% of them were null cell adenomas. So everybody was up in there. What is happening? You have so many null cell adenomas. He said, yes, we have. He said, how do you say? Our pathologist tells us. So who is this pathologist? He says he's a professor, B.D. Radotra. And okay. The fellow came in the evening back to the hospital. They said, Bishan, you have a fellow who's a neurosurgeon, so and so. I said, yes, yes. He's here in the conference, but he says that you are diagnosing 50% of null cell adenoma. I said, yeah, did he say so? He was very confident. So what do you do? So I said, those days we used to do prolactin and ACTH, prolactin and growth hormone. Because Dr. Banerjee those days used to say that there's no point in doing the panel, limited resource setting. So we continued with that. So I told him we'd only do two. So now I understand why the cell has gone up. So there is always a miscommunication between surgeon or clinician. And so I think doing a small panel is no use. If at all you have to do, please invest in transcription factors. Thank you. No. Actually, prolactin, yes, if it is, we are not doing now all these hormones. Prolactin is doing when it is really suspected. Only then, otherwise not. Because once you do PIT1 and there is hyperprolactinemia, there is no point. So we want to do transcription factors, and then accordingly we want to do what is required.
Okay. So I have the pleasant job of thanking Dr. Rutra for such a wonderful talk, kindling our interest in pituitary pathology again. Thank you.
We will now put a 10-minute break for tea, following which the session will resume in the auditorium on the ground floor. All resident volunteers for the discussion on diagnostic pitfalls in thyroid cytology, please approach any of the organizers.
देखो और कुछ करना है शेयर शेयर करिए शेयर स्टॉप करिए हेलो हाँ ठीक है साउंड आ रही है हाँ हाँ इसको रिकॉर्डिंग पॉज
A very good morning to everyone. I, Dr. Shaila Fareel from Pathology Department, SGPGI MS. I, Dr. Shalini, Senior Resident from SGPGI Department. We are honored to welcome to all of you here at 24 IAP IDC at SGPGI. And now we are starting our session, which is entitled as Diagnostic Pitfall in Thyroid Cytology. Now to commence the session, I am highly obliged to call upon the stage Honorable Chairperson, Dr. Professor Nirupama Ma'am. She is the Professor and Head of Department of Pathology at Era Medical College, and Professor Anurag Gupta sir. We requested all the chairpersons to kindly come up on the stage. I request Professor Anurag Gupta sir to kindly introduce our speaker of this session, Professor Shipra Agarwal ma'am.
Good morning, everyone. So we are going to have the next session, and I will invite Dr. Shipra Agarwal to deliver this talk on pitfalls in thyroid cytology. Dr. Shipra Agarwal is currently additional professor in Department of Pathology of All India Institute of Medical Sciences, New Delhi. Her area of interest are endocrine and dermatopathology. She has more than 120 publications in her credit, and she has also written one chapter on the endocrine system in Robinson Cochrane, Pathologic Basis of Disease, 10th edition. And she has authored pathology outlines chapters, and she has more than amongst more than 25 authors of 2020. And she is also working as member of Asian Thyroid Pathology Group, and she has received multiple awards, including the much coveted Travel Grant Award from the International Society of Dermatopathology and the Dr. V. Ramalinga Swami Award. I welcome Dr. Shipra Agarwal. Over to Dr. Shipra, please.
Thank you, Dr. Anurag, for an introduction. It was a pleasure to know Dr. Anurag when he was at AIIMS. So I have been given 40 minutes. This is going to be a case-based presentation. I have about 16 cases. So without much ado, let's start. And I have I requested the organizers, which was duly complied that I need some few residents who can discuss the cases for me to make it more interesting and interactive. So there are no conflicts of any sort, and this presentation is based mainly on my experience with few references taken from the literature. All the cases are from routine clinical practice. So before we go through the possible pitfalls in thyroid cytology, let's see how do we classify thyroid cytology aspirates. So you all know this. Just for a revision, there are 6 categories from 1 to 6. 1 is unsatisfactory, 2 is benign, 3 is AUS, 4 is follicular neoplasm, 5 is suspicious for malignancy, and 6 is malignant. AUS, ATP of undetermined significance, is further subclassified into 6 subcategories. AUS-C, C is for cytological atypia, AUS-A, architectural atypia. So you have to call something as C when you're thinking of nuclear features which are suspicious for PTC, but they're not enough to be called category 5. AUS-A, when you have microfollicles, the new Bethesda, they also added 3D clusters and 3D fragments into this. AUS-A and C, when you have a combined features of cytological and architectural atypia. AUS-H, when you have a predominance of oncocytic atypia. AUS-L, lymphoid atypia, and NOS, when you cannot fit into any of these categories. So this is just an overview of what we have in Bethesda. So can we have our first resident volunteer, please? Anybody? Yeah. So don't worry. These are all diagnostic pitfalls. All of us are bound to make mistakes. We also made mistakes. That's why I brought these cases up. So case 1, 7-month-old male, a thyroid nodule aspirate, very cellular aspirate. You can see a lot of vascularized fragments with stroma. Again, the pap stain smear, lot of cellularity, no colloid in the background. A higher part showing nuclei are predominantly round in shape with rare nuclear grooves, no inclusions. There's an abrupt nuclear pleomorphism with sudden large nuclei, but chromatin is similar to the background nuclei. Over here, you can see some vascularized fragments, no colloid in the background. This is the MGG stain smear. So what would you like to call it? Bethesda category. Category 3. Would you like to subtype it? So cytological atypia you call something when you're thinking of PTC. Are you thinking of PTC in this? There are no nuclear features of PTC. So it's better to call it AUS-NOS. Now, can you do something about this patient? Instead of giving it AUS, do you want to, it's a waste basket. AUS is a waste basket. Do you want to better categorize it? For doing that, what will you do? So we went back to the clinician. Okay, we asked them the ultrasound, we asked them the clinical, there was nothing on the form. So this was a patient who was hypothyroid, and on ultrasound it was a benign nodule. So now can you think of something? Young baby, few months old. So this was a case of dyshomogenetic goiter. The large nuclei which you were seeing are called monster cells. Okay, there were no nuclear features of PTC. So it's a major pitfall. It can appear like AUS, it can appear like a predominantly microfollicular pattern. You can have some nuclear atypia, but not the nuclear atypia of PTC. You can have those nuclear changes also, but they can be a varied presentation. So all hypercellular aspirates, with or without vascular fragments and nuclear pleomorphism, are not malignancies. So yeah. So you have to always go back. You may, in fact, the patient may be in euthyroid also. It may be an undiagnosed case, and it may present with a thyroid nodule. There may be some colloid. So it has different stages of aggressiveness depending upon the severity of the enzyme defect. Category 2. So now we did the clinical and the ultrasound findings, we can go back and call it category 2. Okay. So will you like to take another case? I have 16 cases. Case 2. So let's quickly go through it. We can have the questions at the end. So again, this was a hypocellular aspirate, no colloid in the background. We were seeing these vascularized 3D fragments. This is a papilloid fragment, but there is no vascular core, but it's a tight 3D papilloid fragment. Another fragment over here. So this is the high part of the first image. Nuclei are predominantly round, and there were no nuclear features of PTC, but yes, we did have these 3D vascular fragments. So what's the Bethesda? So when do you call it category 4? So when your suspicion is follicular neoplasm, in this there are vascularized fragments, but there's no nuclear atypia, there's no predominance of microfollicles, right? And you don't have colloid, so you cannot go category 2. So I would like to call it AUS, probably AUS-A, because 3D fragments have now been included into the Bethesda. But I feel AUS-A should be used when there's predominance of microfollicles, but we have to follow the guidelines. So I called it AUS-A without any nuclear atypia. Well, this turned out to be an adenomatous goiter. So you can see from where these papilloid fragments came. You can see something over here which looks similar to what we have. So there was a lot of hyperplasia of the follicular lining. Another area. So this is the papilloid fragment which I talked to you about, and this is pseudopapillary hyperplasia. So adenomatous goiter, all aspirates with papilloid fragments are not PTCs. Do look for nuclear features of PTC. There have been instances when the tight fragments in aspirates without the nuclear features have been just screened in low power and called PTC. So be careful. Case 3, very cellular aspirate, again a thyroid nodule, no specific clinical history. Very cellular aspirate, no colloid. We have these focal areas of microfollicles, and there are these tight papilloid fragments. Another fragment with some nuclear atypia, although there, you can see some platelet clumps also. There is some nuclear enlargement, a partial groove. Somewhere there are longitudinal grooves throughout the axis of the long axis of the nucleus. One more focus showing some microfollicles filled with colloid, and again a tight fragment. Pap stains may have the same. You can see some RBC, so probably a vessel. I'm not sure because I don't see any endothelial cells, but again, tight three-dimensional fragments.
Any other resident want to answer this? Yeah.
So all are not category 3 in my presentation. So are you seeing so many microfollicles? I don't totally disagree with you. There are 3D fragments, they are tight papilloid fragments. So there can be an inter-observer variability which is acceptable. It can be called either 4 or 5 depending upon the severity of the nuclear features. So hypercellularity is there in many of the categories. It's there even in 3. So in 3 subcategories, if you see hypercellularity but with patchy nuclear features, you can call it AUS. So hypercellularity is not the sole criterion. You have to look at other features also, but I agree with you. You can call it 4. Somebody may call it category 5, but there were no Samoma bodies, rare, doubtful inclusion was there. So category 4 versus 5. So well, this turned out to be an invasive follicular variant of papillary thyroid carcinoma. So there were no true papillae in this entire specimen. We had processed it in its entirety. And you can see the clearly overt nuclear features on histopathology. So all aspirates with papilloid fragments are not classical PTC. So all with papilloid are not PTC. All with papilloid are not classical PTC. So this was case 3. Case 4. Any of you can take up. So a very cellular aspirate, no colloid in the background. You are seeing these true papillae. You can see the vascular core, very beautiful tree-like arrangement. There was focal discohesion. Nuclei are a bit elongated. They look darker staining, but they don't have the nuclear features of PTC. We could definitely see a rare groove. I'm not able to locate it here, but there were rare grooves on hunting. And they had these nondescript, ill-defined cell margins. Very good. So in which category, in which type of medullary do you see papillary fragments? Is there any variant? So there's no variant of MTC, but you can get various architectural patterns. So there's a pseudo papillary pattern, but in this you are having true papillae. So this was a problem for me. It didn't look like PTC to me. I was not sure what I'm dealing with. There were no inclusions. So we're calling it something category 6. You need to have intranuclear inclusion, Samoma bodies, 2 papillae. We did have 1, but we didn't have the other 2. So I went back to the clinician. I got the ultrasound. TARADS was high. It was 5. So I ended up calling it category 6, but I totally agree with you. You can call it 5, suspicious for carcinoma. Not sure, PTC versus MTC. That's very well acceptable. So any guesses as to what it turned out to be? A rare case, but a diagnostic aspirate. It was a case of columnar subtype of papillary thyroid carcinoma. Okay, so this patient also had lymph node metastasis. That's why they could tell me that it is category TARADS 5. So aspirates with 2 papillae, but absent or subtle nuclear features. It may be one of the PTC subtypes. It may be an MTC with a pseudopapillary architecture. It may be follicular adenoma with papillary hyperplasia, which was discussed by Dr. Uma Nahar yesterday. It can be a case of papillary hyperplasia, and you have to rule out metastasis in this. So I'm not saying that this case you will consider all these differentials. No, I'm just giving you differentials when you see papillae or 2 papillae in an aspirate. In this case, you cannot have all these differentials. Coming to case number 5, just continue. So this particular aspirate, abundant colloid, you can see dispersed follicular cells in the background. Now, suddenly out of the blue, we had these particular clusters which had some amount of abundant cytoplasm. There was a nuclear enlargement. There was definite nuclear folding and membrane irregularity, but we didn't see any definite intranuclear inclusion. So abundant colloid with atypical cells showing some nuclear features of PTC, including, so nuclear score of 2, grooving and enlargement. Which type? Cytological atypia. So in a background of colloid, you're getting some atypical cells in a background of not only colloid, some benign follicular cells also, right? And not a very cellular aspirate. So you are correct. This was a case of adenomatous goiter with palpation thyroiditis. You can see the granulomas, and interestingly, the granulomas were present on the anterior surface of the thyroid. That's how I sectioned it and realized they're all present on the anterior surface. So this was a case of palpation thyroiditis with adenomatous change. There was focal oncocytic metaplasia, and these cells looked exactly like what we had on the aspirate. So this was adenomatous. We now call it follicular nodular disease as per the new WHO with palpation thyroiditis and oncocytic metaplasia. I prefer to still use the term AG because that's what my clinicians are used to. So cytological atypia mimicking PTC can be seen in many non-PTC conditions. Adenomatous goiter, lymphocytic thyroiditis, hyperplastic nodule, hyalonizing trabecular tumor, oncocytic neoplasms, MTC. So oncocytic neoplasms particularly, they can even show you inclusions. So be careful when you call something category 5 or 6. Case number 6, a very hypocellular aspirate, no colloid in the background. We had some very few such fragments which were cellular. You can see nuclear features of PTC are there. There is nuclear enlargement, some chromatin clearing, occasional doubtful whether, I'm not sure whether it's artifactual or true, but intranuclear inclusion was there at the time of aspiration. So what would you like to call it? Category 5, but it's a hypocellular aspirate. So 5 and 6, you need to have at least moderately cellular to hypercellular aspirate. Will you like to revise your category? Very good. Considering the hypocellular aspirate, you'll call it category 3. Now, I didn't show you one feature which is very subtle in this. So can you see some lymphocytes over here? 1, 2, 3, 4, 5. Some centrocyte nucleus, some dark staining nuclei. So that was in retrospect. I cannot say that I saw it at the first time. This turned out to be Hashimoto thyroiditis on histopath examination. So again, cytological atypia mimicking PTC can be seen in many non-PTC conditions, which I've already enumerated and enlisted. So you should be especially careful when you're dealing with hypocellular aspirates. Again, go back to your clinician. Always get the thyroid function test at the time of assessing the aspirates, which it was discussed very beautifully today morning. So case number 7. Yeah. So this aspirate depends upon the type. I didn't call it Hashi. This aspirate depends upon the site of aspiration. That particular focus. That's what I'm saying. So I call it AUSC. I cannot call it thyroiditis. This is cytological pitfall. That's all. So case 7, abundant colloid, a very cellular aspirate with lot of fragments, 3D fragments. Some of them are vascularized, and you can see what are these white zones? Scalloping and resorption vacuoles. So these were very prominent, again abundant colloid. There was some macrofollicular architecture. Most of the nuclei were looking benign, round, focal microfollicular arrangement, very round nuclei. There were some who were within these fragments, and there were some which were showing nuclear grooves and some enlargement and overlapping. Another focus, another opened up macrofollicle. This is a high power view. You can see some nuclear grooves. I was not sure whether there's some distortion because of smearing, because at the periphery they were looking pretty round. Very good. What are the reasons? What about scalloping and colloid in the background? Will you still like to call it category 5? That goes more in, and the presence of macro follicles. So that goes more in favor of an adenomatous benign nodule. We called it, I was thinking this is probably a hyperplastic nodule, so many macro follicles, so much colloid, and probably the nuclear ATPI is reactive. And but I'm afraid you are right, I was wrong. So it turned out to be a case of, anybody tell me? It turned out to be a case of macrofollicular papillary thyroid carcinoma. So you can see this is a large macrofollicle. The macrofollicle is filled with colloid. You can see the same resorption vacuoles here and then intranuclear inclusion over here. So this, I'll come to the discussion later. So there was a lymph node metastasis also in this particular patient. Case number 8, would you like to continue? So this aspirate again had colloid in the background, and it was not very cellular. It was a hypocellular aspirate, mainly colloid, with this occasional fragment showing mainly round nuclei of the follicular cells. And again, you can see these fire flares in the background. There were no nuclear grooves. So what would you like to call it? This is category 2. I called it category 2. Pardon me, ma'am? Yeah, there are some lymphocytes in the background. Actually, they can be confused with follicular cell nuclei. So, well, this was not my focus. This also turned out to be macrofollicular PTC on HPE. So because I'll come to the discussion. Case 9. Again, abundant colloid, lot of cyst and hemosiderin-laden macrophages in the left-sided image, and opened up macrofollicle without any nuclear features of PTC. On GMSA, lot of colloid in the background and similar fragments, but they tend to show some nuclear grooving, and I was not sure over here whether to consider the PAP stain as final that was HE actually, that was an outside slide, or whether to consider this ATPI as final. So what will you like to call it?
I would say category 5.
No, so this is not category 5. This will be AUSC, or you can even call it category 2. So depending upon how much ATPia you have. Again, this was a case of macrofollicular PTC on histopath examination. So this is a recent review of, not a review, this is an additional case series of macrofollicular PTCs. And it was seen that as many as 60% of the cases were called Bethesda 2 on cytology, 30% category 4, and only 1 was called category 6. And interestingly, all of these, the macrofollicular PTC, even on ultrasound, usually has a lower TIRADS. Why? Because you have large macrofollicles and you have abundant colloid. So it gives a spongiform look on ultrasound and you get a low TIRADS. So that can be a pitfall in itself. On aspirate, you will get a low cellularity, abundant colloid, macro or microfollicles with or without dissociated clusters. By definition, papillae are absent and the nuclear features are also absent or focal. Especially on cytology, it's difficult to pick up. Another series of 4 cases in which 3 were called benign and 1 was called PTC. And this was by Bongiovanni et al. So he is a well-known person in thyrocytology, and you can see. And on macroscopy, gross examination of these specimens also, they were all called colloid nodule. This is a review of 35 cases in which 29% were called benign on aspiration and 37% were called PTC. So again, the diagnosis has ranged from category 2 to 3 to 4 to category 6. So abundant colloid, fire flares, and macrofollicles are features of colloid nodule or adenomatous change, but they can be present in macrofollicular PTC. That's what we need to remember. But please don't take home this message and start calling everything as macrofollicular PTC. Nuclear features in macrofollicular PTC can be absent or focal. Just to keep all this in mind. When I came across these cases, I was taken aback. I thought, especially the first case. The first case had lymph node metastasis, and I was actually taken aback. And that's when I went back and saw the smears again. Subsequently, somehow 2 more cases came within the next few months. So that's how I started collecting them and actually noticing these cases. Case 10. A very cellular aspirate. You can see tight 3D fragments and some singly dispersed discohesive cell clusters in the background. On high power, they had the predominant microfollicular architecture. Easy case. 2. Microfollicles. Category 4. Okay, this turned out to be an intrathyroidal parathyroid adenoma. The nuclei are GATA3 positive and TTF1 negative. So the take-home messages: All follicular pattern aspirates are not thyroid follicular cell in origin. Usually they are FN, but parathyroid neoplasm, follicular pattern MTC, NIFP and FEPTC need to be kept into the differential diagnosis. You need to look for ancillary finding. You need to, for parathyroid, it's very difficult to diagnose, but if the history is of a nodule which is behind the thyroid, the nuclei are small, round, hyperchromatic, and there is scant cytoplasm, then you can think of. But I think it's quite difficult to diagnose something as parathyroid, and suddenly you have the history. Okay, so we have few cases of spindle cell lesions. So a very cellular aspirate composed predominantly of spindle cells. There were numerous vascularized fragments. There was focal query as if they are forming a round shaped SNR structure around some central space. Category 6 query MTC I called it category 6, probably MTC. So this was actually a case of spindle epithelial thyroid tumor with thymus-like elements. So just to bring out what all differentials you need to, you can see on thyroid aspirate. So this was settled spindle epithelial thyroid tumor with thymus-like elements. On retrospect, when we re-evaluated the thyroid aspirate, we found that there were some of these bodies which had the similar material, myxoid or mucoid material in the center. Another case, so all these are similar. You'll end up calling all of these category 5 or 6. Another spindle cell lesion with the nuclei being blunt-ended. They have nondescript cytoplasm, no amyloid, no nuclear features which were like that of MTC. So at this, so again, you don't need to stand up. I think it will be category 6 or 5 depending upon the cellularity. This was 6. Category 6, I call it MTC, but we did immunocytochemistry. It was negative. So we were not sure what we are dealing with. It was a young child. I remember the patient. And we told them to do serum calcitonin levels. They were also negative. So they went ahead with resection. It turned out to be a case of primary synovial sarcoma of the thyroid. This is translocation X18. Yeah. So another case. Okay. So in retrospect, when we again went back to the smears, there was focal acinar arrangement, and some of these cells looked a bit different. So they were a bit polygonal as compared to the elongated nuclei, which we saw in the most of the aspirate, but these were difficult to pick up on routine cytomorphology. Next case, case number 13. So this was a hypocellular, less cellularity aspirate. We didn't see any colloid. There was mainly hemorrhage with some of these fragments, which were composed of these spindle-shaped cells with blunt to pointed end nuclei, and they were embedded within this collagenous sclerotic matrix. So again, another focus. So again, this was one of the difficult aspirates we had. We called it a spindle cell lesion, probably benign because there was no atypia, and even normal thyroid parenchyma or thyroid cells were not seen. So no, there was no necrosis. So this turned out to be a case of fibromatosis of the thyroid gland. You can see the spindle cells which are infiltrating and destroyed the thyroid parenchyma. And these are the immunohistochemical profile. Case 14, a very cellular aspirate, and you are seeing these discohesive clusters of blunt-ended spindle cell nuclei, and hardly any cytoplasm. Again, no amyloid, no features which were suggestive of MTC. We called it category 6. We didn't have, so similar workup was done, which was all negative. So this was interestingly the lady who had a history of hysterectomy done in private. We didn't have any records. Interestingly, when we searched our records, we found that there was a liver biopsy sent almost at the same time, and it had a metastatic leiomyosarcoma. So in hindsight, we put everything together. So it had also metastasized to the thyroid. A rare presentation, but that was the case. The take-home message is most spindle cell aspirates will be MTC, but not all of them. So in case you are not seeing calcitonin immunoreactivity, serum calcitonin levels are normal, you need to follow up, or you need to, so cell blocks often help. So other spindle cell lesions of thyroid, what all you need to consider? Anaplastic thyroid carcinoma, spindle cell variant of PTC. So do look for nuclear features. PTC with nodular fasciitis or fibromatosis like stroma. This was an important differential in the case which of fibromatosis of thyroid, because in these cases, the PTC component may be very small. It may not be aspirated. It may be even difficult to find it on histopath. So you need to sample a lot to rule out PTC. Renal thyroiditis, solitary fibrous tumor, post-FNA or biopsy spindle cell artifact, peripheral nerve sheath tumor, spindle cell follicular adenoma and carcinoma. So main differentials, spindle cell PTC, don't miss it. MTC, of course, I'm sure none of you will miss it. Spindle cell follicular adenoma and carcinoma. So these are the, which are like, we know that they can occur commonly in thyroid. Rest all you also need to keep in mind. Case number 15. So I think one of you needs to take this up. This is an interesting common case. I should not say interesting, maybe a common case. So what we were seeing was this
from this side. Would you like to participate? This side? No? Anybody?
Only 2 more cases and they are very easy. Okay. Arey beta, pura describe to karne do. That will help you. So a very cellular aspirate, what we are seeing are mainly oncocytic cells. So as per the new WHO, we have stopped calling anything hurdle, as sir described yesterday, and we call them oncocytic cells. So predominantly oncocyte-rich aspirates. The nuclei were predominantly large, but they were enlarged. They were predominantly round, but they were large in size. And you can see multiple intranuclear inclusions. So this one has single, this one has 4, this has like a double inclusion. There were numerous intranuclear inclusions. So now what do you want to call it? Beta, there are no lymphocytes. It's a very cellular aspirate, no colloid. So what will you call it? Tell me the Bethesda. Did you see true papillae? Did you see samoma? No. So I told you even oncocytes can show inclusions, but I agree with you, not so many. Okay, so this was a case of oncocytic PTC. You can call it 5 or 6, depending upon the severity of the nuclear features. But you should always remember that oncocytic PTC does not show true papillae. It may show, I'm not saying it, I should not say it does not show, but usually it does not show. It does not show the typical nuclear overlapping. Why? Because these have abundant cytoplasm. So the cytoplasm keeps the nuclei away and they don't overlap much. The nuclei are predominantly round. But don't remember, oncocytes can also show occasional inclusion. And I have also made a mistake. I have called something PTC when it turned out to be an oncocytic adenoma. Luckily for me, there was a microcarcinoma lying nearby and it saved my skin. So the oncocytes are prominent diagnostic pitfalls. But this was a case of oncocytic PTC. So all aspirates with oncocytic cells are not oncocytic neoplasms. You can see the oncocytic change in adenomatous goiter, in Hashimoto thyroiditis, in an oncocytic adenoma. In Hashimoto thyroiditis, a predominant oncocytic nodule may be there. Oncocytic PTC, tall cell PTC, Vardin-like subtype of papillary thyroid carcinoma, oncocytic MTC. So you can see them in a number of cases, and depending upon what you are seeing, the Bethesda will be decided like that. So for example, this was an aspirate in which predominantly we got oncocytic cells, but there were interspersed small lymphocytes. Clinical history was suggestive of Hashi, so we call it category 3, AUSH. This was a hypocellular aspirate, but we got these oncocytes. There was nothing else in the background. Again, we called it AUSH because it was hypocellular. This was the case which we just saw. We call it category 5, highly suspicious for PTC, and it turned out to be oncocytic PTC. This was a case of oncocytic MTC, medullary thyroid carcinoma, which showed oncocytic change. It was very this thing, and in this case, we did see the azurophilic granules. You can see one over here, plus this abrupt nuclear pleomorphism and multinucleation, and we did calcitonin immunocytochemistry, which was positive. So depending upon what you are seeing and ancillary findings plus ultrasound and clinical, you can make the Bethesda classification better. Last case, a cellular aspirate. You are seeing predominantly lymphoid cells, no thyroid follicular cells. There is an admixture of mature and immature, but there is an immature lymphoid cell preponderance. Anybody? So category 6. I told there is an admixture beta. So admixture, your differentials are non-Hodgkin lymphoma, as you said, category 6, or it can be Hashimoto. So when there is a lymphoid follicle formation and you tend to hit with your needle the center or the follicle center, you will get predominance of immunoblast, centrocyte, and centroblast. This case turned out to be DLBCL. So you are actually right. But when you get, you have to see the entire thing into picture. You do need radiology if you get a mixed cell type aspirate. So aspirate from lymphoid follicle center can mimic NHL, high grade. So this is a pitfall. So these are my references. The take home messages: thyroid FNA is challenging. There are multiple potential diagnostic pitfalls. I have not covered all of them. So there are multiple more. For example, abundant colloid, don't call it category 2 till the ultrasound also is suggestive of a colloid nodule. And awareness of these pitfalls, along with careful attention to cytological, clinical, and ultrasound features, as well as use of ancillary studies, can help in reducing errors, as well as giving a better Bethesda classification and a guide to the clinicians of how to manage the patient. Thank you.
Any questions from the audience regarding the cases that we have discussed? Yeah, please.
Since it's a very interesting topic, and I'd like to discuss 2 more conditions which could have probably people can see in their practices, and it often causes a diagnostic pitfall. One is cystic PTC being diagnosed as a follicular nodule. It happens commonly because in that scenario, what happens is that the individual lying atypical cell, it imbibes colloid, and sometimes it starts giving an impression of macrophages. So thinking about means taking a history, a rapidly increasing nodule or a nodule with a shorter history would help in such a situation. And if there is a situation in which there is a long-term progressive increase, then our thinking perspective might change. Second scenario is many a time lymphocytic thyroiditis or Hashimoto's thyroiditis can be misdiagnosed as Hürthle cell neoplasm, because sometimes prominent Hürthle cell nodules tend to develop, and if I maybe hit that position, and then we tend to get more than 75% cells. So again, that is one of the pitfalls that can be seen. Another thing that I would like to mention is that seeing the background picture of the cell is also quite important. When you tend to see different types of cell, for example, macrophages are there, a small cluster of Hürthle cell is there. Apart from that, there is a lot of cellularity with papilloid fragment. Then instead of thinking it of maybe as a category 4, somewhere in the mind, adenomatous colloid nodule should be there. So, and nuclear grooving, what I think is not a confirmatory feature of a PTC. Presence of a number of inclusion is a definitive help, but in nuclear grooving can be seen in benign conditions like colloid nodule. It can be seen in neoplastic benign conditions like follicular adenoma and manium.
Inclusions, many artifacts can look like inclusion, which has to be kept in mind.
So the color of the inclusion matter. If the color of the inclusion is similar to the cytoplasm that we are seeing, then possibly it could help in saying us that it is a true pseudo inclusion.
So this is a picture from one of our
Thank you
cases,
so much
and I loved
for
it.
adding so many pitfalls. Enjoyed that. I think anybody else want to ask something? Yes, please.
Dr. Shipra, very good cases.
Thank you.
The last case, did this patient have enlarged lymph nodes also, the lymphoma?
No. He didn't have lymph nodes. It was a primary thyroid DLBCL, yes.
And did they take a core biopsy from the thyroid?
After this, yes. So when we called it category 3, I went back to the clinician and they reviewed it, and they did subject the patient to a true-cut biopsy.
Yeah, thyroid is the only organ where a core biopsy is taken when an anaplastic is suspected and when a lymphoma is suspected.
Very true.
So thank you, Dr. Shipra, for such an interactive session, and I think it is beneficial for our residents as well as the faculty present here. Thank you so much.
Thank you. And I'm sure all the pitfalls can be sorted out by molecular, which ma'am is going to cover, Dr. Radhika. Thank you.
Thank you so much, Dr. Shipra ma'am, for clearing our concept. It will definitely help us in future.
Moving the session ahead, I am very delighted to invite our chairperson of talk entitled as Molecular and Ancillary Techniques in Endocrine Organ Cytology, Professor Arvind Rajvanshi sir from the Department of Pathology. He is Executive Director of AIIMS Raebareli.
And Professor Ramnath Rao sir from Department of Pathology, SGP-JIMS. He has more than 80 national and international publications.
To kindly come upon this dais.
I request Dr. Advait Advanchi sir, kindly please introduce our speaker of this session, Dr. Radhika Srinivasan ma'am.
Professor Radhika Srinivasan is a head of the Department of Psychology and Gynecological Pathology at PIH Underground. Her main areas of interest are psychopathology, gynecological pathology, and molecular pathology. She is a member of various professional bodies like American Association for Cancer Research, Indian Association of Cancer Research, Indian Association of Gynecologic Oncology. She has many achievements and awards. National Talent Search Examination for Merit Certificate and Scholarship, Mysore Medical College Silver Jubilee Prize, Commonwealth Scholarship Award, multiple national and international publications. I invite Dr. Radhika to deliver the talk.
Thank you so much, sir. It's really an honor to be giving the talk in the presence of our teacher, Professor Rajvanshi. At the very outset, I'd like to thank Dr. Manoj Jain, Dr. Vinita for inviting me to this meeting, and also the IAPID executive, Dr. Kuto, Dr. Rini Malik, and Dr. Anita. Thank you for at least including cytopathology as a couple of talks at least in this large meeting on endocrine. And so wherever applicable, I think we should be also included because it's part of the practice of pathology, I would say. And actually, when I said yes to Dr. Manoj Jain about 4-5 months ago, he just told me thyroid ka molecular aap cover kar denge. I said okay, I'll cover it. So I kept on thinking that all I have to do is to talk on thyroid molecular stuff. But 2 weeks ago, when I actually saw the letter and saw what is the topic, the flyer assigned to me, it said endocrine organ cytopathology, molecular and ancillary techniques. And that gave me a lot of, kind of a shock. And how I said, how can I cover this in the next half an hour or 40 minutes? So all I can do is sirf jhalak dikha sakte, ek trailer de sakte. Movie abhi baki hai. So with that,
so this is what it is. I'll just stick to mostly the thyroid, briefly touch upon pancreas, adrenals, and of course only the neoplastic lesions. We all know this ancillary technique is IHC, and we had this beautiful talk in the morning about hormone-specific, the role in pituitary, but that goes for a lot of endocrine organs. But we know we have the broad markers, chromogranin, synoptophysin, of course, ionism-1, and I have blocked that NSE. That is something so many people use, but that is so non-specific, that it is best if it is not there in your panel at all. Please stop. If anyone's using NSC, please stop using it. So of course, pancreas, we have EUS or transabdominal, and you have the DDs of a pancreatic sol, and we'll look at some examples of NETs. So yeah, even in pituitary adenomas, we saw that you stopped calling adenoma. It's now on the era of NETs, that is the neuronet or the neuroendocrine tumors.
And these are some of the general cytopathological features of NET. All of us know this. I don't have to tell this to this audience: dispersed population, anisonucleosis, some binucleation, salt and pepper chromatin, plasmacytoid cells, granulation. Sometimes you can find also this kind of amyloid-like material. You also can have very cellular aspirates, nice loose aggregates like that, forming these so-called pseudo-SNR pattern, and of course with a fine chromatin. So just like you have in histopathology, organoid patterns, festoons, trabeculae, etc., you have very well-defined cytopathological features of NET that is so you can diagnose with a great degree of accuracy. But yes, like I said, ancillary techniques is what I have to talk about. So here was a small pancreatic sol, 1.6 into 1 centimeters. And this was what we had. We had a nice cell block with us, and we applied chromogranin. And of course, we also do a Ki67. So unlike in histopathology, where you would go do mitotic counting, we find Ki67 very helpful, but you should have a very nice cellular cell block. You should have good fragments. You should be able to, count a good number of nuclei, at least 500 nuclei. And then, of course, you can give the Ki67 index. And this was one low Ki67, less than 2% or whatever. So it was in the grade 1 NET. So here is another case which is very common in clinical practice. So instead of the primary, you get liver metastasis. Again, no problem in calling a neuroendocrine tumor based on morphology there. But we had again a cell block. And then, of course, we applied the chromosynapto. And here, in this case, the Ki67 was, something around 8% that gave us a diagnosis of grade 2 NET. Subsequently, of course, a primary was detected in the pancreas. So this was there, metastatic NET in the liver. Here is another case of a pancreatic sol. Of course, now this is compared to the previous two, is showing you high-grade features. Okay. Obviously, no problem. You have high NC ratio, very coarse chromatin, this kind of, crushed artifacts, nuclear molding. So absolutely no problem in calling this, or even on morphology, as a small cell neuroendocrine carcinoma. But just to show you and to complete the picture, this was positive for the neuroendocrine markers, chromogranin and synapto. Cytokeratin showed this kind of a dot-like positivity, which comes in NETs. And of course, it was having a very, very high Ki67 index. So this was, again, in the liver sol, of course, primary in the pancreas, small cell neuroendocrine carcinoma metastasis. So this is another case, EUSFNE, pancreatic sol, obviously neuroendocrine tumor there. And just to show you that in this case, which applied INSM1 on the cell block. So this is, again, a very good marker if you have less material. And there are some papers, I think, from AIMS in the context of lung NETs, that you could also do this INSM1 on smears. If you didn't have a cell block, it's better to do an INSM1 on the smear and show that it is of neuroendocrine origin. Now, this was another case which we were very confident on morphology that this is a neuroendocrine tumor. It had all the features that I described to you. But this is what the cell block, it showed something funny. We were seeing some sort of a nice acini, some strips like this. And this was what, there was a bit of desmoplastic fragment or whatever in the cell block that said there's something odd for an NET. And when we did the immunos, it turned out to be an acinar cell carcinoma, negative for chromosynapto and positive for CK719, and the specific marker that is trypsin, and also BCL10 is another marker which you could also apply. And another DD is the pseudopapillary tumor with this Chinese letter pattern. And of course, you have these individual cells can simulate an NET, but this is a publication from our department, and we have positivity in the cell block for vimentin, PR, CD10, and nucleocytoplasmic beta-catenin, which gives you the confirmation that you are dealing with a solid pseudopapillary tumor of the pancreas, which is a close mimic of pancreatic NETs. So with this, we move on to a couple of adrenal lesions. Again, this is, like I said, just to complete the topic assigned to me. A case of adrenal pheo, normally you don't want to put a needle if it's a proven pheochromocytoma, but sometimes the radiology in the clinical picture can be equivocal and you can get these aspirates. You have this typical, dispersed population or loose aggregates, some perivascular arrangement, syncytial kind of arrangement, abundant kind of cytoplasmic granulation. And so this was a straightforward case. But here was a case of a patient of men too, and he had a proven MTC, medullary thyroid carcinoma and pheochromocytoma, presented with a liver sol. It had a metastasis, and this is the morphology there. So any guesses from where is this metastasis from? From MTC or from pheochromocytoma? Anybody? MTC, you think because of this fine pink granulation, but that can also be seen in a pheo. So it's very difficult in this situation, and that is where making a cell block is so important. I mean, at least in our department, since the days of Sir also, we have always done a cell block for more than 2 decades, I think almost now, that whenever we do an FNAC, almost invariably there's an accompanying cell block. And I think our success rate as far as cell blocks are concerned from FNAs, we haven't really gone and looked at it, but generally I can say to the extent of 80 to 85%, we get decent cell blocks and quite cellular ones in more than 50% of the cases. So here we had the cell block, and again, it was negative for thyrocalcitonin. So this was proven to be a metastasis from the pheochromocytoma. It was so important from the clinical management perspective. And again, just to complete the picture, like I said, this was a case of an aspirate from an adrenocortical carcinoma, dispersed population of cells, very large cells with the anisonucleosis, bubbly cytoplasm. You can have the differential diagnosis of a renal cell carcinoma, a metastasis into the adrenals, and also a pheochromocytoma. But again, a cell block would solve the problems, negative for the RCC markers, positive here for inhibin, and you can give a confident diagnosis of adrenocortical carcinoma. So with this, we move on to the thyroid, which is the most important focus, I think, of this talk. We discussed a lot of thyroid, whole of yesterday, a lot of histopathology of the thyroid. But actually, we put in the needle first, isn't it? We provide the pre-surgical diagnosis as cytopathologists. Unless we do the FNAC and give a report, the surgeon is not going to take out the thyroid for the histopathologist to see. So sometimes I thought, okay, this cytopathology talk should come before histo, but then, there's another side to it, that you can't interpret cytopathology unless you know the histopathology well. So it's only with a background knowledge of histopathology that you can actually go and interpret. So I think it's very appropriate that we came later after the histopathologists have done their job. So here it is. So we know that it's a well-established technique for the pre-surgical diagnosis, and it helps triage the patient appropriately. So our job is to tell them, is it neoplastic? Is it non-neoplastic? Second is in neoplastic lesions, of course, if it is benign, they will do a certain type of surgery, lobectomy. If it's malignant, it's a total thyroidectomy. But very important is this distinction from non-neoplastic and neoplastic, because in non-neoplastic, the patient could just be observed, or sometimes for other reasons, they may still go and operate the patient. And then came this, the Bethesda system. All of us are talking about it, of course. It's almost 12-year-old. The first edition came in 2017. The revision has come in 2017. We know the 6 diagnostic categories, and Shipra did a wonderful job of showing the diagnostic challenges and the pitfalls. But just remember that in spite of all the challenges and all the pitfalls, we have a wonderful diagnostic accuracy. Otherwise, it would not have stood the test of time. FNA thyroid has stood the test of time, which means that its diagnostic accuracy is quite high, well over 80% would be. So the pitfalls are actually in, the 10%, 8 to 10% of the cases where you can have both false negative and false positive diagnosis. So we have all this category 1 to 6, and we know that what is very important for us to understand is the risk of malignancy. Okay, we know that from CAT 2 to 3, 4, 5, 6, the risk of malignancy increases. And there's also, depending on the risk of malignancy, you have the concern management, which could be just follow-up for a CAT 2. For CAT 3, we have different options, which is repeat FNA, we'll see later. For CAT 4, it is lobectomy, and for CAT 5 and 6, it could be near total thyroidectomy. And this is the biggest challenge, which Shipra covered a lot of CAT 3 cases, which we used to call as OS/FLUS. And then in the revised Bethesda, they said call it OS and tell it. And this really represents the major challenge in thyroid FNA cytodiagnosis. And this was our paper when we estimated our risk of malignancy and risk of neoplasia in overall and also in the Bethesda indeterminate categories. This was published way back in 2017. And of course, even at that time, we had said that this was before the actual Bethesda actually made that recommendation of subcategorization of AUS. We said that you could subcategorize them, and I'll show you pictures of the same. So for example, this was OS-NOS, this was OS-Hürthle cell type, okay, it had a predominance of Hürthle cells, and we always, at the time of reporting, we used to tell the differential diagnosis could be Hürthle cell hyperplasia in the context of lymphocytic thyroiditis. Hürthle cell neoplasm is not excluded. So we would put this in our reports, you see. That is very important rather than simply, telling OS, HC and things like that. And then I still like this FLUS, FLUS. Because why you want to call OS architectural ATP? I know that the Bethesda has gone and made this change, but personally, I mean, our clinicians and even I personally like FLUS. It's a follicular lesion. Of course, you can have differential diagnosis. This is what we would call it as FLUS. That is FH, favor hyperplasia, because it has all these kind of, resorption vacuoles, fire flare, etc. Here is a FLUS of the HC type and Hürthle cell type. And then here is a FLUS where, it had microfollicles, incomplete features of PTC, PTC not excluded. So this is how we were practicing, and we continue to do this also, although we do follow the Bethesda. And when we look at the indeterminate thyroid nodule, it represents together category 3, 4, and 5. Together are called the indeterminate thyroid nodule. So in our study, it was, there was a time trend. Over time, we saw a slight increase in the number of these indeterminate thyroid nodules, but generally it's around 8 to 10% of all thyroid FNA. And if you look at the atypical, that is only the CAT 3, this is in blue, it was hovering around 5% of all aspirates in the year 2015. Maybe it has slightly increased now because of the increased usage of ultrasound, and we're getting more and more ultrasound guided FNAs from smaller and smaller thyroid nodules, and that can increase your AUS rates actually. And I draw your attention to this very nice meta-analysis by Shipra. The Indian experience of OS+ is different from the rest of Asia and the West, a systematic review and meta-analysis. And this is a very nice analysis, and it has compared 18 Indian studies, 12 Asian, and 30 Western. Now, we are always, we are deluged by data from the West, actually, that most of us stop seeing Indian data and stop seeing even data in the rest of the world, like Japan and Australia, etc. Also, they have their own figures. And this is where I would say you need to do these kind of studies, systematic reviews, meta-analysis. And what the bottom line that was drawn from this study was that the pooled prevalence rate was somewhere around 7.3%. The pooled estimates of AUS was around 7.3%, which is not different from India and also the other regions. But the risk of malignancy was very high in the Asian countries and lowest in the West. So the risk of malignancy in the West is somewhere around 25 or 26%. In our case, in PGI study, it was 50%. And in Asia, something around 45%. Now, why does this change happen? The risk of malignancy is different. It can be different in your own center. So you need to do your own analysis. Institutional analysis has to be carried out before you kind of know how should the surgeon. Now, the surgeon is not going to operate each minute you write a category 3 report. The surgeon is not going to operate. So they're going to have some other parameters, and then so they themselves will select certain cases for
surgical, either a lobectomy or something they would select. So there is a kind of a selection bias, but we really haven't gone into the details of what makes the surgeon do a lobectomy when we send out a report of AUS, but that is again an evolving field. So if we come to the Bethesda 2017, they went, if you look at the indeterminate categories, you can see that you have 3 options. You do a repeat FNA, you do a molecular testing, or you do a lobectomy. Category 4, you do molecular testing, and of course, they have said for category 5, nothing at all. The surgeon can go and operate. But just yesterday, while the session was going on, I had signed out one report as category 5. The patient turned out to be a VIP or whatever. And the surgeon calls me and says, Dr. Radhika, can you please review this slide? You have called it out as category 5, and I can't operate if it's category 5. I said, look here, the Bethesda says you can operate, and I have my limitations. I call it category 5 when there's something that's forcing me to call it 5. I wouldn't have. I would have been very happy to have all the material to call it a frank papillary thyroid carcinoma, but there was some limitation, which is why I put it into category 5, and we do cross consultation. We show it to others in the department, and this was a consensus. But that is where the dilemma comes, that not every surgeon would go and even operate. In our institution, they want a category 6 report before this. And thyroid I started giving me a lecture on the complications of thyroidectomy, lifelong L-toxin, hypoparathyroidism, etc., etc. I said, I'm fully aware of all that, Dr. Saab, but you see, I have my limitations. But then that's how it goes, So, but look at this. So you can go repeat FNA or a molecular testing. So let's look at the ancillary technique to improve our diagnostic accuracy. So we have, of course, immunocytochemistry, like I said, we have molecular testing, but this is our real thing that we need as pathologists to understand thyroid imaging or thyroids. In fact, now, when a patient walks into, when we do palpation guided FNACs in most of the cases, and a proportion goes for ultrasound guided FNACs. But irrespective of the fact that even if you're doing the palpation guided FNA, you must ask the patient, ultrasound hua hai? 90% would have had an ultrasound with them. Please check the report of the ultrasound and note down the points. You need to have some basic knowledge of that. And of course, in molecular testing, we'll look at all these in greater detail. And I'll show you a bit of a thyroid IHC there. So this is the thyroid scoring. They will give up 0, 1, 2 scoring, cystic, solid, cystic, echogenicity, anechoic, hyperechoic, hypoechoic, and very hypoechoic. Then we have shape, taller than wider, wider than taller than wider, of course, is significant. The margins, and also they give a score, and thyroids 1 to 5, and then of course what is benign, and of course 4 and 5 are highly suspicious. So this is how it is. So they will do an FNA in 3, 4, and 5, and this is the risk of malignancy based on the thyroid score. So I think your first important ancillary investigation in thyroid is ultrasonography. That is the message I want to give. Please look at the ultrasound yourself and start looking at, just don't simply see thyroids kya hai. Read the report. See if there's macrocalcification. What's the vascularity? Is it hypoechoic? Then your antenna should be up. Okay. So this is very important. I don't have time to show you all ultrasound images because that's not the theme of this talk, but that's very important. Look at what about IHC for thyroid lesions? Should we do a cell block in all cases when there is suspected thyroid neoplasia? Well, I'd say its big role is in the detection of metastasis from well-differentiated thyroid carcinoma. And as far as its role in primary thyroid neoplasms, let me just show you the data, whether it's useful in this context of diagnosis, is it useful in the context of predictive markers. Here is again a very, very recent case, just signed out a couple of days ago, 68-year-old lady, and she comes with this frontotemporal lesion, a lytic lesion was detected. And this was the FNAC that was done from this lytic lesion. And actually, according to somehow from the radiology, I don't know why, but they had written on the form query meningioma. Okay, so, but this is what we had it, and it was all epithelial looking. The cytopathologist reported simply as a neoplastic lesion. It was not further categorized, and a biopsy was then taken from this lesion. And I think the histopathologist had no problem whatsoever in calling it what?
Yeah, it's got nice, you see, macro follicles, not necessarily micro follicles. And we have Dr. Bishan also here in the audience. We have Uma. Yes,
Would you, maybe they signed it out as metastatic follicular carcinoma only, but yes, of course, again, the clinicians force you to do IHC, even though the morphology is so classical. It was, of course, positive for TTF1 and thyroglobulin and all that. So then it came up, they did a further workup, they found these, this is the nodule in the right lobe of the thyroid. Can you see the arrow? Yeah. And so when they did this ultrasonography, they now have this nice nodule in the thyroid, well circumscribed, few hypoechoic internal areas, taller than wider. Then they said it is Thyroids 5. And this is the needle in the lesion, ultrasound guided FNA done. And so then we look back, and in fact, this patient had had 2 previous FNACs from the thyroid, and both had been reported by us only as category 3. And why? Because of this technical reason, diluted, aspirate was diluted, there were low cellularity, and then somewhere we saw a few microfollicles there, so not very conclusive. So it was, and rest of the history was not known, that whatever was not known. And we did have for some reason, a cell block had also been taken at that time, but nothing had been done further. So then came the current FNA, which was absolutely cellular. And this was done by the senior resident, Dr. Eljiva, who is a former resident of SGPGI. You can be very proud of her. And then she had beautiful smears, and it was obviously obvious to us, it's a follicular neoplasm. Now, the classic teaching is in category 4 follicular neoplasm, cytology cannot differentiate between follicular adenoma versus carcinoma because you need to demonstrate all that invasion, etc., etc. But here you have a patient with a metastasis, so there's no problem in calling this follicular carcinoma. So when retrospectively we went back to our cell block, which we had just signed out as neoplasm, and that showed positivity for TG. And the reason I think that follicular carcinoma was missed, in fact, we have a lot of cases where we have diagnosed metastatic follicular carcinoma, metastasis from the thyroid, but here somehow the microfollicles did not predominate. The smear was a little paucicellular, technically not a very great aspirate. That's why we had missed the case, but it was positive. We could have picked it up retrospectively. Here's another neoplasm of the thyroid. So again, another maybe, what would you call it? I don't know. So it had some follicles, some grooving, some dispersed cells, maybe query inclusion. Is it PTC? Is it a follicular neoplasm? Is it query MPC? So any guesses? It's not fair to ask the audience to guess on a single image, but this is what it is. It came out positive for thyrocalcitonin. So sometimes, doing IHC and having a cell block in a case of a neoplastic lesion does help you resolve the case. We had a study, again, this was a thesis of my student nearly 5-6 years ago, where we looked at thyroid FNA cell blocks, and we looked at 3 markers, galectin-3, HbME1, and we did not look at CK19, but that is the third marker that people use in the context of thyroid primary neoplasms. So just to show you that they can show concordant staining, this is discordance, but sometimes this is also concordant negative, this is concordant positive in a case of PTC, and this is sometimes GAL3 comes and HbME is negative. So this is what we saw. And then just to show you some cases, this was a case of AUS. Now, currently, you can call it as Psi-A, cytological atypia, where PTC is not excluded. So it came out positive, and follow-up histopathology confirmed it to be a PTC. So very nice, very happy, both of that worked. Here was a case which we thought it was a follicular variant of PTC, which came negative on, both the immunostains, and turned out to be an FV PTC, I think. This was one. So basically, there have been, if you go back into literature and look at, there are a lot of Italian studies which show very high sensitivity and specificity for IHC using these markers, but this could not be corroborated in many centers, and this is definitely not be acceptable now because of low sensitivity and specificity in the context of intermediate
thyroid nodules. In a frank case, it may help you. So, but ISC is useful. I've already shown you all these two situations. And what about BRAF? V600E positivity, is it useful? Well, we know this is the mutant, ISC for mutant BRAF clone V1, widely now used by all histopathologists. And it shows an excellent concordance with the mutational status in PTC. So basically, as far as histopath sections post-surgery, it is really good. You can use it as a surrogate marker for, the BRAF V600E. But when it comes to cytological specimens, this is one study. So we haven't done actual detailed study. Sometimes we have used it, but it can have problems. Then in this particular study, they found that the sensitivity and specificity of this IHC for this mutation was only 77%, and specificity was also low as compared to a higher sensitivity in CND samples. So it's in FNA samples, it's of limited value compared to molecular testing. But again, that's probably not the last word. That's one study. So with this, I will spend the next few minutes on molecular testing in thyroid FNA. And I just put this especially for the residents. So molecular testing, you can go and read this very nice review article there. And so this, you have to understand that everything, all the mutations are in this MAP kinase cascade pathway. So here you have the growth factor and the receptor tyrosine kinase, the red PTC here, which triggers RAS, RAF, BRAF, MET, and ERK, and which regulate gene expression, leading to uncontrolled cellular proliferation, increased cell survival, invasion and metastasis. And we have the PIT AKT pathway also, which is triggered on by RAS. And then also here comes the role of PTEN as a tumor suppressor gene, which is in turn regulated by PAX8 PPAR gamma. So you have the red PTC gene fusions there, which affect here. At this point, you have the PAX8 PPAR gamma. Here you have the RAS and BRAF, which have the activating oncogenic mutations. But what is the frequency of mutation in thyroid neoplasms? BRAF, again, it differs. If you look at some Korean studies, the mutation frequency is nearly 80-85%. But in general, this is the rate, 40 to 45%. Is the BRAF positivity, red PTC 10 to 20%, and RAS in about 10 to 20% of the cases. So what are the platforms available for molecular testing? So one is ThyroSeq NGS. And so basically this incorporating the new information obtained through TCGA, the Cancer Genome Atlas, the NGS for this thyroid nodules was devised. And it uses both DNA and RNA based next generation sequencing, 112 genes, looks for everything, point mutations, indels, gene fusions, and all that. So these are the genes, BRAF, RAS, TERT, DICER1, NTRK1, BRAF, RET fusions, excellent. And in the FNA validation set, the sensitivity was 98%, specificity 81% with a very high accuracy. And what is very impressive about ThyroSeq version 3, the latest version, is that it can work with input nucleic acids as low as 2.5 nanograms, but it needs at least a 12% concentration of tumor cells. Then we have the next platform, which is the Afirma gene expression classifier and the gene sequencing class for GEC and GSC. This was developed through an iterative process to have a high sensitivity and a high NPV, because what they wanted to do was to distinguish between the benign, the non-neoplastic from the neoplastic. So they wanted a high NPV. So this was developed to potentially decrease the rate of diagnostic surgeries in the case of indeterminate nodules and nodules diagnosed benign on cytology. So, therefore, this again has had a decent result. And this is just to show you, taken from this paper, of course, in how you can have informed clinical decision making from a single FNA sample. The Afirma really helps. For example, this particular nodule got classified as a neoplastic nodule by using this Afirma platform. So then we have the third kid on the block is microRNA profiling. There again, you have these companies which have come up with Thyra-Mir and Rosetta GX. And the Thyra-Mir again has a very high sensitivity and specificity. But if you look at the Rosetta GX renal assay, what is its UPS is that it uses these stained FNAC smears from where the RNA is extracted. It measures 24 microRNAs, and the assay performance, they say in this may vary based on the accuracy of the histopathology results as well. So I was reading one of the papers of this Rosetta GX, and they said that based on the results of this, they went back and got a revised diagnosis of histopathology from the upon expert review. So this can also happen, something that has been called out maybe in routine by a routine surgical pathologist as follicular adenoma may on expert review turn out to be, follicular variant of PTC and so on and so on, or an IFP. So these are all follicular pattern lesions we all know is a problem, and so much of time has been devoted on them. So how does one interpret diagnostic test accuracy? I just want you people also to have this concept that when we are talking of PPVs and NPVs, it is important for you to know the institutional prevalence of cancers. So if you're in a region which has a high prevalence of thyroid cancer, your PPV will be high. Okay, but if the prevalence is low, then your PPV can be low. So basically, you see the formulas for PPV and NPV also incorporate prevalence. So that is very important as a concept. And as a general rule, we know that when you increase the sensitivity, that tends to reduce specificity and vice versa. The second concept that Dr. Neeraj yesterday in the panel discussion she made was this concept of what is a rule-in test, what is a rule-out test. Rule-in means the patient, if the test comes positive, you are ruling it in, patient can be taken up for surgery, for the appropriate surgery, lobectomy or whatever. Rule out means it's most likely benign. You are ruling out surgery. So this, again, when you read articles, this is what you see, rule-in test, rule-out test. And this, again, from this very nice review article published in Cancer 2018. So they looked at the sensitivity. So you see the specificity. So this is rule-in. If you want a rule-in, you want a high PPV and a high specificity. And if you look at that, Afama fails here. Rosetta is very not average, but this Thyroseq and Thyramir have very good, this is 92%, this is somewhere around 80% specificity, and the PPV 68%, something like 77%. And this is an old article by in 2011 published, the so-called 7-gene mutational panel, but now they don't talk about it anymore. Now, if you look at rule-out testing, that is where your Afirma actually performs well with a high sensitivity and a high negative predictive value, but these also perform equally well, that is Thyramir and Thyroseq. So if you look at these two are having good rule-in as well as good rule-out. Afirma is a good rule-out test. So if you look at BRAF mutations in thyroid cancer, sir, how much time do I have now? If you can, 5 more minutes. So if you look at BRAF mutations, we know that it's V600E. I've also said, besides that, you also have the K601E mutation. Point mutations are most common. The clinical implications are that it's a specific marker of PTC because BRAF is not seen in other mutation types, of course, with the exception of anaplastic and some poorly differentiated thyroid cancers, which take the BRAF pathway, so it's seen in about 10 to 20% of these cancers, indicating that it's an early event in tumorigenesis. Prognostic implications, again, yesterday in the panel discussion, is a marker of poor prognosis, extrathyroidal extension, advanced stage, lymph nodal metastasis. Even in T1 carcinomas, BRAF is strongly associated with lymph node mets and extrathyroidal extension. So if you detect BRAF preoperatively in the FNA samples, the surgeon can plan a more extensive surgery, a closer follow-up, and probably can also predict for radioiodine resistance, and so on and so forth. As far as RAS gene mutations are concerned, this is the percentages, but remember that RAS mutation comes up in both adenomas and carcinomas. It marks neoplasia, but not malignancies. As far as third gene mutations are concerned, we discussed this yesterday again in the panel discussion there. TERT genes are always associated with unfavorable outcomes. Now, there in one of the recent studies, they have found that it is, I think there's been a meta-analysis again. They've been found in about 7 to 22% of PTCs and 14 to 17% of FTC, but it's much higher in the dedifferentiated thyroid cancers. Essentially, TERT mutations are an independent predictor of disease-free survival and mortality. So that is where TERT stands. Now, this is another study from the Koreans, actually, where they looked at the prevalence of TERT mutations, and again, they were correlating it to aggressive histological type, poorly differentiated thyroid cancers, anaplastic thyroid cancers, and actually, these are 2-point mutations, C250T and C228T. Individual, this is more common, but they did not find a significant difference in their population. So very quickly, what should be the sample for molecular testing? Directly collected sample, you have cell block, you have smears. Each of them have their advantages. Here in a directly collected sample, it's ideal, but the cellularity and adequacy can never be assured. Cell blocks is from thyroid, you can get it to work even in the best of hands in 40-50% of the cases. In indeterminate thyroid nodules, you'll hardly find any material in the cell block. Smears are excellent, cellularity and representation is assured, excellent for DNA-based assays, but it's okay for RNA-based assays. This is just what we do, cell scrapes, we take it in an epidoff. Similarly, cell blocks can be taken, and then you do the QIAGEN simple protocol. This was the DNA yield in all our cases. When we compared a direct sample to the cell scrapes, obviously the cell scrapes had a higher median level, nearly 2-fold increase in the DNA extracted, and of course of excellent quality. So this is, again, I've already talked to you about this, so we will skip the slide. So I'll quickly take you through the preliminary, the publication we have on this endogen thyroid mutation kit 5-gene assay, RAF, RAS, NRAS, and HRAS. Remember that in thyroid, when we're talking of RAS mutations, it's NRAS and HRAS, which are more common, and not KRAS. KRAS is very, very uncommon. So this is what the whole setup is, simple real-time PCR, and you read out against the internal controls, which are the WIC, and you have, this is the test, which is the FAM. So sometimes you can get problems when you have all internal controls may not work. You have this, something going up and down. You can't, this is an uninterpretable test. Sometimes you get a low rise, which is not good at all. I'll just show you a few cases. Typical case of papillary thyroid carcinoma, nice BRAF positivity there. Again, another case of PTC, BRAF positive there. Here is a case of follicular lesion. It was category 3. We got a very nice NRAS, and then it turned out to be a follicular adenoma there. Here was in a lymph nodal metastasis. So this was, all mutations were negative, and this turned out to be FVPTC. So it doesn't help you in all cases. So you should know the limitations of the test as well. And then, of course, here was an FVPTC. We suspected, of course, but BRAF was nicely positive in this. And of course, this was a follicular carcinoma, which was put into category 4, follicular neoplasm, which showed us HRAS positivity and turned out to be a follicular carcinoma. So here was another case, which was an FVPTC, which showed NRAS positivity there. And here was a poorly differentiated carcinoma, which was NRAS positive. So this is the publication we got from this, which is published in the Journal of Cytology. My just appeal to you is you must also quote Indian studies, which are there and which have got out some data like this. Of course, this was a single center. It had limitations in small number of cases, but this was a pilot study, and this is the first study from FNA samples. So then we have shown it that we have used cytoscrapes, and basically this was the mutational profile. We could see it in nearly 55% BRAF and NRAS in 26 and 23% of the cases respectively. When you look at OS plus, NRAS turns out to be the most common mutation in the category 3. And in category 4, you had both a few HRAS and a few NRAS coming up there. And so also in category 5. And so this is the composite pie chart in the indeterminate category, 24 cases, where NRAS was seen in 30% of the cases, followed by HRAS and also BRAF. So I'll not, I don't have time for that, but especially just to conclude that we had a positive predictive value and a specificity of 80%, making it a good ruling test, but our negative predictive value was only 57% because we were only using a 5-gene very simple assay. So that we have to, of course, go beyond that. But what we really showed was you can use these cell scrapes to do this test. And this is a very easily performed test. And even in nodal metastasis of PTC and in PTC, of course, BRAF mutations came up. And in the indeterminate category, the PPV of 80% made this a good ruling test. Now the Introgen has come up with a 7-gene assay, which also includes these fusions, and that can improve the diagnostic sensitivity, but then you will also have to standardize the extraction of RNA from smears, or you could do it on a directly collected sample. And we are moving forward, and this is the latest that is coming up, detection of BRAF in droplet digital PCR. This will be a real game changer because it is, again, droplet digital is very, very easy to do. And here is another paper which has combined TERT and BRAF mutational profiling using droplet digital PCRs. And that is going to be a revolution. And as I can see into the future, that's going to come into our practice. With this, thank you very much for giving me this opportunity. And I'll take questions.
Any quick question or comment? Very quick. Yes, Cipra.
My parents work with 22 and we have started with both the thyroids.
Yeah.
Sure.
Indeterminate nodule.
Yeah, of course. So have you tried these mutations in both models and compared the proven malignancy versus borderline disease, right? That's what we did. So there were only 24 cases. There was a lot of variations. Yeah, I think I'm kind of going to detail. But 24 were the total indeterminate thyroid nodules, plus 4 is 5. I think out of that, I think category 3 were relatively but histopathological confirmations are available only in 4 of them. Because not every section is not available. So you really need to work on that aspect. In fact, only data from multiple centers, go back and if you do a retrospective analysis, you don't have directly connected samples, you have to use the appropriate centers and then very illustrative and very
Okay, thank you very much,
Thank you, sir.
Radhika, for your nice presentation. Thank you very much.
Thank you so much, Professor Radhika ma'am, for enlightening us and sharing your deep knowledge on molecular testing. Last but not the least, part of this session is case presentation. For that, I would like to take this opportunity to invite our chairperson, Professor Pradyuman Singh sir from Department of Pathology, RML, IMS, Lucknow. Professor Didi Malik ma'am, she is the head of Department of GMC Bhopal. Dr. Rashmi Chaturvedi, she is a pathologist at Cancer Institute, Lucknow. I request to Professor Chanchal ma'am to kindly present a few interesting cases. She is a professor at KJMU, Lucknow.
नीचे का स्क्रीन दिखी नहीं
Should I start? Good afternoon, everyone. Today I would be discussing one case. It's a very interesting case on thyroid pathology, and it was diagnostically quite challenging for us also. So this is a case of an 18 years old female. She presented with an anterior neck swelling, which was progressively and painlessly increasing in size for 1 year. It was moving with deglutation during examination, so means it was from thyroid. It was not associated with any compressive symptoms, and there was no significant family history. This girl also had a history of medulloblastoma, which was treated 5 years back with multiple cycles of chemotherapy and radiotherapy. Her investigations, biochemical investigations were largely normal except for a deranged TFT, that is, she had mild to moderately elevated TSH, that is, had hypothyroidism. CT scan was performed, and on CT scan, the thyroid gland was bulky, and the entire thyroid gland, including both the lobe and isthmus, was studded with multiple nodular lesions. Although the capsule was intact, there was no extrathyroidal extension, as well as no lymphadenopathy, neither cervical or superior mediastinal. Unfortunately, we didn't have the FNAC smears of this patient because she underwent FNAC outside, and it was reported as papillary thyroid carcinoma. And the features based on which this diagnosis was given was high cellularity, presence of papilloid fragments with nuclear grooving and occasional inclusions. So with these findings, she came to the Department of Endocrine Surgery, and based on the history and the FNE finding, a total thyroidectomy was planned and with bilateral central lymph node dissections. And the specimen was sent to our department in KGMU. So grossly, the entire thyroid gland, the bilateral lobe as well as isthmus, correlated with the CT findings, that is, there were multiple grayish-white solid nodules, which were unencapsulated with ill-defined borders at places. It was involving almost whole of the thyroid parenchyma. Some of the normal thyroid tissue was identified at the periphery. There was no gross extrathyroidal extension, and a parathyroid gland was also identified, which was later reported as a parathyroid adenoma. So just to make this session a little interactive, I would be showing the pictures of the histopathology slides, and I would really love to have your inputs on that. And slowly and steadily, we will proceed toward the diagnosis. So this is a scanner view of this case, or low power view. And as you can see, there is a largely well-demarcated growth with some normal thyroid which is seen at the periphery. This is the tumor part, and this is the normal thyroid parenchyma part. The interface is not well defined, but it is largely well defined with some irregularity. And at low power, we can see that it has some sort of cribriform pattern and some microcystic pattern as well. This is a higher power view, which shows a predominant cribriform pattern. And we can see that there are multiple nodules which are separated by fibrotic septa or fibrotic stroma with some lymphocytic infiltration focally at places. This is again a higher power view to give a better idea of what the cells were looking like. And this picture is basically for the nuclear features. Now, based on these features, we can see that the nuclei are vesicular and they are having a prominent single centrally placed nucleolus, which is quite often seen in almost all the nuclei. Grooving was prominent, and at places some pseudo inclusion like appearance was also there, maybe like this and something like this. There was no extrathyroidal extension on pathological evaluation also, and both the lymph nodes, there were 2 central compartment lymph nodes along with the specimen, and both of them were negative. So I would request to please give your opinion about that based on the histomorphological features. What do you think could be the probable diagnosis or the differential diagnosis in this case? Anyone? Yes, ma'am. So the initial thing that came into my mind was cribriform morula variant of PTC. Since the patient was quite poor and was not able to pay for higher investigations, this case was actually initially reported as cribriform morula variant of PTC only. But some time back, I got an invitation to collaborate in an international project where they were studying a specific type of neoplasm, and this case remained at the back of my mind, and therefore I investigated, used some panels afterward when it was initially diagnosed, maybe 1 or 2, 3 years later. So these are the immunohistochemical pictures. Now, this was a surprise that this tumor was thyroglobulin negative. It was negative for TTF1. CK19 was also negative, and EMA was also negative. So this was the IHC itself was a shock. Proper controls were there. The normal thyroid was positive for thyroglobulin and TTF1. The Ki67 index was lower, means it was less than 5%. So it has had a low proliferative index. So now again, the same question. What could be the probable diagnosis, or what is the next thing that pops in mind? So further IHC panel was performed, and this was the panel which I went for, thinking about the prominent cribriform pattern and microcystic pattern. And to my surprise, these markers came out to be positive. The tumor was strongly positive for mammoglobin. S100 was also positive, and there was patchy positivity for PAX8. So based on these histomorphological and immunohistochemical findings, these everything finally went in correlation with mammary analog secretory carcinoma thyroid, which is a recently recognized entity. It was identified in salivary gland in 2015, but it was only after 2017 that it was documented in thyroid gland. So it is a very rare tumor to be present in thyroid. So FISH analysis was also done to confirm it. And I collaborated with Dr. Shipra, and this investigation was performed in AIIMS for this patient, and this is the FISH picture. Now again, this is the second surprise that we received on FISH. An ETV6 anti-RK3 fusion probe was used. So we were assuming that we would be seeing a lot of yellow signals because we were expecting this fusion to be present in this particular case, because mammary analog secretory carcinomas are associated with this translocation and genetic abnormality in almost all the documented cases. So, but in this case, we saw 2 separate green and 2 separate red signal. So there was no fusion of ATV6 and NTRK3. So based on these findings, I did a lot of literature search to justify that how it could be explained. All these things can be put together. Finally, I found some literature which I would be sharing with you. And I consider it to be as a mammary analog secretory carcinoma thyroid without classical ETV6 anti-RK3 fusion. When I was undergoing the literature search, many cases are documented. In fact, series are there of 3 cases, 4 cases, where ETV6 gene can have a different fusion partner. Most of the time, it is NTRK3, which is now considered to be a diagnostic genetic abnormality in this tumor. But in series, it was documented that it can pair with NTRK1, NTRK2 commonly. And there are few cases reported, 3-4 cases reported in which the fusion partner has not been identified. And they are being reported as ETV6 gene X fusion cases. So the histomorphological finding, pathology, IHC findings, and the molecular, the FISH findings can be explained by putting it under this category. The patient is still in follow-up. She has not developed any recurrence or lymphadenopathy, and she's in a perfectly fine and healthy situation. So a little bit about this rare tumor. It is a rare salivary gland tumor. It was first described in 2015. But was more talked about after 2017 when it came in the WHO Blue Book. In thyroid, less than 10 cases have been documented so far. Usually it involves middle-aged females, usually in an age range of 36 to 74 years. And this tumor should always be suspected whenever there is a presence of microcystic and cribriform pattern, especially when the nuclear features are not entirely that of PTC, means a lot of nuclear clearing is not there and a conspicuous nucleoli with some cytoplasmic vacuolization or vacuolated cytoplasm is seen. The origin of these tumors is debated, and some think that it is a primary thyroid tumor from ectopic salivary gland remnant, which are present either intra or perithyroidally. Some suggest that it could be metastasis from an occult primary salivary gland and breast tumors. In the present case, salivary gland and breast were normal. And some suggest that it may have the same origin as papillary thyroid cancer because some MASCs can coexist with PTC and can share some molecular alterations. So case reports like this are also available. It is important to diagnose this entity and subtype this tumor group because it has an aggressive course and is usually, not always, but usually insensitive to radioiodine. So it won't be of much use of subjecting a female patient, especially in a fertility age group, to expose her to a radioiodine treatment. So it is important to diagnose it. It can, in fact, undergo dissemination and can lead to fertility, and recurrence is also very frequent. The current WHO has included a separate category in thyroid classification as salivary gland type tumors in thyroid. And these are the essential and desirable criteria which are considered at present, that they have a characteristic morphology with mammoglobin S100 positivity and absence of thyroid differentiation and ETV6 translocation. So these were the two main studies which I came across. The first study is by Ito et al., in which they documented 2 cases in which they were not able to identify the second partner for ETV6 gene fusion. And the other study is by Skalova et al., both during 2015 and 16. This is a series in which they did molecular analysis of 25 cases, and out of that they found 4 cases that harbored ETV6X and X gene fusion. And there were 2 cases in which they found the supporting partner to be NTRK1 and 2. Now, since we don't have the probe for NTRK1 and 2, so that has not been evaluated, but this is an unusual case, not only in terms of a rare entity, but also in terms of absence of the classical genetic abnormality, which we intended to document. Thank you.
So, very interesting case, Dr. Chanchal.
Thank you, sir.
So, can we have a discussion on this at the moment, or should we take the questions at the end? Dr. Vineet, any comments or questions at the moment?
Very interesting. The lesson learned is that if you have a real baby with a type of tumor in the thyroid, please go for IHC first and not happy, then go for
Right, truly said.
Yes,
So that
ma'am.
was the
PTF should always be done whenever there is such a situation. And apart from cribriform marula, which is now, in fact, in new WHO is no more considered a variant of PTC also. So it can be another thing that could be thought of. Thank you, sir.
All right, thank you so much.
So another lesson is that you keep on following in your question mark cases. Otherwise, if she wouldn't have had followed this case after so many years, ye sara hota hi nahi. Congratulate. I really congratulate you.
Thank you so much, Dr. Chanchal ma'am, for this interesting case. Now I request Dr. Nidima. She is a senior resident at SCPGI and present an interesting case. There are some questions. We will take questions after this case presentation. Good afternoon to all. I'm presenting an interesting case with a strong family history. This is a case of 42-year-old male businessman by occupation, resident of Lucknow. The patient presented with the burning pain in abdomen since 4 to 5 years and paroxysmal raise of blood pressure. And no significant history like fever, nausea, vomiting, or any abdominal stria or facial hair. An outside patient consult and then ultrasound abdomen showed bilateral solid cystic suprarenal mass with the central areas of necrosis, and probably it was adenoma or pheochromocytoma. Spot urine metanephrine were raised, however, spot plasma and metanephrines and normetanephrines were within a normal range. This is a family history of the patient. So our patient, 41-year-old male, was diagnosed as a MEN 2A, and his 2 of the daughter also diagnosed as a MEN 2A. And the patient sibling also had a history of MEN 2A, and his wife was diagnosed with breast carcinoma with a BRCA1 mutation, and his daughter also had a BRCA1 mutation. And the patient's grandfather also had a history of blood cancer. On general examination, patient was conscious, alert, and cooperative, and vitals were within the normal range. And neck examination showed a nodule in the left side of the thyroid. For abdominal examination, so no significant organomegaly, and neck examination showed a left side thyroid nodule. After that, patient investigated in the SGPGI, and his urine metanephrines and normetanephrines were raised more than 10 times. CT abdomen showed a bilateral, well circumscribed
mass. This is the left side mass measured around 10 by 8 centimeter, and this is the left side suprarenal mass measured 5 by 5 centimeter. The ultrasound ultrasound of the thyroid. So the bilateral thyroid nodules and thyroid spore. CECT neck showed bilateral neck nodules also. Then we did the FNAC from the bilateral thyroid nodule. This is a FNA smears of the thyroid nodule. The smears are moderately cellular and showed atypical cells. This is a clusters of atypical cells. This is further high power view. Here we can appreciate these clusters are dispersed and showed the moderately pleomorphic cells, which are plasmacytoid in appearance and showing dispersed chromatin and moderate amount of the cytoplasm. So the FNAC from the thyroid nodule was reported as suspicious for medullary thyroid carcinoma, Bethesda category 5. The DOTA neck scan of the abdomen and neck also showed the nodules. This is the neck nodule measured 1.5 by 1 centimeter with the avid uptakes, and this is the abdominal mass. This is the right. This is the left side mass, and this is the right side mass. Also showed uptake in the lesion, and the biochemical parameters were significantly raised. The calcitonin, serum parathyroid, and PTH and CA also raised significantly. However, serum calcium and vitamin D within the normal limit. Technetium 99 also showed the cold nodules in both lobe of the thyroid, likely medullary thyroid carcinoma. After that genetic testing, patient showed the RET mutation also. And after that, patient operated and we received 2 labeled specimen of the adrenal. This is the low power view. Here we can appreciate the tumor morphology of the adrenal. This is a capsule and the tumor cells. Tumor cells are arranged in the nest. This is high power view. Here we can appreciate the tumor cells are arranged in the nest. We can call this is gel ball and pattern. These nests are separated by thin fibrovascular septate. This is a reticulin stain. This also highlights the these gel ball and pattern of the tumor cells. This is a further high power view. Here we can appreciate the individual tumor cell morphology. Tumor cells are moderately pleomorphic and occasional bizarre large nucleus also appreciated. This is another area of the tumor. Here we can appreciate occasional mitosis and bizarre cells. So the bilateral adrenal was reported as a pheochromocytoma, and the PAS score in the left side of the adrenal was scored 1. After that, received cervical lymph nodes for the frozen sections, cervical lymph node and level 2 lymph nodes. This is a frozen section of the cervical lymph node, show the tumor infiltration. And this is the paraffin section of the same frozen section. We can appreciate the loss of architecture of the lymph node. And the high power view, here we can appreciate that the lymph node showed the tumor infiltration by these tumor cells. The tumor cells are showing a moderate pleomorphic nucleus with the dispersed chromatin and moderate amount of eosinophilic cytoplasm. Along with the areas of these eosinophilic, congophilic deposits, and which highlighted on the Congo red stain on polarized microscopy. Here we can appreciate this apple green birefringence. So this was reported as metastatic medullary thyroid carcinoma. After that, received the total thyroidectomy, CCLND, SLND, and inferior parathyroid. This section from the thyroid nodule, this is a normal part of the thyroid, and this is the tumor. Here we can appreciate this infiltrating tumor. The tumor cells are arranged in the nest. This is hyper view. Here you can appreciate the tumor cell morphology. Tumor cells are showing minimal pleomorphism with the round to oval nucleus and prominent nucleoli with dispersed chromatin and a moderate amount of the cytoplasm. This is the oil immersion view. Here we can appreciate the individual cell morphology and this congophilic deposits. This is another area of the normal part of the thyroid. Here we can appreciate the C cell hyperplasia, the clusters of C cell in the normal part. And this is another area. Here we can appreciate these C cell hyperplasia with the transform into the tumor. And this is section from the CCLND lymph node showing the effaced architecture and tumor infiltration in the lymph node. This is this is section from another lymph node showing multiple granulomas also. Section from the parathyroid showing the compressed part of normal parathyroid, and this this is a hyperplasia of the parathyroid. This is hyper view of the same. So finally, this was reported as medullary thyroid carcinoma with C cell hyperplasia. CCLND lymph node showing metastasis. SLND lymph nodes also showing metastasis of the medullary thyroid carcinoma. And right SLND lymph node showing medullary thyroid carcinoma along with granuloma. And inferior parathyroid was reported as parathyroid adenoma. So now coming on the discussion part of the this case, this was a MEN 2A, the case of MEN 2A. And the patient has a strong family history of MEN 2A, and patient is also has a carcinoma medullary thyroid, pheochromocytoma, and parathyroid adenoma. Any questions? I have time to discuss this or any? Should I discuss?
So very interesting cases, and men cases always have the spectrum of lesions that it can present. Can pose an enigma and also challenging range of findings that can come across. Any comments or questions to the presenter?
Ma'am. Yes, ma'am. PPT. This is our patient, and this is sibling of the patient. Patient sibling also have the same tumors, bilateral pheochromocytoma and medullary thyroid carcinoma. And both of the daughters diagnosed as a MEN 2A, but no operative procedure was done. And patients, this sibling and his wife was diagnosed as a BRCA1 mutation with breast carcinoma. Yes, sir. Yes, yes. Regular follow. Thank you. Ma'am, because C-cell hyperplasia is generally associated with the syndromic medullary thyroid carcinoma. Yes.
If there is prophylactic thyroid, then it is important. Children, for example, that may show you only C-cell hyperplasia and not that.
So there is no mention of the diagnosis of the two daughters. What was their diagnosis? No operative procedures, yeah. Thank you so much. Who is the next presenter?
Ma'am, that's all. That's all. ma'am.
Yeah, please.
Yes, ma'am. Ma'am, we have only two presenters. Thank you so much for both the presentation and thank you so much to our honorable chairperson for this insightful session. We have two questions for Dr. Chanchal ma'am. It's in the chat box. What was the beta catenin stain in this case? Is 100 is positive. It's not like memory analog secretory carcinoma. And it's in the chat box.
Yeah. Okay. Beta catenin was not done in this case and S100 was positive. But it was positive in the tumor cell, although it was not that full-fledged positivity in the entire tumor cells. But what positivity of S100 was there was definitely in the tumor cells. Beta catenin was not done. But the other findings, especially mammoglobin, positivity and negativity of TTF1 and thyroglobulin. These are the three main markers that would be able to differentiate it from others, differential diagnosis.
Okay, ma'am. Thank you, ma'am.
Is there any more case presentation?
No, ma'am. We
Yes,
are.
So we'll thank you for the very beautiful two cases which has been presented here. And I would specially say for the second one, they have presented with a very beautiful radiological pictures. That was quite nice.
And thank you everyone for sharing your knowledge with us. And it will be a great pleasure to listen you in the future, in our future events.
Now it's time for a lunch break. We would like to request all our respected delegates. Lunch is waiting for you outside.
After that, Dr. Rishabh and Dr. Shikha will resume the session at 2 p.m.
Thank
you,
you.
everyone.
ये है पहले सर का ही होगा ना, अमित अग्रवाल सर का। ठीक है अभी तुम पढ़ने लगो उसको मोबाइल देखा करो, वीडियो नहीं चला तो तुम मोबाइल इसमें
Good afternoon, delegates. We'll be starting the post-lunch session now. I take privilege to invite honorable chairpersons for the next session titled Diagnostic Workup for Adrenal Lesion. I invite Dr. Ish Bhatia sir and Dr. Pratik Mehrotra sir to the dais. Dr. Ish Bhatia sir, Professor and Head of Department of Endocrinology in SGPGI. Sir has multiple national and international publications.
Dr. Pratik Mehrotra. He's a senior consultant surgeon, Department of Endocrinology in Sahara Multi-Specialty Hospital. His areas of interest are thyroid and parathyroid disease, adrenal tumors, diabetic foot disease, and breast cancer. And he has multiple national and international publications and few book chapters as well. We now request Dr. Ish Bhatia to please introduce the speaker.
Dr. Amit Agarwal has come.
He'll be online, sir.
Oh, he's going to be online.
Yes, sir.
Okay. Great. Okay, well, welcome to this session. And I, along with Dr. Pratik Mehrotra, who I know very well, will be the chairman for this session, and Dr. Amit Agarwal, who is the professor and head of endocrine surgery at SCPGI. He's going to give the talk on evaluation of adrenal lesions. And Dr. Amit Agarwal is an excellent surgeon, especially, and he's done lots of adrenal surgery, and he has many achievements, numerous publications, and he's fellow of the Royal College of Surgeons of England, and he's a member of the National Academy of Medical Sciences. So I request Dr. Amit Agarwal to start the talk, please. Thank you.
Good afternoon, ladies and gentlemen. At the outset, I'd like to thank the organizers of the Department of Pathology for organizing such a wonderful endopathology symposium. And I'm sure this will be of great benefit to both the endocrine surgeons and the pathologists. So let me share my screen. The task that has been given to me today is to talk and share with you about the diagnostic workup in adrenal lesions. Now, adrenal lesions mostly present as an adrenal incidentoma, like many other endocrine organs. And as per definition, they are clinically inapparent adrenal masses, which are inadvertently detected during a non-invasive imaging studies, particularly a CT scan, which have been conducted for reasons and symptoms other than for the evaluation of adrenal glands. Now, why is it important that we talk about adrenal lesions, particularly adrenal incidentlomas? Now, these lesions may be hormone secreting, but they may be silent without any symptoms. For example, a normotensive pheochromocytoma, and you have a time bomb sitting there, which can burst anytime or during any other unrelated surgery. Similarly, a steroid-producing adenoma can be potentially harmful, even though there are no symptoms overtly present in the patient. Other important concern is that they may be harboring malignancy, and it is very difficult to predict whether a particular lesion is going to be malignant. Though size and Hounsfield unit are the criteria, which help the clinician to predict malignancy to a certain extent, and I will come to this later in my talk. There are a couple of controversies surrounding the management of adrenal lesions, whether one should operate on all adrenal lesions or should a conservative management be followed in selected cases. Is there any benefit of adrenalectomy, particularly in patients who have subtle symptoms like a subclinical steroid-producing adenoma? And what should be the follow-up protocol once these patients have been either operated or put on conservative regime? And I'll touch upon these controversies in later in my talk. Now, one should remember that the majority of these adrenal lesions are non-secretory. And in one study, it was found that 85% of these lesions were non-secretory, followed by subclinical Cushing syndrome, pheochromocytoma, and aldosterone-producing adenoma. Now, this is a slightly older slide. I mean, it's almost 2 decades now. But recent studies and even one of our own studies have shown that amongst adrenal incidentomas, which are hormone producing but silent, pheochromocytoma is the commonest. And in our studies, in fact, it was around more than 40% cases of adrenal incidentomas were actually pheochromocytoma. You can see the importance of workup of an adrenal lesions for hormonal production, even though they are silent. And imagine if these pheochromocytomas were missed or patients were operated for other unrelated conditions, they would have a hypertensive crisis during surgery. Now, most of these lesions may be non-functioning and indolent and asymptomatic and may not cause harm to the patient. But as I mentioned, the high proportion of these tumors will be subclinically functioning and they may be potentially harmful to the patient. So I'm overemphasizing this point for the benefit of the listeners. Initially the fear was that we may not miss any malignancy in an adrenal lesion, but now there is more fear of missing a subtle function, which is potentially harmful to the patient rather than missing malignancy. And I would say, in fact, both of these reasons are important to work up adrenal lesion. Now, what is the endocrine workup which we normally do in our practice is that, first of all, as a general principle, the adrenal incidentomas should be screened for adrenal catecholamines, all adrenal lesions, except recent data has shown that in cases which have a low Hounsfield unit, for example, -40, -50, where the CT diagnosis of myelolipoma can be made, you can exclude doing an adrenal catecholamine estimation. And again, patient having overt glucocorticoid excess symptoms and signs, one can exclude doing adrenal catecholamine. But in my practice, I'll probably do catecholamine or metanephrine estimation for almost all adrenal lesions. Now, any patient who has hypertension or hypokalemia, of course, mineralocorticoid excess should be excluded. Similarly, any patient of adrenal lesion along with hirsutism or valorization should be suspected of either androgen producing or estrogen producing or even mixed cortisol androgen producing, which is a hallmark of a malignant lesion. Now, a couple of points specific to specific adrenal lesions. Screening for primary aldosteronism, one should remember that hypertension and hypokalemia are the major classical clinical findings. And then whenever you get them in the context of an adrenal lesion, they should prompt the clinician to carry out appropriate screening investigations. But remember that PA is associated with low plasma renin activity because the aldosterone-induced hypervolemia results in suppression of the renin release. Now, why should we work up a lesion which is suspected of aldosteronism? Because there is a high chances of stroke, coronary artery disease, fibrillation, heart failure, and even mortality when you compare to matched population with essential hypertension. So there is no doubt to my mind that all lesions where you suspect a primary hyperaldosteronism, they should be worked up and managed, either treated or surgically or medically. So the diagnosis of PA is important and requires either surgical excision or a targeted antihypertensive therapy with mineralocorticoid receptor antagonists. Now, although I'm aware that this is not a topic for the to talk about in detail about the workup, hormonal workup, but it will be interesting to know that there is a 3-step approach for the screening, confirmation, and subtype classification for a lesion suspected of primary hyperandrogenemia. Now, the most reliable means for screening is the aldosterone-renin ratio, whereas a lot of confirmatory tests available, but in my practice, my endocrinologist would do a oral sodium or even a saline infusion test. But fluorocortisone suppression test and capillary challenges tests are just mentioned, but not routinely carried out. The third aspect is how to confirm that whether it's a tumorous PA amenable to surgery or it is a bilateral hyperplasia where medical treatment is a treatment of choice. And for subtyping, I commonly use a CT scan, which is helpful in majority of cases, and sometimes MRI. But AVS is a very informative investigation, though it is invasive. But in patients who have a CT scan which is equivocal or shows a bilateral lesion, AVS or adrenal venous sampling is a very good investigation, though it requires a certain level of expertise and is done in specific major centers such as SGPG. And of course, the new kid on the block is the metomidate positron emission computed CT scan, which is quite helpful in picking up the adrenal or bilateral disease. Third lesion is usually the sex hormones or sex steroid secreting adrenal lesions, and they may be either androgen producing or they may be estrogen producing. So in women, if there's androgen secreting tumor, there may be features of virilization, such as excessive facial hair growth, skin changes, whereas estrogen secreting tumors in women will cause breast tenderness, irregular uterine bleeding, whereas in men, the estrogen secreting tumors may cause feminization, such as decreased libido, testicular atrophy, and gynecomastia. And once your patient presents with these features, the estimation of sex hormones or 17-hydroxyprogesterone is the investigation choice. Now, to summarize, for screening, we have to exclude a cortisol-producing adenoma by a low-dose dexamethasone suppression test, a pheochromocytoma by a serum plasma metanephrine or a 24-hour metanephrine and non-metanephrine. For PA, we have to do either a plasma aldosterone-renin activity or ratio, which is as a good screening test. And if ACC is suspected, you can do a DHEAS or a low-dose dexamethasone suppression, and I will detail it in my subsequent slides. Coming to pheochromocytoma, it's always a question that is asked, which is better, a plasma-free metanephrine or a urinary metanephrine, non-metanephrine. In my practice over the last 25 years, our endocrinologists are very happy with urinary fractionated metanephrine, non-metanephrine, which gives excellent results. But the plasma-free metanephrine is of course found to be more sensitive as compared to the urinary metanephrines, but it's quite expensive, not easily available. We don't do it. But I found that it is useful in hereditary syndromes as compared to the sporadic ones. So when I get a hereditary, I like to do a plasma metanephrine, whereas in the rest of the cases, I would like to do a urinary metanephrine, non-metanephrine estimation. Hypertension is the commonest sign of pheochromocytoma, but remember 30% of pheochromocytomas can be normotensive, silent, and they can be easily missed. Now coming to another very interesting entity is a subclinical Cushing syndrome, and it is important to consider because they are potentially harmful. It's an ill-defined condition of altered HPA axis, the hypothalamus pituitary adrenal axis, in patients who do not have classical signs and symptoms of overt or apparent Cushing syndrome. And in recent years, it has become a topic of increasing interest in controversy. Now, this is because the diagnostic criteria are very heterogeneous and varied among the studies, and there are no specific signs for overt CS. So the commonest studies is the ONDST test, and failure to suppress cortisol secretion is considered mandatory out of the majority of these studies, but it is a cutoff point for a pathological EST, which is sort of an issue of discussion and controversy, and it can range from 50 to 138, but I'll not dwell a lot. But these are certain studies which I mentioned, which have taken different diagnostic criteria, but most of them would agree that low-dose dexamethasone suppression test or 09 dexamethasone suppression test is useful, but they have taken different cutoffs ranging from sort of 50 to 70, 80, and even not 30. So these are all different cutoffs. But overall, it can be defined by the presence of increased urinary free cortisol. Now, urinary free cortisol is also a very good investigation that most endocrinologists would like to do. And unsuppressed serum cortisol levels after 1 milligram overnight dexamethasone, that is ONDST, low ACTH levels, and of course, no clinical signs of Cushing's syndrome. So these are sort of criteria that are used in different studies, but at least 2 of these should be present to label a patient as subclinical Cushing's syndrome. Again, different cutoffs, 5. And so, you know, if you take a different cutoff, the sensitivity and specificity would vary. And it depends on individual centers to stick to their own cutoffs. So we have talked about why workup of AI is important because the steroid reducing adenoma is harmful and phacocytoma, of course, is a time bomb. Coming to the malignant, how can we predict whether a particular lesion is malignant or not? Oh yes, one more point. There are long-term consequences of subclinical Cushing syndrome because it has been shown that patients may be hypertensive, they become, they have metabolic issues like diabetes, dyslipidemia, obesity, osteoporosis. So much so that there is a distinct impairment of quality of life as shown in different studies. And not only that, there is a certain increased mortality rate if these patients are not managed or operated. So coming to the second important question that we have to answer is that is a particular adrenal lesion malignant or not? Now, 2 factors have been taken over the different studies and over many years, which I also use in my practice, as one of the size of the mass and the other is a radiological finding. And it is conventionally taught that in masses which are more than 6 centimeters, 25% chances of malignancy is there as compared to 0% in masses less than 4 centimeters, but it involves the intermediate 4 to 6 centimeters that is questionable. This was a survey done in Italy, a multicentric study, which showed that the mass size is the most reliable factor in separating benign from malignant, and they took a cutoff of 4 centimeters. But the limit, if you look at these studies closely, you will find that these studies are limited by the fact that in most of these studies, old generation CT has been used, which has less resolution, so we cannot really rely on the exact size cutoff. And in some of the studies, it is not clear whether it was univariate or multivariate analysis. And in fact, interestingly, CT measurement was available only in 1/3 of the patients. And the hormone active lesions are not excluded. So there's a lot of heterogeneity in these studies. And this is compounded by the fact that there are now reports in literature that even adrenal lesions less than 4 centimeters may harbor malignancy. So certainly, definitely we need something more than the sizes alone to predict malignancy. And there comes the role of sort of these imaging studies where the Hounsfield unit is measured, and it has been shown that this is a very good criteria to predict malignancy. So 2 types of Hounsfield units are measured. This can only be done in real time. Most of our patients bring CTs out from outside where Hounsfield unit has not been calculated. So we have to ask for a repeat CT scan because the Hounsfield unit can be calculated only on real time and not retrospectively. So unenhanced values calculated as well as delayed enhanced is calculated. I mean, malignancies, if the delayed enhanced CT value is more than 30 or unenhanced CT is more than 20, then it is suggestive of malignancy. And there is a sensitivity of 95, but specificity of 100%. Now you can see there's a lesion on the right side top. It's a case of adrenocortical carcinoma, which had a unenhanced CT value more than 20, whereas the below picture shows a large myelolipoma, which is around 12 centimeters, but the CT Hounsfield unit were minus 40, so it was a diagnosis of myelolipoma. Again, just how to calculate, I'm not going into detail, but this is a formula where absolute washout is calculated, which is equal to enhanced minus delayed divided by enhanced minus unenhanced. And if the this delayed washout is less than 50%, because it is thought that if it's a malignant process, the cells are immature and they cannot process the contrast. Whereas if it's a benign adenoma, the cells can rapidly process the contrast, and there will be a washout. So if the washout is more than 50%, the absolute washout, then it is diagnostic of adenoma. Where it is washout is less than 50%, it is diagnostic of malignancy. So although an unenhanced CT scan attenuation value of less than 10 is an excellent predictor of benign histology, but around 1/3 of adenomas are lipid poor, so they will not show a unenhanced CT value less than 10, they will have more. So therefore, and similarly, there are tumors which are less than 4 centimeters, but with Hounsfield unit more than 10, whereas tumors more than 4 centimeters may have Hounsfield unit of 10. So obviously, none of these criteria alone are very sensitive, specific. So the authors from Cleveland Clinic decided to have a combination of the two, where they combined the size with the Hounsfield unit, and they came up with a new stratification algorithm. And they said that if the tumor size is less than 4 centimeters, you give a score of 1, and if more than 6, you give a score of 3. Whereas similar scores are awarded to density less than 10, 10 to 20, and more than 20. And they found that if the score is sort of, they found that 1/3 of patients had a score of 3, another third had score of 4, another third had score of 5 or 6. But interestingly, the incidence of ACC in those patients with a score of 0 was 0%. And the score where Hounsfield unit was more than 20, it was 25%. So obviously, when you combine the size as well as the Hounsfield unit, you have a better sensitivity and specificity. So another advantage with this scoring system or stratification is that those patients with scores of 2 to 4 would have been spared a diagnostic adenectomy because the risk of malignancy is almost 0. Whereas a combination of size less than 4 centimeter and more than 4 centimeters and an attenuation value more than 10 will have 100% specificity to predict a malignancy. So that is how a size and Hounsfield unit together can help the clinician to predict malignancy. Now coming to controversies, the first controversy is there any benefit of laparoscopic adenectomy, particularly in a patient who doesn't have an overt sign of Cushing syndrome, and is a case of subclinical Cushing syndrome. And nowadays, laparoscopic adenectomy is the standard of care, which is rather less invasive. The patient can go home the next day. Surgery takes less time. Potential herniation and all other complications post-operatively in long term are very less. And therefore, there is a tendency that there is a low threshold for adenectomy for patients with subclinical Cushing syndrome. Not only that, it has been shown in this beautiful review by Ecobone from Italy that the patients who were operated subclinical Cushing syndromes, they all had reduction in arterial hypertension, their glucose got better, the lipid metabolism improved, the body mass decreased in obese patients, the osteoporosis improved, and overall they had a good quality of life. So therefore, this cavalier attitude towards adrenal incidentomas should be changed. All adrenal incidentomas have to be taken very seriously, and they should be screened out to rule hypersecretion, whether they are producing cortisol, steroid, or catecholamines in the case of pheochromocytoma, or aldosterone in cases of primary hyperaldosteronism, or estrogen or androgens in cases of sex hormone secreting tumors. The third point is what should be the follow-up protocol for these patients. The American Association of Clinical Endocrinologists or the European Society of Endocrinology usually should be annual follow-up for 5 years, and no repeat hormonal workup is required if the initial workup was normal. Of course, if there is a development of new symptoms, particularly evidence of hormone activity, endocrine activity, then you can repeat the hormonal assessment. Now, this is an algorithm which is, I think, a beautiful algorithm for management of adrenal lesions. If you have an adrenal incidentaloma, the first thing is to do a CT scan and look at the Hounsfield. If the non-contrast CT attenuation value is less than 10, then you go in for hormonal workup to see whether you can rule out a pheochromocytoma. So if it is less than 10, a pheochromocytoma is ruled out. If it is more than 10, then depending on the size, you will do estimation. for the metanephrines for excluding pheochromocytoma. But if the household unit is less than 10, pheo is excluded. You may not do a metanephrine. Just do a 1 milligram dexamethasone suppression test to rule out steroid producing adenoma, and patients with hypertensive do an aldosterone renin ratio. If it is non-functional, no routine follow-up imaging is required. Only hormone evaluation of 5 years only, particularly in tumors which are more than 2.5 centimeters size. If it is functional, of course, you will surgically remove them depending upon the etiology. On the other hand, if the non-contrast CT value is more than 10, and the lesion is less than 4 centimeters, do a DST, metanephrine, and ARR. Again, if it is non-functional, do a percentage washout at 15 minutes to rule out malignancy. If it is less than 50 to 60%, then surgery, because the chance of malignancy is more than 60%, and the size is less than 4 centimeters, I mentioned, then follow-up. On the other hand, in the patient's lesions more than 10 household unit, more than 4 centimeters, again, you do a hormonal workup, including plasma metanephrine, all three have to be done. And of course, surgery is the treatment of choice. So this is the kind of rough algorithm that is followed by most centers with maybe minor changes, but I like to stick to this protocol for managing our adrenal lesions. So ladies and gentlemen, the take-home points could be that the incidence of adrenal lesions, especially adrenal incidentoma, is expected to increase because of the wide availability of cross-sectional imaging. Remember, the commonest pathology of AI is pheochromocytoma and not steroid producing and non-functional. Almost to the 1/3 of your lesions would be pheochromocytoma, very dangerous. So you can understand the importance of ruling out pheochromocytoma. Then the screening is done to rule out steroid producing adenoma as well as the primary hyperaldosteronism. The most important radiological characteristic is a non-contrast CT attenuation value, and this is very important. All clinicians, when they are asked for a radiology, please especially mention for the radiologist to calculate the HU unit. Again, a combination of adrenal size and attenuation value is very important. And if you have a lesion which is less than 4 centimeters with a non-contrast CT attenuation value less than 10 HU, it has 100% specificity for a benign adenoma, and you can follow the algorithm for the follow-up protocol in a conservative HU. Whereas surgery is indicated for more secretory tumors, whether overt or subclinical, and those with radiological features. So overt features, subclinical features, especially subclinical syndromes, subclinical Cushing syndromes, and those with concerning radiological features, they should all be operated, either by laparoscopic adrenalectomy, robotic adrenalectomy, or you can do open adrenalectomy depending on surgeon's experience and the etiology of the tumor. So I hope I was able to share with you some of the important reasons why AI should be worked up very seriously, and they have to be taken very seriously because they have increased serious risk and mortality. Therefore, all clinicians, whether endocrinologists and endocrine surgeons involved in the management, should work up these patients on a set protocol so that we don't miss these potentially harmful adrenal lesions. Thank you, ladies and gentlemen, for patient listening. Thank you.
Thank you, Amit sir, for a comprehensive talk on adrenal lesions and their workup. Do we have any questions from the floor of the house? Any questions? In that case, I would like to make a comment that if you have seen that algorithm, most of the adrenal lesions that are picked up, or if they are presented as adrenal incidentalomas, they are by and large diagnosed on the basis of clinical features, on the basis of radiological features, as Dr. Amit sir has mentioned, and the biochemical parameters. FNAC has a very limited role in the preoperative or the initial workup of such lesions. And upfront, FNAC should only be done once you have ruled out pheochromocytoma by doing urinary catecholamine or urinary VMAs. And they may also, FNAC may also be done when you're suspecting metastatic lesions. Otherwise, by and large, most of the adrenal lesions can be picked up and diagnosed on the basis of radiological features and biochemical features. So would you like to add anything?
Yeah, but I agree with your comment. I can ask Dr. Amit Agarwal, would he operate on all patients with subclinical Cushing's disease, or would he make some differentiation among different types of patients?
Sir has been disconnected due to some technical errors.
Can you say that all patients with subclinical is still a controversy going on, whether all patients with subclinical Cushing's should be operated? Certainly, younger patients and those who have evidence that they have more secretion of cortisol in various, according to different testing, and they should be operated. But sometimes patients, especially elderly patients, it may be more appropriate to just follow those patients. I think Dr. Amit Agarwal is not there, so.
Even the FNAC is not much helpful. Rather, it is contraindicated in these kind of cases, especially the pheochromocytoma. So I would suggest that in this kind of cases where the metanephrines are increased, in that case, it should not be rather attempted.
Absolutely, I totally agree with you, sir. FNAC, the main indication is when you are suspecting infective lesions in terms of histoplasmosis or tuberculosis. Then the role of FNAC comes in. Otherwise, for such lesions, biochemical workup and radiological workup is good enough.
Yeah, I think we can end this session.
Yeah.
End this particular talk.
Not.
I think.
He is not. Are you there? Sir has not been able to join due to few technical errors.
Okay. So in that case, we'll close this session. Thank you for a patient hearing.
Thank you, sirs. Moving ahead, we have a few intriguing clinical pathological case discussions. I take privilege to invite Dr. Preeti Agarwal ma'am and Dr. Gyan Chand sir to the dais for chairing the session. Dr. Preeti Agarwal ma'am is Associate Professor in Department of Pathology, KGMU. Ma'am has interest in neuro-oncology and cytopathology. Dr. Gyan Chand sir is Professor in Department of Endocrine and Breast Surgery, SGPGI, Lucknow, with a special interest in thyroid and endocrine neoplasms. I invite our first speaker, Dr. Sushila Jaiswal ma'am, to the dais.
Good afternoon, everybody. So this case was of 42-year-old female presented with bilateral diminution of vision for last 2 years on examination. Vision or patient was blind on right side, and on left side the visual acuity was 6/36 with left temporal field cut, and no other neurological deficit was identified. Patient was a known case of hypothyroidism for which he was taking Thyronorm and no history of diabetes mellitus, hypertension or any other drug intake. So clinical impression was salivary supracellular mass with a differential diagnosis of pituitary adenoma or craniopharyngioma. So MRI brain showed salivary supracellular mass that was reaching up to lateral foramen minor of lateral ventricle. So the radiological impression was pituitary adenoma. For this, hormonal workup was performed and that was found to be normal. So tumor was excised through endonasal endoscopic transsphenoidal route. Intraoperatively, tumor was reddish, vascular, and intraoperative impression was pituitary adenoma. So the biopsy was taken from that area and it was sent to pathology department, labeling it as A in form of multiple gray-brown soft tissue pieces aggregating 2 ml on microscopy. This is a scanner view showing tumor arranged in sheets, nests, nodules separated by fibrovascular core, and the tumor cells are monomorphous, having round to oval nuclei, fine chromatin, inconspicuous nuclei, and moderate amount of granular cytoplasm with no mitosis. So the histological diagnosis offered was cellular supracellular mass consistent with pituitary adenoma. Approaching the tumors, sphenoid sinus mucosa was found to be abnormally thickened. So this biopsy was taken from that area also, and it was sent, labeling it as B in form of multiple gray-brown soft tissue pieces, altogether measuring 1.5 ml, and microscopy multiple bits were seen, lined by pseudostratified columnar epithelium with underlying granulation tissue, mononuclear inflammatory infiltrate comprising of lymphocytes, plasma cells, and one of the bits showed fungal ball. And on close inspection, this is fungal profile and highlighted by PS and CSN stains. And on close inspection, the fungal hyphae showed parallel walls, acute angle branching, septations. So sphenoid sinus mucosa suggestive of aspergillosis was given. On post-op day 7, the patient's sensorium deteriorated, for which CT head was performed and showed hydrocephalus. CSF sent for examination. So this is the wet preparation of CSF. So any guesses? So this is spondylitis. Patient treated with antifungal and antihelminthics. The patient did not respond and went against medical advice and later succumbed. So now coming to discussion, pituitary adenoma is the third most common intracranial tumor that accounts for 15% of all tumors and 85% of cellular and supracellular region. Pituitary adenoma associated with sphenoid sinus aspergilloma is rare. Seeing literature, few case reports are there, similar to our case. And aspergillosis can occur in invasive and non-invasive forms, and non-invasive forms occurs in immunocompetent individuals, while invasive forms can occur in immunocompromised patients. Our patient was immunocompetent, although workup for immune status had not been performed, and the predisposing factors like diabetes, HIV, or any drug intake were not there, and the patient was not any organ transplant recipient. The fungal ball, which is seen in sphenoid sinus, was just an incidental finding. Similar to aspergillosis, spondylitis can occur in immunocompetent as well as immunocompromised host. In immunocompetent individuals, it remain asymptomatic for years, and in immunocompromised individuals, it may remain there for it may cause life-threatening infection in form of hyperinfection syndrome or disseminated spondylitis, and mortality rate is about 85%, and CNS involvement is rare, and filiform larva found directly in CSF may be seen. So similar to our case, few case reports are there in the literature showing spondylitis in wet preparation of a CSF. So take home message is that concurrent incidence of pituitary adenoma, aspergillosis, and spondylitis is extremely rare. And if although immunocompromised individuals, they are at high risk of fungal and helminthic infections, immunocompetent individual may have. And if there is any doubt of fungal infection intraoperatively in case of pituitary adenoma, surgery should be delayed to avoid life-threatening fungal dissemination. And if one should raise the suspicion of a fungal infection in case of a sphenoid sinus mucosal thickening.
Very interesting case, ma'am. And I would like to say that I still don't believe that this patient will be not immunocompromised. Might be there, he might have some abnormality because he went lama. We can't have any word on that. Secondly, yes, this is true that we should not touch a fungus in a brain surgery if we are doing and we are suspecting fungal infections, but multiple times radiologically they are not picked up. They are picked up on histopathology only.
So this interesting case is open for discussion. Query and comments from the floor.
So this fungus is not invasive. It's just in the nasal tract, sinuses. So why to consider this as for immunocompromised? This is aspergilloma is normally seen in many of the patients.
But sir, having strongylitis,
That's a
fungus and
different thing.
everything, huh?
But I'm
That is when in this particular case.
This
only-
fungal ball is there, that is there lying on a surface of a mucosa. It is not invading anywhere.
But sir, having strongylitis, two things which are not seen in non-immunocompromised in same patient might be कुछ हो इसमें तभी एकदम से rate कर गया वो.
Any other comments?
Thank you.
Thank you, ma'am. Thank you. So next we would like to invite Dr. Pallavi Prasad from SDPGI, and she is going to present some interesting case. Dr. Pallavi, please.
Good afternoon, everyone. So I'm here to present a case on adrenal insufficiency in an elderly male patient. So our patient was a 67-year male who was a known case of diabetes and hypertension for a long duration. And he had been on oral drugs, but he could not continue the drugs for the last 6 months due to multiple episodes of hypoglycemia. As far as the present illness was concerned, he had recurrent hyponatremia, for which he required frequent salt supplementation and Vaptan therapy. So Vaptan is basically a vasopressor receptor agonist. He had symptoms of altered sensorium and drowsiness. He responded to medications, but the complaint kept on recurring every 1 to 2 months. He also complained of excessive fatigue, weakness, weight loss, and loss of appetite. So for the negative history, there was no history of blurring of vision, floaters, pain, numbness, angina, or claudication. However, he had a lacunar infarct 2 years back. Also, there was no history which was suggestive of any other significant abnormality. There was no history of any autoimmune disorder. So before coming to our institute 3 months back, he had an episode of right-sided focal seizures for which he was admitted to a private hospital. And there on workup, on CT scan, he was found to have bilateral adrenal masses along with hyponatremia. Then he was treated as a case of adrenal tuberculosis, was initiated on ATT and prednisolone therapy. And on examination, his vitals were stable. He was well-oriented. There was no pedal edema icterus. And however, his skin showed hyperpigmentation, especially on the oral mucosa. And the respiratory system and these systems were normal. In the neurological examinations, the cerebellar signs were absent, but and also the fine sensations were reduced below the ankle joint. So we proceeded with the lab workup, and he showed the presence of moderate anemia. The viral markers were negative, and the blood glucose levels were elevated. And the significant finding here was presence of hyperkalemia and hyponatremia. The MRI brain showed an old lacunar infarct along with presence of diffuse cerebral atrophy because he was an elderly male. And then as far as the hormonal evaluation was concerned, the cortisol levels were low, that is 20.4. The serum ACTH levels were elevated, and the aldosterone plasma renin activity was markedly reduced. So so with this, we come to the conclusion that he was a case of hypoaldosteronism or adrenal insufficiency. Proceeding further with the workup, like for the causes of adrenal insufficiency, our main motive here is firstly to rule out the causes. So the primary causes, infective etiology, for which microscopy and cultures were done for any infection. Those came out to be negative. And for amyloidosis, the workup was done, which was again negative. So the patient was taken up for adrenal biopsy. This is the image. Here we can see this has been taken up while the patient was undergoing the biopsy. And here bilaterally, we can see that these are heterogeneously enhancing mass lesions present in both sides in the adrenal. And just for comparison, I have put here an image from the internet. Here we can see these are the normal adrenal glands, which normally are seen as just thin strands above the kidneys. So this is the adrenal biopsy which we received. These are the two cores. And one core, as we can see here, comprises predominantly of inflammation. The other core comprises of this tumor. And on higher part, we can very well appreciate there is presence of atypical or malignant glands surrounded by moderate degree of mononuclear inflammation. So this biopsy was diffusely infiltrated by these glands, which are lined by columnar atypical cells. And this is again a higher magnification to show the atypical glands. And the other, similarly, the entire biopsy showed infiltration by this tumor. And this is the mucin stain which we have done, PA stain with mucin, which highlights the intraglandular mucin in these malignant glands. So coming to the diagnosis of adenocarcinoma morphologically, we proceeded with the immunohistochemical panel so as to derive a possible site of origin. So the tumor cells are diffusely positive for CK7, while being negative for CK cytokeratin 20. Again, PTF1 was positive. It showed nuclear positivity in the cells. PSA was done to rule out prostatic origin. And again, SAT-B2, this IHC panel is done to exclude the possibility of colorectal cancers. Then calretinin was done, even though morphologically it did not look like, but just to rule out a remote possibility of adenocortical carcinoma. So calretinin was negative. And so this is the panel which was performed. So we have a histological diagnosis of metastatic adenocarcinoma, and the possible primaries which we indicated were from lung. Following this report, the patient underwent the full body PET scan. And again, as we can see here, these are the bilateral enlarged adrenals. And these are very well showing the FDG uptake in both the sites. And again, since this was a full body scan, so at this time we found out that there was a lesion, and this is an irregular spiculated lesion which is present at the apex of the right lung. And again, this is showing nice uptake by the marker. And then these are a few images which I have retrieved from the nuclear medicine department. So here we can see that the entire chain, starting from top to bottom, this is the chain of lymph nodes which has been involved, all of which are showing uptakes. And this is the confirmed mass lesion, which is our primary in this case. And these are the bilateral adrenals. All of these uptakes have been highlighted well in this MPR scan. So the follow-up of this patient, since he was a case of disseminated disease, so he was initiated with chemotherapy. However, unfortunately, he succumbed within 2 weeks. And so we concluded that it is a case of pulmonary adenocarcinoma with metastasis to bilateral adrenals. The point is that why this case is interesting, because it has adrenal insufficiency as the initial presentation of his illness. So coming to the discussion, majority of the adrenal, what is the adrenal insufficiency? In this, what happens is majority of the adrenal cortex is damaged. As a result, there is deficiency of gluco and mineralocorticoids. And this may be caused by infiltration or destruction of the adrenal cortex. So coming to the causes, it can either be primary or secondary etiology. Primary, wherein the cause lies in the adrenal itself. So as I've already mentioned, either the cause can be infectious or it can be some malignant cause, like either metastasis or lymphoma involving the adrenal. And another rare cause is autoimmune adrenalitis. And also here the secondary causes include those causes which mainly are concerned with the CNS, that is the pituitary or any pituitary infection or pituitary malignancy. This can also be drug induced. And the important point to differentiate is that in case of autoimmune adrenalitis, basically the glands are atrophic on scanning. And whereas in case of infiltrative lesion, we have enlarged masses. So the adrenal metastasis, are the more frequent malignant tumors of the adrenal gland. Usually they occur as a part of disseminated disease. And isolated adrenal metastasis is very, very rare. And various studies have been done, and in which they have mentioned that the most common primaries which they found in their study were those of lung, followed by renal cell carcinoma and melanoma. And the other result was from a larger study, in which they concluded again that the most common site of primary was lung, followed by colorectal and others. A large autopsy study showed that lung cancer metastasized to the adrenal gland in around 35% of cases. And such patients rarely, at times, patients rarely suffer from these symptoms, that is from the pulmonary symptoms. And like in our case also, the patient primarily did not show any pulmonary symptoms, rather he presented with manifestations of adrenal insufficiency. And why adrenal gland is a frequent site for metastasis? The reason being it has a rich sinusoidal blood supply. So our experience regarding this was also a poster presented by a resident yesterday. So in 7 years, we found a total of 266 adrenal lesions, out of which 15 were bilateral. Out of them, 6 were cases of metastasis. Out of 6, in 2 cases, the primary site was in kidney, and 4 cases were those of pulmonary adenocarcinomas. And the treatment can be either in the form of surgical management, whereby we can go for adrenalectomy or locally ablative procedures. In case the disease is widespread, then the patient has to be taken up for chemo or radiotherapy. Also, these are some other modalities. And in those cases in which the disease is localized, then the patient is taken up for adrenalectomy. These patients they'll show improved survival. Whereas in those cases in which the patient cannot be managed well by surgery, still their overall survival is quite poor, and it averages to roughly around a year or so. So coming lastly to the learning points from my case, bilateral, if there is bilateral adrenal enlargement, especially in an elderly patient, we should keep metastasis in our differential diagnosis. Secondly, adrenal insufficiency may at times be the initial and the only manifestation of metastasis. And lastly, and importantly, tissue diagnosis is the key to clinching the correct diagnosis in such cases. So these are all my references. Thank you very much.
Nice case. Even we had reported one lung cancer with adrenal metastasis we have seen recently, but usually they present with lung primary symptoms. This is very interesting that the patient presented with adrenal insufficiency in the first. And usually we see fungal infections or tuberculosis more in our patient population rather than having metastasis as primary bilateral adrenal.
Yes.
Excellent presentation, Dr. Palvi. So case is open for the floor for discussion. Any comments and queries? But yes, sir.
That was a really nice presentation. Actually, this was my patient.
Yes, sir.
And the patient kept on having hyponatremia. He was treated outside for hyponatremia. But when he was diagnosed to have adrenal insufficiency, when he came here, then his hyponatremia improved, but somehow he was not feeling very good still. Mostly patients who have primary adrenal insufficiency, once you treat them with steroids, glucocortisone, etc., they do gain a lot of weight. He gained a little bit of weight, but he and on imaging, his adrenal glands were enlarged. The patient was elderly, and the family members would bring him slowly for testing. Otherwise, I think we could have tested all the things that we did. It just took a long time to do it. So, though he didn't improve, so because he didn't improve fully, so then we wanted to, and the glands were bilaterally enlarged. So mostly glands are bilaterally enlarged, as you have said. We think of infections, sometimes lymphomas, and of course, sometimes adrenal carcinomas also. Metastasis can cause adrenal insufficiency, but it's conventionally believed that more than 90% of adrenal has to be destroyed before adrenal insufficiency sets in. So a little less common in when you have metastasis. So anyways, he underwent finally a biopsy and then we got this diagnosis, which was a surprise. Then the PET scan revealed, unfortunately, that he had a primary in the lung and also multiple other regions where the carcinoma had metastasized. And that is the second thing which was already also pointed out, that normally the primary is evident when you have metastasis to the adrenal glands. It's not very silent that you just have a metastasis, you diagnose there and then you start looking for a primary. It's often quite evident. So those are the two things for this patient. So I think that maybe for me at least the take-home message was that if a patient is having adrenal insufficiency and you treat and he doesn't improve fully within 4 to 6 weeks, then really you should start looking for something else. Maybe he has a other kind of lesion. We have a large series which we are in the process of writing up along with many members of pathology department, about 100 patients with adrenal insufficiency, primary adrenal insufficiency. And in that so one correction I would like to make in your thing is that almost 60% were infected. Adrenal histoplasmosis is quite common in this part of India. Adrenal histoplasmosis is common and little difficult to differentiate from adrenal tuberculosis clinically. Of course, histologically, and when you do the FNAC, you will, or a biopsy, you will know. About 30% or so were autoimmune. So autoimmune is not so uncommon. It's not a rare cause of primary adrenal insufficiency. In Western countries, 90% of adrenal insufficiency, primary adrenal insufficiency, is actually autoimmune. But as tuberculosis has been conquered out there, it has gone down, and tuberculosis, etc. So anyway, this presentation was very nice, and you made a nice presentation. Thanks.
Thank you, sir.
Yeah. Doctor.
Just to add, I had a series of adopting studies I'm talking about, right? And there were 3 in our, so we looked at all homeopathic adrenal lesions and adoption, in which there were 10 cases of diagnostic insufficiency, 6 for tuberculosis, 1 histoplasmosis, 1 lymphoma, 3 cases of adenocarcinoma, and 4 cases. I just wanted to share that.
Yeah.
Yeah, it's so bad. And it's difficult. You're lucky enough to get it up on the special space itself. Yeah, we can get metastasis. So lymphoma is much more common. The bilateral.
Yes, thank you. So most of the time it is usually in metastasis cases, most of the time patients have diagnosis of cancer and they are already finished their cancer treatment, or they are in the follow-up, they have developed modes of metastasis. But in this case, it is presented primarily as a metastasis. So it is definitely surprising. Any other comments and queries? Yeah.
Morphologically, for the definite case of adenocarcinoma, but just trying to find out this unknown primary.
Sir, this patient didn't give you any history related to lung. Not in retrospectively, if you ask.
Was not there, and in fact, he had seizures earlier. Right? Right focal seizures. So we thought maybe something is there. That may have been due to the fact that he had hypotension severe outside. Maybe
but we didn't know anything totally asymptomatic and maybe a surprise and good histopath. I mean, immunohistochemistry was very good in the past patient.
Yeah, definitely, sir. It is very surprising because he has already metastasis to all over the body, especially the bones, multiple bones metastasis. So that might have some pain and backache, something might be there. Yes. So any other comments, queries? So if there is no comments, thank you, Dr. Pallavi. Thank you. Next case.
Next case will be presented by Dr. Nidhi from RML IMS.
Good afternoon. I'm Dr. Nidhi Amin, additional professor, RML IMS, Lucknow. I will be discussing the case of a 19-year-old female with a history of intermittent abdominal pain, hypertension, palpitation, and elevated blood pressure. Admission was performed and sent for histopathological evaluation in January 2022. We received the right endectomy specimen with a weight of 38 grams and size of 7.5 by 5 by 4.5 centimeters. On gross evaluation, it was well circumscribed and with the tan brown appearance. On microscopic picture, we can see the tumor is in the medullary portion of the adrenal and pushing the adrenal cortical tissue towards the periphery. On the further higher power view, it was the appearance was valent with the well-developed vasculature. On the further higher power view, the cells were polygonal in shape with moderate to abundant cytoplasm, eosinophilic cytoplasm, and at focal area there were pleomorphic nuclei. Mitosis was very scant. So the histopathological diagnosis was rendered as adrenal pheochromocytoma. So according to WHO classification, with the this type of morphology, we had with the differential of pheochromocytoma, adrenal cortical carcinoma, and renal cell carcinoma. So for this, we performed the immunohistochemical panel for synaptophysin, chromogranin S100, inhibin, HMB45, and PAX8. So the tumor was beautifully positive for synaptophysin and chromogranin. So the final diagnosis, other markers were negative. So the final diagnosis was given as adrenal pheochromocytoma. For the risk stratification, we performed the pheochromocytoma of the adrenal gland scaled score, that is PAS scoring. So according to this score, the peri-adrenal adipose tissue, more than 3 mitosis, atypical mitosis, necrosis, cellular spindling, nuclear pleomorphism, cellular monotony, and large cellness or diffuse growth, as well as with high cellularity. 2+ score is given in capsule and vascular invasion with hyperchromesia. Score 1+ is given. So the total score of 4 is concerning for malignancy. So in the current case, there was marked pleomorphism. The PAS score 2 was given. Mitosis was less than 10 high power field. So the score was given as 2. The PAS score more than 4 is likely malignant, but the limitation of PAS scoring is the pheochromocytoma histopathology features including the cellularity, cellular pleomorphism, and monotony, no prognostic value. This is applicable only for the pheochromocytomas, and the other histological characteristics like other influencing factors like gene mutation, tumor characteristics, and clinical characteristics of the patients were ignored. In addition, there are too many histological features, inter and intra-observer variability is present. So according to the 2017 endocrine organ, WHO 2017, the term benign and malignant has been replaced by the term metastatic and non-metastatic, and the GAP scoring is introduced. So according to the GAP parameters, in addition to the histopathological parameters, Ki67 labeling index is introduced as well as the catecholamine secretion. So in the current case, the pattern was gel valence, so the score 0 was given. The cellularity was moderate, so score 1 was given. And the Ki labeling index, Ki67 was 2 to 3%, so score 1 was given. So the patient was significantly secreting the normetanephrine levels, urinary normetanephrine levels were significantly high. So catecholamine level was given, score was given as 1. So total score was given as 3. That falls into the category of moderately differentiated. So for the score, risk stratification. So for the risk stratification, the score 0 to 2 is well differentiated and the 5-year survival is 100%. And the score 7 to 10, that is poorly differentiated, the 5-year survival is 22.4%. So pass or gap scoring. Then in 2017, there came the modified gap scoring system. And in 2019, the COP scoring system has came. That is the composite pheochromocytoma paraganglioma prognostic scoring system. And another is the ACCESS score that is came into 2018, that consisted of age, tumor size, extraadrenal location, and the secretory type of the tumor. So for the modified gap scoring, the pseudorosettes, the comedotype necrosis, the vascular invasion, the Ki-67 labeling index, that is more than 1%, and catecholamine type and SDHB stain in IHC negativity is taken into account, and the score more than 3 is considered to be metastatic tumor. So we performed SDHB IHC. So we can see in this microscopic picture the internal control, that is the endothelial cells, has beautifully positive for the SDHB, that retain the SDHB, but the neoplastic cells has lost the SDHB staining. So, and in the lower portion, we have presented the other case, that is SDHB retained. So SDHB, loss of SDHB is seen in about 15% of pheochromocytomas and paraganglioma, 3% of GIST, less than 1% of renal cell carcinoma, and less than 1% of pituitary adenomas. So in the modified gap scoring, the pseudorosette was not present, comedonecrosis was not present, Ki-67 was 2 to 3%, that was score 2. Capsular and vascular invasion was not present, and catecholamine was 2, and SDHB negative staining, that is 2 scoring. So total score was given as 5. So for the COP scoring, focal or confluent necrosis was considered, PS100 staining loss is seen, vascular invasion, SDHB loss, and tumor size more than 7 is considered. So for COP scoring, we reviewed our S100 stain slides, and there was loss of S100 in the sustentacular cells. So score 2 was given. SDHB loss was given as score 1. And tumor size was more than 7 centimeters, that was score 1. So the total COP score was given as score 4. So for different predicting system with their prognostic parameters, so pass score was 2, gap score was 3, modified gap was 5, and COP score was 4. So the according to the European Society of Endocrinology clinical practice guideline for long-term follow-up the patient operated for pheochromocytoma or paraganglioma, there is no single clinical, biochemical or histopathological feature that can distinguish malignant from benign PPGs. The multi-parameter pass score and the reproducibility of the gap score it requires further validation. A metastasis is defined as the presence of chromaffin tissue in location where normally no chromaffin tissue is expected. So another paper in the published in the Cancers, the value of histological algorithm to predict the malignancy potential of pheochromocytoma and abdominal paraganglioma and meta-analysis and the systemic review. According to the authors, they have represented the schematic overview of the pass scoring system and the gap scoring system, and they noted the green square as the benign cases and the orange square as the malignant cases. So the left-hand side of the both the algorithm shows the benign cases and the less than 4 scoring system and score, and in the gap score that left-hand side is the less than 3, that are the benign cases. So in the both algorithm they show the excellent sensitivity but the reduced specificity towards the malignant cases. As we can see in the more than 4 score, we can see the green squares also, and in this gap scoring there is also the green square. So these analyses indicate that low pass and low gap or scores almost always are associated with the benign clinical course. So another study, another paper by the that is the predicting metastatic potential in pheochromocytoma and paraganglioma, a comparison of PAS and GAP scoring system. According to this paper, they found that GAP performed significantly better than PAS in predicting the metastatic potential. The poorly differentiated range was associated with better outcome than a well-differentiated score, and the most effective for the PAS and GAP are the most effective for negative predictive value of a low score. So a rule-out strategy has typically been utilized for both PAS and GAP, as low scores in both systems demonstrate negative predictive value, but higher scores have low specificity for malignant disease, with an advantage over to the GAP over the PAS scoring system. Another paper in the American Journal of Cancer Research, the system of metastatic potential prediction in pheochromocytoma and paraganglioma in 2020. It says that the accuracy rate of metastatic prediction results, that is 66% in PAS, in GAP 69%, and MGAP, that is 53%. But the accuracy rate of non-metastatic prediction, that is 100% in PAS, 96% in GAP, and 91% in MGAP system. So the scoring system have not been validated in multi-center clinical trials and have not been widely accepted by the clinicians. So in PAS score, 12 parameters are utilized, low specificity, only pathological, and in SS, 4 parameters, it has worst sensitivity and lowest metastatic prediction accuracy, only clinical parameters have been used. So this is the TNM staging of the tumor. T1, pheochromocytoma, less than 5 centimeter in greatest dimension, no extraadrenal invasion. T2, pheochromocytoma, 5 centimeter or more than in greatest dimension with or functional paraganglioma with no extraadrenal invasion, and T3, tumor of any size with invasion into the surrounding tissue. So the learning points are, from the pathological point of view, benign versus malignant has been replaced with the non-metastatic versus metastatic for the risk stratification. PAS scoring has been replaced with the GAP scoring or the modified GAP scoring, and TNM staging should be given, and the biochemical test recommended to rule out the catecholamine secreting tumors. Thank you for the listening.
Thank you, Dr. Nidhi, for nice presentation. And this case is open to the floor for discussion. Any query? Yes, sir. Krishnani, sir.
So what is the present recommendation? I think the present recommendation is that you keep on doing, and they are saying that don't do it. Scoring, they have said there is no validity. So presently in 2022 classification, WHO Blue Book, they said, they have still said that don't do scoring system. No scoring system is good or perfect or giving any good information. See, if you see the non-metastatic potential, it is giving 100%. Rest other things, if you say the metastatic potential, hardly 60%, 50%. So ultimately, it has got no benefit. So that is why they have said that don't do a scoring system in adrenal pheochromocytoma. But if you want, you can just note it down. That's all.
Thank you, sir.
Any other comments? Yes, ma'am.
So I would like to ask the surgeon, how many of this likely report so many cases?
Over your experience that you find any metastasis over time. As pathologists, we keep on doing these scores.
So I never do a scoring system PAs. If we do it, 90% of cases are 0 to 1.
Yes, sir.
So it hardly makes any difference till now. And we have never seen any metastasis till now.
Thank you, sir. And thank you, ma'am, for asking this question. Actually, we not only the scoring, we see the entire clinical presentation of the patient and the tumor itself, whether it is extensive large tumor and surrounding structure or if there is R0 resection is there or not. All these things we matter during the surgical, and during the follow-up, we find out if there is any metastasis. And in the tumor which we have find out the metastasis, mostly it was a large tumor, and not the scoring, we have not correlated with the scoring. One publication is from our department that they have correlated, but that was found that it is not very much correlating with the metastasis, although we have checked the pass scoring system.
Yes.
Yes, sir. Thank you, sir.
Like in this patient, in this case, it was SDHP negative, means it was familial type.
Yeah.
So even at times we don't know it is multiple or it's a metastasis or the multiple that can happen. Even we cannot say whether this is metastasis or not metastasis. So even that problem is even not solved many times. Many times we say this is a lymph node completely replacing, but whether it is a lymph node or the paraganglia, we don't know.
Yes.
So in familial cases, even difficult.
Yeah, we have to follow and just taking out the tumor, and finally you will be decide whether it is metastatic or it is another paraganglioma. It is up to your report. We will follow accordingly. Any other comments?
So the next point is that if age is less, like this 19 year, so we should go for VHL, familial, SDSP. All these things should be taken care of first of all.
Yeah, in young patients, we have to follow closely and find out, and also this genetic testing is required. Bhatia sir, any comment for 19-year female with pheochromocytoma?
So my only comment would be that I agree with what he said, that anybody at this young, we should do the genetic testing. It's not only for the patient themselves to participate, but also for the family.
As there is SDS loss that falls in the familial category or the, so we have to follow up the patient by the.
Yeah, we other gene testing is.
Can you do the gene test panel so that it answers the patient type that
Sorry, you did the genetic testing for the.
No, sir. We have performed only the STHP staining.
You did the staining.
Yes, sir. For the MGAP scoring.
But you should give an asterisk and advise that the patient must undergo further testing, gene testing for. There should be a comment on it in the report, I believe, if SDH is negative.
Thank you.
Any other positive comments or any query? So if there is none, thank you, Dr.
Thank you, sir.
Nidhi. Yes, thank you, Dr. Nidhi. So thank you. We've closed this session. Thank you. Over to organizers.
Thank you, sir, ma'am. Now, next is the most awaited session, that is quiz. So I like to invite Dr. Raghavendra L. Sir, Assistant Professor, Department of Pathology, SGPGI, and Dr. Vinita ma'am, Professor, Department of Pathology, for the quiz. Over to you, sir. We request everyone to actively participate in the quiz. Instruction वाली slide. Instruction वाली slide. Photo. हाँ. नहीं डाल.
Thank you very much. So,
how many residents are there in the house? Can you raise your hands? Offline. Oh, good.
so there are a good number of residents. Great. I think online also many residents have joined. So this is basically a revision kind of a session in which after a packed scientific sessions over the last 2 days and moving over the last 2022 updates on endocrine pathology classifications and molecular advances. So basically this quiz is being conducted online. So you can participate through using your mobile phone only. So the link has been circulated in the WhatsApp group and in the Zoom chat. So you just have to click it and you need to name properly as given in the instructions. I can show it online right now. So if you're in Zoom, log in. No. You don't need to be on computer or you don't have to be logged in Zoom. So if you have the link in the WhatsApp, you can click it and yeah. Yeah. So I'll also be joining the quiz, but as a dummy person. Okay. So don't see what I'm marking. It might be wrong. It might be right. I'll be marking 8 for every question at the end of 30th second. Okay. So there is a time gap, time limit of 30 seconds for every question. So for the first round, we have 20 questions. So in 10 minutes, it will get over. And the top 6 registered candidates will be selected. And we will be seeing the leaderboard over there. So there is a number projected on the right side of the screen. So there the leaderboard will be continuously updated for after every question. So and then the 6 selected one candidates will be called on stage, and if a person who is on online or makes it to top 6, so he can participate online also. So there is in the second round there is only 10 questions, and there will be prizes for the final 3 winners.
And all questions are from the sessions which have been held in the past 2 days. So nothing very new.
And there are some here and there some questions, facts or trivias about endocrinology. Yeah, but that doesn't carry any marks. So each question has a weightage of 5 marks, and the software automatically calculates based on the time you have taken to give the correct answer. Not only the correct answer, based on the time also. So it gives a score for each question, and accordingly the leaderboard will fluctuate. Okay. So I'll show you how to join into this thing. After you click this particular link, so as in the instruction I had said, you have to mention the registration code first. So like I'll give myself as 1234 and the last name of mine, and then I'll join. So basically I'll be joining as a dummy. So I'll not be able to take any prizes or go to second round, unfortunately.
So everybody can open it. Click your link. Everybody has been able to open it. Any issues? You are on the login page? Okay.
So after correctly mention your name, so you can customize yourself whether you want music or not. Because so many people are here, so each one mobile phone giving them a background music will be an issue. So I'll continue with the music here, but you can unmute yourself with sound effects and music and names if you like to. So names. So I'll start with
President, can someone go and check any of the resident is outside? Will be called inside. Just give 2 minutes for that.
So even if you press the start button, the PC is not going to start. So I have the master control. It is just जो WhatsApp लिंक है वो आपने क्लिक किया है लिंक WhatsApp में नहीं है there is no link in the WhatsApp or what is it saying? You can do copy pasting or you can go to the website quiz.com and enter the code manually. So once you mention your name, you can join. So on the right side of this thing, I can see there are so many 53 participants are already joined. We can also see in the screen. So we will wait for a few more minutes because the time given was 3:30. And there are 5 more minutes.
So that everybody can announce with the online also if they have any issues, they can put it in the chat.
Yes. So online candidates, if you have any issues, you can put it on the chat box. Yeah, chat box open over. Yes, sir. अच्छा यहाँ notification आ जाएगा. Okay. Someone like she did not mention the registration number. Many like Dr. Gauri, many people. Okay. Okay. So duplication is not allowed. So people can log in from two mobiles and they can participate, but such kind of things are not entertained. That's 58. Everybody can participate in the first round, but only residents are selected in the second round. If full screen करो. Wait करो. So we'll wait a few more minutes. And some people are attending through on YouTube also. So that is no. The session we are attending YouTube, so we will not get to know on Zoom. Yeah. And because even the faculty are attending now. हाँ 74.
So we'll start in another 2 minutes. Sharp at 3:30.
So if you attended the last 2 days, given attention to the slides, the questions are made from those slides only. So it will be pretty easy, I believe. So if there is a tie, then again, we'll have a tiebreaker question or based on the time taken, so we can have. But that is on the second round, probably.
So till now we have 79 participants. We don't know how many of them are faculty, online, offline, so let's see. Including you 79, otherwise 48.
Yes. Later we'll get to know everything. We can see. Start करो. Okay.
We can say we're starting in 1 minute.
कर सकते हैं, it's 3:30.
So now we can start.
Yeah. So there will be shuffling of the options. So there is no point in seeing the person sitting beside you.
The options in the order may change for you and the other person sitting beside you. So don't get.
Yeah. Start, please.
Start.
So leaderboard you can see there that side. I'll be marking first thing for everything. Okay, then. So most common tumor to cause acromegaly. It was one of the slides, extract from the slides of Dr. Adotra. Today it was presented. Yeah, it's reading well. So it's a gross question for parathyroids.
So the normal weight of all 4 parathyroid glands together is usually less than.
But do they usually carry out all total parathyroidectomy with including all 4?
No, no.
Never.
Generally, no. It is only in hyperplasia that you get to have, but no.
Okay.
These are all autopsy studies.
So which hormone is rarely produced in adenomas?
This is also from the the second lecture today.
Yeah.
Second in the offline lecture.
So you can advance on your own levels. You can go ahead with your questions because I am taking full 30 seconds. So for you, it might be 10 seconds and you might have moved with the further questions. So the question is lengthy, but the end of the day, it's just what is the immediate post-op period? What is the investigation that you want to do in the immediate post-op period following a subtotal thyroidectomy? स्क्रॉल करना पड़ेगा ना लीडर बोर्ड वहां से दिखेगा वहां पे मैं स्क्रॉल का क्या था it is just
Filler.
yeah filler with the recent device of the cream. So this was in here. Yeah. नहीं मैं वो चला गया वो स्क्रॉल कर रहा है. Yeah. So you can see the leaderboard there. Picture is just a distraction or it can be a hint also. If you so the terminology hormone came into effect from 1902. So before that, there was no term being used for these micromolecules. So all these animals are used generally, but in this landmark study, which animal was used? So key is bilateral cortical hemorrhages. So what is the infection which most likely to cause this one? Again, this was covered. It is not that all first options are wrong. I'm just marking it, okay? So even the first option can be correct. Again, this question does not carry any marks. So there are two George Bushes, the father and the son, both were American presidents. In fact, during his presidency tenure, he developed atrial fibrillation. So at that time, Grace was diagnosed. इसके marks नहीं है तो आंसर दे दिया मैंने. हाँ. हाँ. I think few of you already have completed the session. Okay. So can you see yourself in the leaderboard? Okay. But आसान है. Okay. They are hard. टाइमर के साथ.
So how do you define the presence of differentiated high-grade thyroid carcinoma?
It's never that easy. So there was an extensive discussion yesterday, poorly differentiated thyroid carcinoma and anaplastic thyroid carcinoma. So this question is from that discussion. This is from the talk which was in the first session of today. Cribriform, no, yesterday probably.
First day, first, Dr. Donald.
Yes, okay.
This is something which has been, this has come in the new classification. And it is defined by some immunohistochemical marker. Now this is a new entity in the new classification.
So probably in your mobile phones, you may not be able to see this image properly. So I believe, but it is quite easy, a spotter for any histopathologist. Okay. I myself got few questions correct. Okay. This is a classic reaction. If you put potassium dichromate in a freshly crossed specimen. Some biochemistry question, as being I'm looking after clinical chemistry in the Department of Pathology. So I thought we'll include some question on congenital neuroblastoma and urine marker. Okay. Yes. So APMs does not show any diffuse this thing, positivity. So all 20 questions are done. I think highest score मैं वहाँ पे दिख रहा हूँ. मैं लॉग इन कर लेता हूँ. On leaderboard में I think is really you can identify yourself with the top 6 here, which is being shown in the that side projector. Online okay, yes. I cannot see actually वहाँ पे तो logged in है, वो log out करना होगा. वहां से एंड करना है. Any offline participated in the top 6?
You can read out the names. Dr. Harshita Lee, Shikha Singh, Asta, Monica, Yasmin, Niklesh. Raise your hands. Come.
Please come.
Tell your names and come on stage.
Introduce yourself.
We'll have to put 2 more chairs. But have a clear figure and her dress will be orange. Please come. Introduce yourself.
रिफ्रेश कर देना.
More participants.
So 2 more.
So please say your names. Sit down, please.
So please introduce yourselves. Harshita, I know. Other 2. Should be Kanaha.
I'm Dr. Harshita Bandwal, ex-senior resident from SGPGI.
Dr. Monica Shukla from RML Hospital. Good evening, everyone. This is Dr. Shipra, JR3, KGMU.
Okay.
Rest you have to identify.
Yeah, I'll just have to check in this one.
Niklesh.
So is Dr. Asta, Dr. Niklesh, and Dr. Monica, are they online in Zoom?
Just type yes.
If you're online, you can type yes in the Zoom chat window, so that I can share the second down link. वहाँ से वो लॉग आउट कर दीजिए. अब इसका जरा second one is only for 6 people. So I'll be sharing the second round this thing link in the website, also in the Zoom or you can enter the code manually by going to the join my quiz.com. So until you people don't join, I will not start. नहीं है. Yes. M. Bhargav.
Mithilesh Bhargav.
Yes, yes. Okay. So second round is only for the residents. If in the top 6, if someone is don't participate, I think Dr. Mithilesh Bhargava is at the level of faculty, I believe. Dr. Mithilesh Bhargava, can you introduce yourself? Not responsive. Not responding. Probably they are using mobile now. So I'll share the second round link. So I'll wait for online participants in the top 6. If they don't join, and then I'll begin this thing. So for the second round, you can enter this code directly in joinmyquiz.com. So बाकी सब तो I think even those who are not in top 6 also joining.
Monica has joined, Mithilesh has joined.
So Pratik is not.
और किसका आस्था?
Asta. Dr. Ashita, you have not joined yet. And no, Ashita, okay. Dr. Asta, if you're online, kindly join. So Ayuti, you have joined? यार ये मुझे Zoom में डाल नहीं था. Miss quarter.
Shipra has joined.
Or start.
नहीं वो रिमूव नहीं करना.
नहीं वो नहीं करता. नहीं लास्ट.
नहीं ये ऐसे
नहीं ये
सिक्स पार्टिसिपेंट को ले लो ना अपने उससे. एक और पार्टिसिपेंट.
इनकी नाम उन्होंने फोटो लिया था. Dr. Ghati, you have taken photograph of the top 6. Niharika. Okay. Niharika, if you are there, you can join. Yes. Okay. ऐसे join साइड कर लीजिए. Okay. So Mithilesh Bhargava has not identified. Dr. Mithilesh Bhargava has not identified whether she's a resident or. Okay.
One person is left. So from here, I think all of you have joined.
Yasmin. I think it's an international candidate or what?
Who's the next? We'll just check. Can you tell us the spelling of just say yes.
Spend this registration ID if you have number. Okay.
Yasmin. Why is it? Chat on. And post this.
Okay, you can continue. Dr. Bhargav. So I will begin the second round because short of time. Kuni will not about price fight. So I'm ending it. So Dr. Shipra Singh is the winner. followed by Dr. Ashita and Niharika. Niharika is on stage? No, okay.
Good. Good.
Okay.
So we'll be giving e-certificates. We'll note down your names and we will be giving the e-certificates. Be there for the validatory function. Thank you.
Thank you very much.
Thank you, sir. Thank you, ma'am. Moving on to the next session, we have the best paper presentation session. I request honorable judges, Dr. Varsha Bini ma'am, Dr. Francisco Couto sir, and Dr. Hani Malik ma'am on the dais. Okay. We'll be starting with the first presentation, Dr. Alka Singh from SGPJ.
Session 10 no?
Session 10. Second. Okay.
Good afternoon, everyone. I'm here to give an oral presentation on my case study entitled Sporadic and Inherited Medullary Thyroid Carcinomas, Significance of Serum Tumor Markers and Clinico-Pathological Correlations, a decade's experience from a tertiary care center. Medullary thyroid carcinoma is a relatively thyroid cancer and it accounts for 2% of all thyroid malignancies. They originate from high-follicular cells of thyroid and are capable of secreting markers, calcitonin and calcium embryonic antigen. Calcitonin is produced by C cells of thyroid and levels of carcinomas. CEL, however, is considered a tumor marker mainly for gastrointestinal malignancies. There are references in literature where elevated CEL levels the first factor MTC. This is perhaps related to origin of C cells from the endoderm of anterior gut. Also, the cases of MTCs, they can be either sporadic or hereditary. Sporadic cases are more common compared to hereditary in medical families. So, the purpose of my study was to determine the clinical significance of CEL levels and whether abnormal CEL and calcitonin levels may be used as a tumor marker to predict the severity of disease in MTC. Also, the second was to compare the clinical pathological characteristics of inherited sporadic medullary carcinoma cases. It was a tertiary center-based retrospective cohort study. The study duration was for 10 years from 2020 to 2022. All cases of MTC that were received included absence of surgical tissue specimen were excluded from the study, and all statistics were performed using SPSS 24 software. Coming on to the demographic, clinical, and pathological parameters, there were a total of 64 patients that we included in the study. The mean for these patients are 38.5 years. Females slightly showed a greater percentage for years. Out of these 64, cytology could reach the diagnosis in 58 cases, while in 6 cases, the diagnosis was either PC or FMS or colonoscopy. Which were further on histopathology. The cases were unilateral in 65.6% and bilateral in 34.4%. Most of these belong to inherited carcinomas. Lymph node metastasis was in 68%, distal metastasis in 14%, capsular lesion in 15%, lymphodistal lesion in 15%, and extrathyroidal extension in 12.5%. And also sporadic cases were noted in 30 cases, 16.9%, and inherited with 25 cases that proportionate to 31%. These are the gross effects from a case of a sporadic thyroid carcinoma, from a case of MEN2 showing bilateral carcinomas and bilateral chromocytoma in one patient. These are the effects from the patient, which are showing a dispersed population of plasmacytoid cells. The histological sections from a case of MTC and the showing chorophilic deposits. These are morphology. This case presented with advanced features like lymphovascular lesion, presence of capsular lesion, So we saw the pre and post of CA association with advanced features, and we found that elevated levels of pre and post of CA found to be significantly associated with metastasis, distant metastasis, advanced tumor stage, nodule diameter, capsular lesion, lymphovascular lesion, as well as extrathyroidal extension. Also, we saw the association of pre and post of calcitonin level with advanced NTC features. However, in case of calcitonin, metastasis was found to be clinically significant. Other features were not found to be significant. In the receiver operator curve, to predict the sensitivity of the CE levels in metastasis and metastasis, it was found to be range in the range of 70% and this value was clinically significant. When we go more specifically, similar values of 33.5 per was found to be significant for lymph node metastasis, distant metastasis, and advanced tumor stage with a sensitivity of 79% and 0.05. Also, we compared the sporadic cases, and we found that in comparison to sporadic cases, in the cases presented at a younger age, they had lower levels of pre and post of CA calcitonin levels, they had diabetes, and reduced incidence of distant metastasis. These are the same pictorial representation, box plot showing the comparison of parameters between sporadic and inherited MTC cases that I've already showed you in the table that we see. So concluding, elevated serum CA levels are associated with advanced disease in MTC and may be used as a predictor of tumor size, lymph node metastasis, distant metastasis, and advanced tumor stage. Also, inherited MTC is present with a more favorable prognostic features, including younger age of onset, lower increase of serum calcitonin and CA levels, smaller mean nodule diameter, and lower incidence of distant metastasis compared to sporadic cases. Thank you, and very thanks to my moderator, Dr. Pallavi ma'am, and my colleague, Dr. Shweta, who helped me in this study. Thank you so much. Yes, ma'am. Yes, ma'am. I showed the cutoff for lymph node metastasis and for distant metastasis. We have found a cutoff of 133.5 nanogram per ml, above which it is significant. There is a sensitivity of 79% that it can predict lymph node metastasis and distant metastasis in a case of MTC. The specificity is 75%. Yes, ma'am. 79. It's just border. It's for all MTC cases. Yes, ma'am. Sorry, ma'am, I didn't get.
So, for inherited and sporadic cases, were the cases stage matched? Because it's likely that the inherited cases may have a lower levels, may have a lower pre-op levels because we detected them early.
No, we didn't do the stage matching, but yeah, it may be because they have some family history or some indications. So that's why they detected early and body parameters, body parameters and values. Yeah, this is a possibility, but we have not a stage matched.
Another thing, last one. So in inherited MTCs, we know some of them like M9180 is associated with aggressive behavior. But in your conclusion, it was written that inherited had a lower metastatic rate.
So was it correlated mutation? Because that will definitely have an impact on the outcome
No, it
and the conclusion.
It correlated with mutation.
Any other questions or comments?
Thanks.
Yeah, thank you, Dr.
I invite the next paper presentation by Dr. Nilima Gupta.
Good afternoon to everyone. I'm presenting the 12 cases of rare pineal parenchymal tumor of intermediate differentiation. The pineal region tumors are uncommon and accounts less than 1% of all the intracranial tumors and 10% of pineal region in the sorry. The pineal parenchymal tumors are subdivided into the pineocytoma, pineoblastoma, and pineal parenchymal tumor of intermediate differentiation. The PPTID is a pineal giant neoplasm that introduced as a distinct entity by the WHO. Lying between these tumors, lying between the pineoblastoma and pineocytoma, and graded as grade 2 or grade 3 tumors. Because of limited number of reported cases, the PPTID is still matter of controversy for the classification. The recent WHO has not set any cutoff value for the PPTID to grade as grade 2 or grade 3. However, George et al. Graded these tumors in grade 2 or grade 3 according to the NFP, immunostaining, and mitotic activity. The methods and materials of our study, I have searched the data from the 2010 to 2020, and only 12 cases have been reported as a PPTID in our study. This is the grading system which we applied according to George et al. The grade 1, grade 2, and grade 3, and grade 4. We include only the PPTID tumors which graded as grade 2 or grade 3 according to the mitosis and NFP expression. The median age of the patient and the initial diagnosis was around 35 years in this study. However, the range from the 6 to 61 years, and the male to female ratio was 1.4:1. The most of the patient presented with a headache and dizziness and vomiting, and the most common location was a posterior third ventricle in 9 out of 12 cases. This is a tabular form of this is a table that predict that showing the age and chief complaint, size, and mitosis, pattern, hyperfield, and grade of the tumor, and I see findings and radiological findings of all the 12 cases. The operative finding in most of the cases showed a pinkish soft flashy mark, which was highly vascular and settable in nature. The mean size around 3 by 3 centimeter. Out of 12, I'm presenting few cases related this study. This is first case. This 13-year-old female who presented as a holocranial headache and progressive vision loss and ataxia and urinary incontinence. The MRI finding showing 5 by 3 centimeter lesions in posterior third ventricle. The intraoperative findings showing a soft lobulated and mildly vascular tumor. This photomicrograph showing this is low power where we can appreciate the tumor is moderately cellular, and further high power where we can appreciate the tumor cells are showing mild pleomorphism around the oval nucleus and moderate amount of the cytoplasm. This is the further high power where we can appreciate some vague rosette formation also, and another area showing the calcification. And immunohistochemistry showing synaptophysin, diffuse granular cytoplasmic positivity, and FP also showing diffuse positivity, and the Ki67 proliferation index around 60%. This is the second case. This was diagnosed as PPTID grade 3. This is second case of the series. This is 30-year-old male presented with a headache, vomiting, and blurring of vision since 14 days. The MRI finding shows the posterior third ventricle mass. And intraoperative finding showing pinkish whitish soft flashy vascular tumor. This is photomicrograph of intraoperative square smear. This is the square smear cytology. Here we can appreciate these tumors are moderate to highly cellular. This is further hyperview. This the cells are showing moderate pleomorphism and inconspicuous nucleoli and the moderate amount of the cytoplasm. This is a histological picture. Here we can appreciate this is a mild to moderate pleomorphism in the tumor cells, showing inconspicuous nucleoli and moderate amount of granular eosinophilic cytoplasm. The immunohistochemistry is showing synaptophysin, diffuse positivity. NFP also showing diffuse positivity, and Ki67 around 5 to 6%. And this was a PPTID grade 2 tumor. On coming on the results of this case series on immunohistochemistry, PPTID showed diffuse positivity for the synaptophysin, and some cases showing diffuse positivity for the NSC and NFP. This table showing the treatment and follow-up of the cases. Now, coming on the discussion part of the this series, the pineal parenchymal tumor, which cannot be classified into the pineocytoma or pineoblastoma, may exhibit the features of intermediate grade, which is a distinct entity. These PPTID include in 2020 classification, WHO classification as a PPTID as a distinct entity. In fourth edition WHO classification and 2016, or in 2020 updates not decided any definite criteria for the grading of these PPTID tumor because of paucity of the literature. PPTID is more aggressive than the pineocytoma, but the less aggressive than the pineoblastoma. So this tumor has the overall survival between high survival between the pineoblastoma and the low. And the microscopic findings and IHC grading as the role in the clinical cause and the patient survival and outcomes. However, the histological grading is still matter of controversy because of the paucity of the data. Low-grade PPTID is the survival 5-year survival 74%. However, the high-grade PPTID, grade 3 PPTID, Up to 5-year survival around 39%. Now I am concluding this the PPT-ID tumor. In view of paucity of the literature, it is a heterogeneous spectrum and no precise grading system and optimal treatment option which are challenging. And because of rarity of these PPT-ID, parenchymal tumor that emphasize the importance to distinguish these neoplasms from the other neuronal tumors that may be impinging upon the pineal region, including central neurocytoma, ependymoma, or oligodendroglioma. Or this series, this series, that contribute to scarce data available regarding the prognosis, clinical courses, and treatment of the PPT-ID. Because of limited data available on the pathological features and biological behavior, the relevance of grading criteria, including mitotic activity, NFP expression, and Ki67 MIB is requires for the confirmation. These are our references.
Yeah. Thank you, Dr. Nilima. You have overshot your time. So if there are any quick questions, just wanted to, any question will come in. If not, thank you very much.
Now I welcome Dr. Pranita to the stage for her presentation.
Good afternoon, everyone. My name is Pranita, and I'll be discussing comparison of PDL1 expression by tumor proportion score and combined proportion score in thyroid carcinomas. So, immunotherapy is a novel tool in the armamentarium against refractory malignancies. Main focus currently being on targeting the PD1, PDL1 axis. Various scoring systems have been used for PDL1 evaluation in different cancers, such as the validated tumor proportion score using SP263 clone for the companion drug pembrolizumab. Similarly, in urothelial cancer, CPS is being used with 22C3 clone for pembrolizumab drug. Application of immunotherapy in thyroid cancer management is currently under investigation. To date, no single scoring system has been recommended for PDL1 assessment in thyroid oncology. Hence, we aim to compare the two immunohistochemical scoring systems, TPS and CPS, for determining the status of PDL1 expression in thyroid carcinomas. The current study is a retrospective study from 2015 to 2020. Total of 65 thyroid carcinomas were included, of which 10 were classical PTC, 10 were tall cell PTC, 10 were hobnail PTC. Follicular and poorly differentiated thyroid cancers were also 10 in number. Anaplastic thyroid cancers were 15 in number. Control were tonsil and follicular nodular disease. Assessing. Tumor immune cell assessment, immune cells present within tumor and within one high power field of tumor border were assessed using SP263 immunohistochemistry on Ventana platform. Scoring system, TPS was done using positive tumor cells to the total number of tumor cells. CPS was done as positive tumor and immune cells to total number of tumor cells. At least 500 cells were assessed. A cutoff of more than 1% was considered positive. Tumor cells which were showing only membranous staining was taken into consideration, and in immune cells both membranous and cytoplasmic staining was considered, and they were divided into 4 groups depending on the percentage. Statistical analysis was done by using Spearman correlation coefficient to compare TPS with CPS. Patient demographics, age range was between 15 to 72 years with a mean age of 44 years, and the predominant patient population was female. So of the total 65 cases, 27 cases showed tumor infiltrating immunocells as depicted here, a case of FTC showing macrophages and lymphocytes in a case of PTC. Tonsil was used as both positive and negative control with crypt epithelium showing strong positive staining The other pictures are showing patchy positivity in adenomatous goiter, classical PTC, and tall cell PTC respectively. Similarly, patchy positivity, membranous in hormonal PTC, follicular thyroid, poorly differentiated thyroid carcinoma, and a diffuse positivity was seen in anaplastic thyroid carcinoma. So TPS and CPS were compared in papillary thyroid carcinoma and anaplastic thyroid carcinoma. In both the cases, TPS was comparable to CPS, and we have taken the whole cohort and cases with which were showing tumor infiltrating immune cells. So when we have done a Spearman correlation coefficient, R was 0.9 in both the cases, with p-value less than 0.001, showing high significance and comparability between TPS and CPS in both the instances. And when TPS was less than 1%, and at TPS less than 1%, CPS was also less than 1% in most cases, except for 6 cases in which it has gone to either less than 5% or 5 to 50%. When TPS was 1 to 5%, 2 cases have showed a CPS of 5 to 50%. But when was TPS 5 to 50% or more than 50%, there was no change in CPS. It remained either 5 to 50% or more than 50%. Here I am depicting the change in the TPS and CPS scores. The first case, TPS was 4%, but when we did CPS, it was 7%. Similarly, second is a follicular thyroid cancer case. Here the TPS was less than 1%, but when we performed TPS, it was 32%. The third case is anaplastic thyroid carcinoma, which showed a TPS of more than 90%, and occasional lymphocyte was positive. And it was also more than 90%. Similar studies have been carried out in other cancers, but not in thyroid carcinoma. In lung, TPS and CPS was comparable. And in head neck squamous cell carcinoma, CPS at a higher cutoff of 50% was comparable, but at lower cutoff, CPS was more sensitive. In the current study, it's a first study to assess comparability of TPS and CPS immunoscoring systems for PD-L1 and thyroid carcinoma. 8 of the 32 cases with TPS less than 5% were upscored on CPS. Of these, 6 of these had TPS less than 1%, which means they were negative. But on CPS, they have become either they have become more than or equal to 1%, which means they have become positive. Especially this is of importance because it included an ATC case which had a TPS 0, but on CPS it has become 6%. This is I would like to emphasize this because we use these cutoffs for therapy to give anti-PD-1 or PD-L1 therapy. Hence, TPS and CPS were comparable irrespective of TPS, but the scores groups remain unchanged for all cases with a TPS of more than 5%. I would like to conclude by saying TPS and CPS are comparable in thyroid cancer, especially in cases with TPS more than equal to 5%. The results indicate that the two scoring systems can be used interchangeably. However, clinical trials are needed to establish cutoffs for responsiveness to immunotherapy. Thank you.
Thank you, Dr. Pranita. And the paper is open for questions and discussion.
So my question is related to your inclusion criteria. You took samples from 2015 to 20 and you included 65 tumors. So what were your inclusion criteria? How did you select your cases?
Ma'am, we have taken dissection specimens from, so ma'am, it's part of my thesis. We have a fixed number of cases and equal to 10 in each category. And we have included all ATC cases because they were rare. Whatever ATC cases we could find in the given time period, we have taken. Resection specimens were taken, and in which
So my basic question is, how did you select your 30 PTC cases from a 5-year data? Were they consecutive?
Yes, yes, ma'am.
So then you will have included only in 15 and 16, because as far as I understand, in All India Institute, you must be having a large number of thyroid tumors which must be operated.
Yes,
So
yes.
how did you select? That is the basic question, 65 patients.
PTC we have taken consecutively starting with the current year of 2019. It was the year in which I have started my study, ma'am. And hobnail and tonsil PTC, they were rare and the number of cases were less, ma'am. So we had to go back till 2015 to get a number of 10 cases.
Okay, so that I think that is that makes the data a little skewed, because you need to have consecutive. Even if you're seeing typing,
Yes,
you need
yes,
you have to start either from 2020 to 15 backwards, or you start from 15 to 20. But then you should know what were where did you stop consecutively. You cannot select up cases and take up. That is the only point. Random selection is difficult in such type of studies.
No, ma'am, we took consecutive only, but we had to go till 2015 only because of the rarity of hobnail, tonsil, and ATC.
The other question was related to, because in PTC we generally have a mixture of typing. So you have areas where you can, even in tonsil variants, you may have areas of the classical papillary type, and you also have areas where you have the tonsil variant. So were there any differences in this staining in these two type of areas? What was your observation?
Ma'am, in papillary thyroid carcinoma, it was always patchy. Even if it was tonsil morphology or classical morphology, even in the same case also, it was always patchy.
So for example, you have a tumor which has tonsil and which has classical areas. So did you find staining for PDL1 in both of these areas, or selectively only in tonsil areas, not in the classical? That will be of importance, because tonsil, as which we know that it is prognostically associated with the poorer.
Yes, ma'am. If it was if it had both tonsil and classical morphology, we found staining both in classical PTC and tonsil PTC.
I think that that is an important point to make, and whether it was significant. And in ATC, we chose only resection specimens, as she emphasized. That was because PDL1 can be patchy from previous studies, other tumors, and so we didn't want to take true cut. We wanted only resections.
So when I was assessing to select the cases, I have found immune cells in other morphology also. So I wanted to see if they were also showing any PDL1 staining. So that is why we have included all morphologies and not limited to anaplastic only. So we can see a case of FTC like I have shown. So case 2, sir, it was TPS less than 1%, but CPS was 32%, sir. So it went from positive to negative, sir. Negative to positive. Thank you.
Okay, thank you, Dr. Pranita. So we thank all the three presenters, Dr. Alka, Dr. Nilima, and Dr. Pranita, for presenting the nice papers. And on behalf of Dr. Rini Malik and myself, I thank the organizers for asking us to judge this session. Thank you.
Thank you, sir. Thank you, ma'am. Moving on to the prize distribution ceremony, I would like to invite Dr. Seema Sharma, ma'am, to the dais.
So we come to the end of the scientific sessions. Thank you all for attending to the class. We request the executive members of the RPID to kindly come on stage, and Dr. Manoj Jain, who is the organizing chairperson. Till then, we're making the certificates and we start the prize distribution.
So we'll be starting with the we'll start with the case report presentation winners. The award.
So for the case reports, we have given first and fourth second prizes because there was a tie in 4 papers. So we don't have the third prize. We have the first and fourth second prizes for the case reports. And because we have 3 certificates for second and third, what we do is for first we are giving the certificate, 2 seconds we are giving, but for the 2 seconds we do an e-certificate. So now I'll request Dr. Rishabh to announce. Thank you, sir.
The case report presentation, the first prize goes to Dr. Neha Gupta for the paper titled When the Butterfly Gland Grew Earrings. I request Dr. Seema Sharma ma'am to give the. The second prize goes to Dr. Hansha Singh for the paper titled Malignant Gastrointestinal Neuroabdominal Tumor of Ileum. Dr. Hansha Singh. Second prize goes to Dr. Madhuri Shukla for the paper titled Epithelial Meningioendothelioma of Nasal Cavity in Young Female and Unusual Occurrence. Dr. Grishma Depina for the paper titled Ectopic Acetous Production, Thiamine Urandine Endocrine Tumor, a case report.
Do we have anybody from the institution? From Dr.
Grishma Depina. Dr. Saurabh Singh for paper titled Sarcoidosis presenting with thyromegaly. Dr. Saurabh Singh. We don't. Moving on to the winners of quiz prize, Dr. Shipra Singh from KGMC, first prize in the quiz. I request Dr. Anita Bhadri now for prizes.
We are presently giving a plan, a symbol of life, and we will send the e-certificates to the winners.
Dr. Dr. Harshita Kanwar. Second prize in case. The third prize went to Dr. Niharika, but she has joined online, so e-certificate will be provided. Dr. Saurabh Singh, second prize in case report presentations, titled Psychologists Presenting in Theoretical. I request Dr.
Came late, so to announce, we will give the e-certificate.
Okay, sir.
And we will give you a plan at this point. Dr. Anita Bhargava.
I request Dr. Amy Malik Ma'am for the next prizes. Prize for best oral presentation. First prize goes to Dr. Anita Singh, SGPGI, sporadic and inherited medullary thyroid carcinoma. Second prize goes to Dr. Pranita Gadan from AIMS New Delhi for PD-L1 expression of tumor proportion score and combined proportional score are comparable in thyroid carcinoma. Third prize goes to Dr. Nilima Gupta, SGPGI, for a clinical pathological study of female tumor and tumor intermediate differentiation in North India, a single institutional study. Thank you, ma'am. I will now request the honorable members for a few words of encouragement.
Me? You ask Dr. Manoj.
Dr. Manoj, sir, I request for a few words of encouragement. Thanks. So, आपको दे दे पहले आपको बोलो आपको बोलो अरे आपको
Thank you all for staying back. At the end of 2 days, I'm sure you will agree that it has been really a very spectacular meeting and we all learned so much. At least I did, so I'm very sure you all did too. I'm very happy with the way the whole meeting was conducted. And in spite of a few hitches and glitches in the beginning, the whole proceedings went on very smoothly. And we got a lot to learn from all of it, including time management and management of crisis, where you need to actually stand up to it. I thank all the participants for their extraordinary contribution and all the faculty for expert experience that they have shared with us. And I especially thank Dr. Seema Sharma, Dr. Jain, Dr. Vinita, and the rest of the pathology team that has organized this excellent meeting under the umbrella of the IAPID. It's been a very commendable effort. Thank you all so much.
Say something.
Very good evening, and at the same time, now a good time. नेतृत्व पूर्वक कानून के अभी और बिठा के रखना है सारे दिन के बाद. So on behalf of IBID, heartfelt thanks to all the speakers, to all the participants, and above all, the entire organizing team of SGPGI. And a special word of gratitude to Dr. Manoj Jain and Dr. Vinita Agarwal, who so meticulously planned the entire event, so nicely and smoothly handled the crisis that we all faced early in the morning yesterday. But the team was very efficient. They were very efficient that they gave very good instructions that everything went on so well. The presentations were excellent. We all learned a lot. Thank you. Thanks once again.
And just to reiterate what Dr. Anita Barbari and Dr. Rini Malik has said, this was an excellent CME, extremely well organized by the team from SGPGI. I congratulate Dr. Manoj Jain, Dr. Vinita, Dr. Seema Sharma, Dr. Krishnani, and the whole team for arranging this so well. And the quality of the scientific sessions was very high with well selected speakers. And we are not only national but as well as international speakers of high quality. And it's heartening to see that there was quite a good participation, physical as well as online participation. And after COVID, the numbers have been very less in most meetings, but there's been a significant number of attendees physically here. And thank you for your participation as well. And once again, happiest congratulations and thanks to all the team from SGPGI, Dr. Manoj Jain, Dr. Vinita, and all the rest for this very complicated ceremony. Thank you very much. So, first of all, I thank IAPD Executive IAPID giving us opportunity to conduct CME in SGPGI. Since last year, this CME was done in RML, so it was very remote possibility that again we will get in Lucknow city. But since a topic we chose like that, it should sell, and topic sold, and we got this CME because of our infrastructure and our goodwill. So I'm extremely grateful for IP Executive for giving us this opportunity, and we tried our best to conduct this CME. And I thank all my entire team because they have done tremendous work. My residents, my whole staff, telemedicine center, everyone. So you see that they all are involved and they are doing very good job to conduct this CME. And especially I thank Dr. Amitabh Srivastava because I've been continuous for the last 6 months to Dr. Amitabh Srivastava. So, because there was a lot of timing issue, day and night timing. So we were thinking how we can connect with those original authors which you are seeing in 2022 WHO books. Bernard Bashir, Peter Shadow, they are original authors. They have contributed. So we wanted to do him to speak here, but there was issue of the timing. So we decided that to meet the expert session at least yesterday that we conducted. So we got all the recorded talks here. We planned such a way that we can get, but Amitabh had very much, and still even yesterday he had some fever also, and he gave me talk on the night 12. That morning you played, I will be unable to join physically, personally in the morning. So everyone has worked very well in this, I think, and hold the department support, institute supports. So I think everyone has contributed in this too. So, and I thank all the delegates because they all attended well. Scientific papers were also very good. And we had around 120 offline registration and 120 online. So around 220 registrations we had. Even 3-4 online registrations are from abroad. So that was commendable. So I think that, so thanks.
So first of all, thank you to the delegates and our faculty who attended. We had a talk to them yesterday, and the best thing part was it that everybody was they had they tried to do, so everyone said yes, we are allowed. So that was very happening for us because in the morning it was really because we came here at 7:30 and we saw water everywhere. So everyone supported so much, not only our residents, our staff in pathology, but also the delegates who had come from outside, and that was commendable. And that gave us that courage that yes, we can go along. So thank you so much. And we saw a very good participation throughout the CMU, and it was really interactive, very nice, and we hope you take away some good memories from there. So thank you so much. Thank you everybody in the department, in the institute, residents who have worked so hard. Thank you so much. And there was a very nice participation in the scientific sessions and also in the posters. And thank you so much. Thank you to the executive also who have been this yesterday and today, and it has been a good support for us in conducting the CME. Thank you so much.
Yesterday, we launched the e-souvenir of this CME, and that is around 810 MB file, PDF file. So that will be shared on the website as well as on online, offline participants who are there. So we'll be sharing with them this. So all abstracts are there. So every content is there. Yeah.
Anybody?
Any
participant or participants would like to comment, can raise their hands and say something. It is an informal discussion. Any online participant can raise their hands. You've seen the chat. Yeah, so thank you. We have to Niharika, thank you. So people are putting the comments. Thank you so much. A nice academic. So anybody would like to speak? Raise your hands. We have any participants do we have presently?
26.
26. So anybody from the participants? Okay. So we can end.
Yeah, in the end, I would like to say thank you to all the three people from IUPID, Madam Madhuri, Dr. Rini Malik, Dr. Kuto, and I would like to thank Dr. Manoj Jain, Dr. Vinita, all my residents, all the faculty members, all my staff for making this successful. Thank you.
Congratulations. Thank you, ma'am. Thank you so much for having the question answered.
Thank you, delegates and dignitaries. With this, we conclude this CME.